And welcome everybody. Nice to see all these smiling faces, and welcome to everybody in the Zoom room. Let's see if this is going to work. Just adjust my screen here since we moved it around. I think we've got a good crowd on Zoom. We have about 200 folks registered, so that's fantastic. We have about 120 of you registered in person, so it's wonderful. First of all, I do want to thank the Center for Global Health for being the on-ground Hopkins fixer, as I like to say. Megan has been tremendous as far as organizing the things that are very difficult to do from the West Coast, 3 hours behind, and then Canada as well. So that makes it always a challenge. It's tariffs now. And also I do want to, our kind of co-sponsoring organization is Solidarity Dental Foundation, which I'm a part of. It's a nonprofit 501(c) charitable organization based in the United States, and they started off in Ecuador and have expanded off into amazing parts of the world, in Tanzania and Ghana and Kenya and maybe Malawi? No, maybe not. But they do have their first dental school, so this is a project that we're interested in participating in. And just recently with India and the Indian Dental Association. So it's some very exciting things going on. So rules of engagement. We want to be obviously respectful. You guys all know this. I don't have to tell you about your cell phones and whatnot. We do want to encourage conversation and dialogue. We will go over a couple of things. We're using some new digital tools that we'd like you to participate and comment. If there are photos, hopefully not too embarrassing ones, we'd encourage you to put that on there on this digital bulletin board. We're all here to learn. So again, just being patient with one another. We have different levels of background. So absolutely just want to be patient in this very interesting 2025 year. Again, these are our major sponsors. Wow, those logos came up really big on a big screen. So with the Center for Global Health and Solidarity, very thankful to CareQuest Institute for Oral Health for their the grant that they have honored, and Vifor Pharmaceuticals. And also a massive shout out to the Johns Hopkins Oral Health Society. This is a new student group that has been recently active or reactivated under a new name and under new leadership, and you will hear from their president later on today. So we're excited about that. If you are going to be posting, we'd again engage you with using the Hopkins GOH, which is Global Oral Health 2025 hashtag. And so let's see it here. So this program, it's first started off in 2023 with the inaugural Global Oral Health Symposium. It featured 8 fantastic speakers, and we have a couple of them here. Maybe one. There are 2 are coming, and one's going to make a surprise entrance. Okay. Well, so we originally had Dr. Brittany Seymour, Dr. Eleanor Fleming, who will be here momentarily. We have Dr. Priyanka Goodsarkar, who's returning this year. Professor Frick from the Carey Business School is returning as well. And yeah, surprise guest message. Okay, very good. And we've had some few tweaks and adjustments and such. And last year, from going to a sort of in-person event in 2023, last year we had a webinar in conjunction with the Johns Hopkins Hospital. This was a theme on oral health and hospital-acquired pneumonia. and completely webinar based. The hospital took the initiative to have in-person education awareness for patients on the ward, for their staff, and it really quite intriguing because this was a hospital-driven event, and part of it was some inspiration from attending the original 2023 event. And so we're really excited that to have the hospital participate with us again. We have some representation from the Department of Nephrology that will be coming on later on today. And we also have representation from the Department of Otolaryngology, who will be moderating the session. Yeah, we're gonna have to get tech involved because there's a couple of little scan codes that we want you to use. So we're going to use a platform called Padlet that, yeah, so yeah.
So you're having a tough time getting through.
So Padlet is this software that you will be able to see the digital agenda, and you'll be able to scroll one way to see all the speakers, and under each speaker, there will be a number of references, articles, things of interest, things that I found interesting, and things that the speakers found interesting. And if you go to the left of that kind of speaker library, and it's the graphic is a ChatGPT generated image of a reproduction of the Trinity Library in Dublin, Ireland. And it's just this beautiful, and what's different about it is this has skylights, and the original library does not have skylights. So the first slide that you'll see to the left, that will have the agenda. And so you can click on that and you'll be able to see a digital kind of program. And just then to the next to that agenda, there will be a bulletin board, and it looks like a cork board. And that's the area where you are more than welcome and encouraged to post anything to your heart's desire, whether it's an article or you've taken a photo at lunch or the masala chai tea bags in the coffee room, whatever it is. So hopefully there's some combination of fun and interesting things, but also some articles, references, ideas, recommendations for the future. Thank you all, very much appreciated for the inspiration and igniting us all. And yes, thank you for being here. Again, this is a Baltimore perspective. Even our panelists were wondering, well, this is global. Why are we here? But if you think about how all international projects start, they all start and need local communities. And the fact that we are here in Baltimore, and we have resources from the first ever dental school in the country, it seemed appropriate to get people from the Baltimore, Bethesda, DC corridor. So thank you. So I can tell you a couple of things about how we're going to set this up. First off, we're going to do a fireside chat, which is, I guess it's something that I'm fascinated with, fireside chats, because I grew up, and I get it, everybody doesn't like camping and that sort of thing. But for me, sitting around the fire was one of the most kind of fun, intriguing, inspiring events. You know, if you had a long hike, you went for a swim, everyone's cooking together, you're cleaning up, and at the end of the day, your feet are just dog tired, and everybody is sitting around this fire and enjoying whatever it might be. It might be a ghost story, it might be something inspiring. You might be singing songs. And it really was some of the most fun and interesting things. That looks good.
Yeah, I just need to share the screen to see what we. Oh, there we go.
So that was one of the most fun and interesting things at the end of the day. And so in organizing this 2-day symposium, the thought is, I gotta be honest with you, I've been to a lot of conferences and some of them are pretty boring. So how do you recreate that energy from the end of the day when you're just so tired and you're enjoying, maybe it's a frothy, non-public healthy beverage, maybe it's s'mores, but you're intrigued, you're engaged, but it's the end of the day. So how do we do that at the beginning of the day? And so I wanted to flip that on its head and start off with a fireside chat. So we'll come back to that. But this is the very large barcode of the Padlet. And so you can see this reproduction of Trinity Library, courtesy of ChatGPT, with the skylights. So our job really is over this next 2 days to challenge you to really bring to the forefront. Again, at the School of Public Health, we have every possible public health entity and body part, except for one. And you can guess what that is. It's the mouth, the oral cavity. And I think a lot of the public health faculty here, as soon as they hear dental, it's very much like maybe for those of you who are clinicians in the oral health sphere, you've heard those comments at cocktail parties that, oh, no, you seem nice, but I hate the dentist. And that's kind of the interaction that I had with some of the faculty here as well, in that we don't really have anyone who's on the dental side. One individual has a BDS, a Bachelor of Dental Surgery, and they introduced me as a recovering dentist. And I thought, well, that's quite interesting. So they've gone on into epi and have transformed and pivoted their career. But we have this very much a silo, and I think most of you in the room probably can appreciate that. But within the silo of dentistry, we have further silos. And what I mean by that, for example, in 2020, March 2020, does everyone remember what you were doing in March 2020, especially at the end of March? Maybe some of you who are academics, you're flipping your classroom. If you're in private practice, you're freaking out how you're going to pay your staff and how you're going to put food on the table. Lots of webinars in CE about how to handle this new kind of, phenomenon. But end of March 2020, there were 2 new dental specialties that were recognized. And those are oral medicine and oral-facial pain. And that's essentially my background. So I was quite excited. I read about the announcement, but I'm sure most of you didn't know and probably didn't pay attention to it. Much of the literature writes about the public health importance of whether it's oral mucosal diseases and mucositis associated with cancer chemotherapeutics, or misdiagnosed trigeminal neuralgia, certainly temporomandibular joint disorders, which fall under both the purview of oral medicine and orofacial pain. Yet public health hasn't really embraced those fields. So that's what I mean by this silo within a silo. And there's so many of those aspects that we're going to cover throughout these 2 days. So that's, if you scan that previous code, you will come to this library. And this is basically what it looks like and what I was alluding to. As you scroll to the right, you'll go through the speakers in alphabetical order by last name. So if you recognize a speaker, their name, their picture, their mugshot, you'll find them. And then if you scroll downward, for example, with Dr. Olayinka, you can see some of her work. And you can click on it and go to those articles. But you can see to the left, we have the agenda, and just next to that is the bulletin board. So we're really trying to engage you in a slightly different way. And so this is the bulletin board, so feel free to log into that. There's this little plus button at the bottom right, and you can add various kinds of things. We want to keep it professional, obviously, but we'll have to see if this needs to be moderated, but I trust you. And here's the agenda. So again, this is organized in that you can click on that very first one that says the agenda, and you can get a digital kind of readout, or you can scroll down and you can see there's an image to the right of day 1 at 9 o'clock. And this is our quote fireside chat to try to inspire you with my s'mores or what have you. And that's a scan code there for the agenda. So you should be able to get to all of these 3 Padlets with one. And same thing there. that's the scan code for the bulletin board. How are we doing on time? We're just about there. I wanted to, have a few surprises planned for the today, and I'd like to introduce you to Peter Mossy.
Hello, my name is Peter Mossy. I'm the Professor of
hear it.
Craniofacial Development at Dundee University Dental School. And I'm very honoured to be asked to participate in this Global Oral Health Symposium. I think it's a wonderful, refreshing, interdisciplinary approach that Johns Hopkins are. Hello, my name is Peter Mossy. I'm the Professor of Craniofacial Development at Dundee University Dental School. And I'm very honoured to be asked to participate in this Global Oral Health Symposium. I think it's a wonderful, refreshing, interdisciplinary approach that Johns Hopkins are renowned for. Now, in terms of oral health, we know the problems with oral diseases in terms of the high prevalence and the lack of improvement over the last 30 years. And I'm just going to focus on a few solutions rather than elaborating the problems. Number one is prevention. So what do we do and what do we teach in dentistry in all the curricula around the world? We teach intervention. We let disease happen and then we treat it. So this is a futile and an unsustainable approach. We understand the causes of dental diseases. We know how to prevent, but we don't do it. Secondly, integration. We remain firmly stuck on our own dental silo, despite the fact that we know the influence and the value of oral health in overall health and well-being. We must embrace integration with other disciplines, particularly medicine, for the sake of overall health. Third is access to care. Dentistry is characterized by unique access to the healthy population. Patients attend regularly, or should, for dental visits. And why do we not take action to make sure that we integrate oral health with general health on these visits? The fourth thing is embracing social society. Despite unique access, we don't communicate with the global population. We don't harness the power of the public voice or ensure the general population are our advocates. And we can't change political will unless we change social will. And that was beautifully demonstrated by Mary Otto in the Diamante driver case. And finally, addressing inequalities agenda. We remain very significantly affected around the world by oral health inequalities. This is one of the greatest problems known to mankind, and we're not addressing it. We need proportionate universalism, and that is the only approach that will eventually deliver universal health coverage. Thank you.
Thank you, Dr. Mossy, for sending that in. As a prequel to today, or to these 2 days, we approached two of our original speakers. Our keynote address from 2 years ago was Dr. Brittany Seymour and Dr. Hyewan Lee, who's an alumnus of Johns Hopkins University. She did her master's of public health and her doctorate in public health here. Both of them were key speakers at that initial event, and we had a very nice, again, kind of a repeat in the theme, a fireside chat at 5 a.m. Pacific Coast time. And for those of you who know me, I don't really do well at 5 a.m. But we had a fairly good turnout with a short marketing time, and a fantastic conversation with both Brittany and Hyewan. Really very inspiring people. in that realm. So the goal of the symposium is to encourage collaborations across disciplines, not just within the silos that we tend to hang out in. Very difficult and challenging to do even within the public health school. But so we're going to attempt it. Encourage including oral health at the School of Public Health, and this need to provide so my dream is 4 courses of oral public health here at the school. And so this is where your help comes in. You may have noticed there were no registration costs associated with this. So the ask is that if you are convinced from today and tomorrow, if you have the leadership's ear at the university, I would ask and encourage you to call them, text them, cajole them, and convince them that we need to incorporate some of the themes that we will be discussing here today and tomorrow in a formalized form in education. Basically, the first course would be an overview for anyone, whether you're a physician, a nurse, OT, speech language, pathology, nutritionist. There is something very much relevant in oral health for all of those fields and more. A second, I don't know if I want to call it a higher level course, but it's more specific for the oral health clinician. So whether you're a dental therapist, a hygienist, a dentist, what have you, you're pursuing a master's of science or master's of public health or a doctorate in public health, like we have, where's Katie Patani? I just saw her, she's right over there. So if you're pursuing doctoral degrees, whatever, it doesn't matter. You need some form of sponsorship, mentorship at this institution. We have several individuals in the dental field pursuing degrees, but there's a need for not just education, but the lifting up and the career counseling. We have, because of our silo and our historic separation, which has a Baltimore origin story in 1840, the first dental school right here in Baltimore, but we don't have adequate career planning within the institution for us that are on the dental side. And ultimately, we need a center for oral health that is independent of a dental school. And again, we will go into some of these themes and some of the rationale, but trust me when I say, I'm not convinced that many of the dental schools have the bandwidth in the 4-year curriculum. I'm told the 4-year curriculum is full. We can't afford to add anything more. Yet we have conjured up 2 days worth of stuff. And there's actually the original plan from 2023 was a 3-day conference. And the Vice Dean, Josh Sharfstein, sat me down and said, are you nuts? You can't, like, have you ever done this? Have you ever organized a conference? No. You want to do 3 days? Can I check your temperature? He's a very kind, gentle man. He's a pediatrician. So the way he speaks is not how I'm conveying it, but he was very kind about it, but he convinced me to bring it down a notch. The first comment was, why don't you just do a noon-hour webinar? And I said, I already have a day and a half worth of speakers lined up. So he kind of looked at me with that pediatrician kind of look, and he said, let's hop on another Zoom. And this was on a Tuesday, and he hopped back on a Thursday, and we lined up the seminars. So this is the fireside chat kind of idea, which I think I went over, so I won't bore you with the details. But this idea to start and flip the day, start with inspiration, but we won't have s'mores because it is oral health. I do want to have a quick introduction for our moderator, Dr. I asked everyone to send in bios, and you are a fantastic writer, but I can't read this. It's too modest. So bear with me as I attempt to embarrass you a little bit. So this is an individual that I first came across in dental school, and just an incredibly inspiring individual. I think at that time, you may have been announced as the deputy director of the NIDCR. And I think that's when I first heard, and I believe you were the first female, if I'm allowed to say that word. It might be banned, but first female. And so that was the first time I heard that, having a very strong mother. I think I was very intrigued that this is the first woman in this position. It seemed to keep repeating that there was first time that Dr. Kleiman was this, and then and forgive me if I get the names wrong, because I'm not in the military. So first chief dental officer, and then the list keeps going on. Finally retiring through the U.S. Public Health Service as at the level of Rear Admiral General. And I believe the first female at that level as well. So yeah, I wasn't sure when I'd ever get a chance to introduce Dr. Kleiman. So I wanted to take that opportunity. For those of you who don't know, because we do have some young whippersnappers in the room who might not be familiar with your work, you know, including myself. But so Dr. Kleiman started off with a degree in zoology, and then went to UIC for dental.
Illinois.
Okay, yeah, University of Illinois, and then did a Master's of Science in Dentistry and Public Health at the Henry M. Goldman School of Dental Medicine at Boston University, and just has continued on with just incredibly amazing things. Professor Emeritus at the University of Maryland, College Park, at the School of Public Health. So again, just incredible credentials. So I want to have Dr. Kleiman come up and lead this fireside chat, and I have some extra biographies if you need. You know them all. And do you want to stay there? Or do you want to? Yes. Yeah. Okay. Fantastic. Yes, I would prefer you to be here. Thank you for being here, and I would let you introduce Anna.
Thank you. I'm all set.
Fantastic.
Also, one more thing, everyone that is able to speak without a microphone there.
These are all mics that are live right here.
Okay.
We're
Well, that was a wonderful beginning and a long. Thank you so much. I am really, really impressed with the launch of this second annual meeting and the emphasis on the need for global oral health. When I think about Maryland and knowing that 1 of every 5 residents was born in another country. I was born in another country, lived in several countries before coming here. That the issue of local, global is really one and the same. And so I am delighted to be here. And I also wanted to thank Dr. Mosey for the comments that he made. It would be the same charge that we are going to have for our panel. So I would like our panel members to come up and sit at the table as I say some of my introductory remarks. So please come up and sit at the table. And so Sujay, thank you so much for the introduction. And given the background you have given and your love of the fireside chat, we are hopeful that we're going to ignite a discussion this morning that is going to be carried through the next day and a half. And as we all know, there's been a tremendous amount of work that's been invested and progress has been made in the oral health area and integration with general health. We have the evidence. We have seen the benefits economically and health-wise, and we've created incredible programs that we are ready to ramp up and frameworks that make a difference for our policies at the global level, at the national level, and at the local level. So our panel members today have contributed to so many of these efforts. Less than a few months ago, we may have focused this panel on extending all the efforts that we already have in place. However, today, we have new realities that we're facing. They're facing our public health capacity and infrastructure, our healthcare services, our academic institutions, and of course, our research capacity. We now need to change our thinking into how we can preserve our efforts. Not only preserve them, but have the energy and the positive outlook that we can make a difference. We've been in difficult situations before, and we're probably going to be in difficult situations in the future. We also need to think about upstream issues and actions. So in preparation for this panel, and before I introduce our members, I reflected on Julie Richmond and Milton Huddlechuk's paper on the topic of discussions that inform policy development. They proposed, this is back in the 80s, in the dark ages, but good things have come out of the past, that informed policy making is dependent on at least 3 components. They're interdependent: the knowledge base, the political will, and the social strategies. They emphasize the importance of the knowledge base to help guide our action. They talked about the political will to generate support and resources that are needed. And they spoke about the critical need of social strategies, both to stir up that political will and to make sure that we have that knowledge base for action. Our rich panel represents many different disciplines. They bring extensive experiences and perspectives to shed the light on these issues. They bring their lens as educators, as researchers, as clinicians, advocates, and journalists. They have contributed to the knowledge base. They are more than familiar with the political will, and they've applied social strategies for upstream approaches. And they have local, national, and global experience. So let me start by introducing Mary Backley. Mary is the Chief Executive Officer of the Maryland Dental Action Coalition. I see a lot of people in the audience that are very active members. For her entire professional career, Mary has worked in the nonprofit sector at mission-driven organizations, working at the community and national levels to address humanitarian and societal issues that affect health and well-being. She's done this through awareness, education, and outstanding advocacy to promote policy change. Her contributions have been recognized by the Department of Veteran Affairs, by grant makers in health, and the National Human Rights Committee. And during her 8-year tenure at the Maryland Dental Action Coalition, she's led a successful advocacy effort to expand Maryland's Medicaid adult dental programs, securing comprehensive coverage for over 800,000 adults in this state. Way to go, Mary. And Lois K. Cohn has always had my heart for the last almost 50 years. She's a consultant and Paul G. Rogers Ambassador for Global Health Research. She's a research sociologist who was recently awarded the American Dental Education Association's Guys Award for Eminence in Achievement and lauded for her sentinel contribution as the architect of the behavioral and social sciences in the oral health field and for her global health work. She's held multiple senior positions at the National Institutes of Dental and Craniofacial Research at NIH, where she last served as the Associate Director for International Health. She's a highly sought after consultant for her scientific and global health expertise, and she's provided consultation to international agencies such as WHO, national and international academic institutions, nonprofit organizations, research institutes, and more. Thank you, Lois, for all. And Eleanor Fleming, I remember the first day I met you at a PhD and your poster presentation. She is now, and look, you've grown up. She is now the Director of Health Equity Research and Innovation and Clinical Associate Professor at the University of Maryland School of Dentistry and is a diplomat of the American Board of Dental Public Health. In addition to her current position, she brings a wealth of experience from her postdoctoral training as an epidemic intelligence service officer at CDC, where she conducted studies to promote health equity. And she brings experience from her role overseeing the oral health component of the National Health and Nutrition Examination Survey and as a PI of multiple studies. She's a member of the editorial board of the Journal of the American Dental Association and of Public Health Reports, and has held leadership roles in multiple professional organizations. Welcome, Eleanor. Mary Otto. She also has my heart and your heart and everybody else's, because she's done such incredible work as an independent journalist, the author of Teeth, The Story of Beauty, Inequality, and the Struggle for Oral Health in America. She links us to the public at large. She began writing about oral health while at the Washington Post, where she covered social issues, including healthcare and poverty. And as we heard, her Post story in 2007 about 12-year-old Diamante Driver, a Maryland child covered by Medicaid who died after suffering complications from a dental abscess, highlighted inequalities that exist between oral and general healthcare and was a clarion call for state and national reforms. She studied at Harvard as a Knight Science Journalism Fellow and served as a visiting journalist fellow at the Russell Sage Foundation. For her keen reporting, journalism, and clear communication, she's been recognized with awards by nonprofit organizations and professional associations. Thank you, Mary. And Darian Witherspoon. I also remember the first time I met you, Darian, and your pursuit and your passion for oral epidemiology and for health literacy. Darian is an assistant professor, University of Maryland School of Dentistry, and also a diplomat of the American Board of Dental Public Health. He brings his experience from positions he's held in academic institutions and at the National Institute of Dental and Craniofacial Research. As an educator, he lectures on topics such as access to oral health, social determinants of health, and interprofessional education and practice. And his NIH-funded research focuses on oral health inequalities, improving oral health of older adults, and oral cancer epidemiology. He's also served as an essential member of the American Dental Association's National Advisory Committee on Health Literacy in Dentistry. Welcome, Darian. So, as mentioned, there have been a lot of investments to integrate oral and general health, with marked declines in funding, supportive policies, and workforce capacity. We see ourselves at risk of losing ground. While our preference is to grow our efforts, we now need to find a path forward to protect what has been established, but to move forward with gusto. So let's begin our conversation with some initial thoughts, and we'll go from panel member to panel member. We have an opening question that we see as our umbrella question for the conversation. The question is, in this current environment, what can help support and guide the sustainability. That's number one. And number two, the resilience of our efforts to enhance oral and general health and well-being. We need to consider ways to move forward as positively as possible. So as I look at the panel, I think I'm going to go to Mary to launch us off. And if our panel members have a story they want to share that sort of sets the scene of how they have persevered, we want to go from the ashes in the fireplace, Sujay, to the bright light that's going to lead us in the future. Mary.
Thank you very much. And it's such an honor to be here today. Thank you for the opportunity. And I see so many good colleagues and friends in the audience, and I look forward to meeting those who I have not met. It is a challenging time. It is an incredibly challenging time, but I go back to what Dr. Mace was saying and Dr. Kleiman opening this up. The power of collaboration, the power of community should never be underestimated. And the MDAC constituency, its incredibly diverse network of partners beyond dental, including medical, including social work, including care coordinators, including behavioral health specialists, everybody that has a relationship with a resident. Oral health is all health. Oral health is total health. And the necessity of involving community is imperative. And that was so key to MDAC's groundbreaking securing of Medicaid adult dental, bringing in the social workers, bringing in the care coordinators, providing them with the appropriate data. Data cannot be, again, also, its importance to document the case is so critical to moving forward. And the thing that in these challenging times, and right now challenging for MDAC, obviously, is the retention of the Medicaid adult dental. But the results so far, thanks to the community, thanks to our coordinators, thanks to the messaging, and most importantly, thanks to the utilization of the data that we've been able to see from this program, we are guardedly optimistic of moving forward. But again, it takes a huge effort on everyone's behalf. And it takes a huge commitment. And we would not be where we are in Maryland, even from our beginning, if it weren't for the participation and the dedication and the education of the legislators, which is very, very important to what we've been able to achieve. So again, the diversity of the network, the collective effort of all is what has been able to move what we've been able to so far in Maryland, secure and sustain what we have, and frankly, even build on that using the broad-based community and the network.
Thank you very much, Mary. I'm going to turn to Darian to continue. Darian, with your experience looking at the national picture, but especially the local and the work that you've been doing in Baltimore, what lessons can you bring forward and thoughts about where we can go from here?
Well, yeah, I think to piggyback on that, it's great to hear, and I kind of being at the state and seeing the power of the dental benefit and all the different constituents that have been involved. That's really inspiring. When I think about the current environment, especially, and we're talking about integration, I think there really is strength in numbers, and there has to be. And so thinking about, we know the connection between oral health, general health, and I think as much as we can, talk to our physician colleagues, really get that message across, I think it can be very helpful. I think about an initiative we're doing in Baltimore through the University of Maryland, all the different schools, medical, pharmacy, dental, nursing, social work. It's called Engage for Heart. And so obviously the central focus was on cardiovascular disease. But we were fortunate to have a director of this program who understands the importance of oral health, general health, mental health. And so we're all kind of at that table. And because we have this program, even though it's centered initially around cardiovascular disease, we understand that oral health is critical to cardiovascular health. So as dentists, we are part of that program. We've been able to engage with the faith-based community. I think about the upstream and how we can connect to the community. And so I think about these different touch points. And so we've been able to kind of use that as a leverage to get out into the community, address some of those social determinants of health. In addition to collecting data, I think also it's important to have our political constituents actually see what we're doing. So as we think about the different programs we're doing, inviting someone to actually come to some of these events to see what's actually happening, to have community members talk to political constituents about the importance of these programs. I think that's all very important. And I think at this time period now, when we think about the challenges and the challenges of funding, the more we can kind of connect with this bigger picture of oral health, overall health, and kind of come together, that's going to be critical going forward.
Thank you very much, Darian. You brought in some new aspects with the faith community and looking at the interprofessional interaction. I'm going to turn to Eleanor. Eleanor, if you can give us some insights from your research and from your perspective.
So yeah, thank you. Good morning. Happy Friday Eve to everyone. I want to start off by sharing that, in being here today, while I do have a day job and I'm affiliated with a number of organizations, like what I'm sharing does not reflect the perspective, position, work of any of those spaces. And I need you to understand that, because where I'm grounding my reflections is less on the science, but on lived experience. So I don't know how many of you live in the city, but I live in the city. Specifically, I live in West Baltimore. Specifically, I live in the hood. And when your neighbors are unhoused, when you see the impacts of structural racism and living in the Black Butterfly, if you haven't read that book by Larry Brown and you want to understand the city, I encourage that you do. Your sense of what we're talking about today and the realities that are going on, it doesn't make sense. And I honestly have struggled with trying to be here and engage with you in a conversation when the world is on fire and upside down and all of the things that are happening. And the only thing that I can offer in looking at community and looking at a city that next month will celebrate and remember the 5-year death of Freddie Gray and the uprisings that happened in the city. The only thing I can tell us is that we're either going to stand on business or we're going to fall. And I name this in these specific terms of where I come from, the folks I see on a daily basis, and the work that I do that reaches beyond oral health to this thing called justice, which if you've read any of my work, for 5 years, there has been that meter of beating that drum of justice. My co-conspirator, Sarah Raskin, is here, and this is the work that we've been trying to lead through both thought leadership and offering us ways to broaden our perspective. And to the degree that we land on collaborations that are up top, and to the degree that we look at institutions to do whatever it is that institutions and industrial complexes do, we've missed the point. Because the people, the community, the folks who I live and work and plan and collaborate with, they've moved forward with health. Like they're doing things to proactively take care of themselves without nary a provider to help. And usually I'm the only dentist, but they don't know I'm a dentist. So that means that I get to get in good trouble without this expectation of prevention or any of the things that we should be doing. I say all of this because if your moment is to think about physicians, nurses, whomever, that's fine. But I don't know that those folks are gonna have your back, because they have not had the back of oral health. And if what we're trying to do is preserve, I wonder what we're preserving, because this has been a house on fire for decades. The silos have existed for decades. And if that is what we are preserving and sustaining, I don't know that's what people want. In fact, I don't hear people saying, give me more of the same. Folks are saying that they actually want to use those benefits that MDAC worked so hard to get, but they're facing discrimination in oral health settings. And by the way, we can't talk about that anymore. They're struggling with trying to find time to do all of the things to maintain their health, when, like me, there are more tobacco stores on their streets and places where they can get kale or an apple. And so when that is the reality of the day, on top of the politics where you have some sense of neutrality, we gotta wake up. And again, I go back to this point of standing on business, because now is the time. If you thought that this was about community water fluoridation and some vaccines, you missed it. If you thought this was making sure that CMS has a chief dental officer, you missed it. The time is now. And I don't know any other way to express the urgency other than letting you know that around us, well, not here, but if you go outside to the places where people are still in community, where they are thriving, where they're actually fighting institutions like this, and see how they model and do the work, that's where we go and get our lessons. Again, this is a city that was on fire 5 years ago, and people have been able to rebuild themselves. They didn't ask for federal dollars. They didn't ask for anything from the state. They organized themselves and they did it. Why we are seemingly unable to do that, I don't know. But I offer that to us as the thing to take away from gathering today. Like, what are you going to do? Who are you going to do it with? And are you going to stand on the square to do it? Or at the first puff and huff and whatever it is that bullies do, you fold? Because if you fold, good luck to you. But I'm here to stand on business, because that's what I know this is about. So to the point of thinking about medical dental integration, of thinking about, going and advocating, like, certainly do all of that stuff. However, just know that the game has changed and there are more pressing issues to our survival that we must be about. And hopefully we can have some sense of hope, because I get that that's the theme. But when things are on fire, we don't talk about what curtains we want in the kitchen. We get out, and then we figure out what our next steps will be.
Eleanor, thank you. You always encourage back. And I just want to highlight the fact that we should never, ever, ever lose the fact that we are here to work on overall health and well-being, no matter how we approach it, that our role is to invest and help everybody rise from wherever they are. Oral health is our tool, but it's only one tool of many that we have, definitely in public health. So Eleanor's point, I think, is key. And we have to look at ourselves of integrating ourselves into society in a way that is trusted, but also in a way that allows us to move ourselves forward in the oral and general health aspects of the world. I'm going to turn to Dr. Cohen next to give us a perspective from her many different roles she's played. Lois.
Thank you so much. This is a wonderful opportunity to learn what's local and what's global. As many of you know, that term, it's a reciprocal relationship between what's happening in the here in our local community and what we might learn from the global community. The global community is not so foreign, as Dushanka mentioned. Many of us did not come, we were not born here. I happened to be born here, but my mother was not, and many of you were not born here, but you live here now. And Maryland is a particularly diverse state among all of our United States. I came to the global view that we're all in this together way back at least 55 years ago when I worked. I came to work in the government during Lyndon Johnson's presidency, and he had proposed national health insurance way back then. But it was under President Nixon, who also proposed national health insurance. And we, in the oral health area where I happen to work as a sociologist, anticipated being asked, well, is oral health how are we going to incorporate ourselves into a national health plan? We only have private practice fee for service in this country. That's all we have to offer. Well, the idea was that maybe we have something to learn from elsewhere in the world, where they have a longer experience of delivering health services to the entire population, and they have integrated oral health into their health plan. And that started what we began to implore the White House, President Nixon's White House, why we should do work globally. And he opened up China, which allowed us the permission to look outside the country. Up until then, we were focused within our own country. So we looked at examples outside, but they were behind, a lot of the good examples were behind the Iron Curtain. We couldn't get there by ourselves. So that's another thing we learned. We learned that we had to have a neutral platform on which to bring disparate people together and learn from each other. And that's another lesson about reciprocal learning, how we learned from the countries behind the Iron Curtain at that time and brought together more than a dozen countries over two major international studies. By the way, Johns Hopkins was an inspiration because they did one of the very first studies of medical care utilization, and we used a lot of their methodology in order to launch the first and second international collaborative studies of oral health systems. And I'm going to stop there, but just to say, sorry, I need to continue one more thought. Reciprocal learning is one way to be resilient and maybe sustain what we're doing by getting ideas from anywhere we can get the ideas from. But the other thing I want to mention is the progress that has already been made at the global level. First, the United Nations, the first time they brought oral health up, other than establishing the World Health Organization in 1948 and making sure oral health was in it, which they did. In 2011, the United Nations General Assembly passed the proclamation for the disease prevention of non-communicable diseases. In Section 19 of that agreement, they added oral health. In 2019, the General Assembly passed another major proclamation related to universal health coverage, and they added oral health. Later on, the World Health Assembly, which is the health arm of the United Nations, proceeded to elevate oral health in their agenda and passed a resolution to that effect. It was followed subsequently by several major reports, but culminated in the WHO Global Oral Health Action Plan 2023 to 2030. And just last November in Bangkok, they held the first ever World Oral Health Summit to convince those national governments that signed on to this to proceed with national oral health plans. That is what we have to sustain right now in this environment. It's quite a challenge, but through reciprocal learning, and if we can't do it here, we can still learn from other countries.
So Lois, thank you for letting us see from the top down that will permeate. And I can hear Eleanor and also from Mary and Darian from the bottom up. Those things have to converge. Mary Otto, I am turning to you for your reflections and incredible experience that you can share with us.
Thank you. I'm so honored to be here. And I'm sitting here, oh, it's so powerful. I'm sitting here and I'm thinking Dr. Fleming on one side, Dr. Cohen on the other. It's like from the
Can you
block by block work to the, global work, and Darian and Mary are here too. From the state, the bastion of state institutions here in Maryland, and you're all here too. The story of this poor boy who passed away 18 years ago. It might have been forgotten long ago, but there was a movement already in place when that story was written. And that's what happened. His story went into hands of people who took it up and used his tragic death as a way of making clear the urgent needs that oral health advocates and researchers and teachers and providers see every day. It was something that a lot of lawmakers didn't understand. They maybe had never gone without care. They didn't understand the suffering and the silent epidemic that Dr. Satcher had written about. And he'd foretold this tragic death and many others in his Oral Health in America report in the year 2000. But when Diamante died, one of those advocates was on his way to the Capitol Hill, Dr. Edelstein, Dr. Burton Edelstein, and he'd been fighting for 10 years already to get oral health benefits included in the reauthorization of the Children's Health Insurance Program. And it was a program that had been signed into law by President Clinton. It's like 7 million children of working poor families. They were a little bit higher. Their income was just a little too high to qualify for Medicaid, but they still needed benefits for their children. And this program was signed into law, but it had never included a guarantee of dental benefits. And for 10 years, the oral health movement, this quiet, strong movement, had been preparing for this moment of opportunity to get these dental benefits included. And I was thinking about the similarities of those times and these times. We were in the war on terror. We'd been attacked, and President George W. Bush was focused on this war that was dragging on and on. It was one of those, we don't have money for this. We're going to veto any expansion of this program. But the oral health advocates did not stop pressing quietly and working. And the story of this little boy's death kind of galvanized, this idea that, this is really, lives are at stake here, the expansion of CHIP was vetoed twice, but then President Obama, when he was elected and got into office, it was one of the first things he did when he became president, was to authorize a full comprehensive dental benefits for the children in CHIP. And there were deep reforms, as Mary knows, on the state level, where Governor O'Malley said, we're not letting this happen again. And this Dental Action Committee, you were supposed to be there for 6 months. They're still fighting and working. They got adult dental benefits, But they reformed the state system too, in ways that were very meaningful by integrating, finding ways in, not dramatic ways, but important ways of integrating oral health services into our healthcare system, as Dr. Satcher called for in Oral Health in America, you know, things like giving nurses and doctors an incentive to look inside little kids' mouths in the first few months of their lives when they're doing well baby checkups, to provide the most simplest, most teachable and sustainable oral health lessons to their families, and to help them connect with a dental provider, an oral health provider, to help them, you know, all their lives, you know? I mean, these are so, they're things that they're so practical and humble in a way, but so important. So we're thinking about sustainability and resilience. I accidentally also wrote resistance in there, but you know, I think it was also listening to you. You know, they have to accept everything as it is in a moment of crisis. It's a time to discover and explore and try new things too. So I don't know. Thank you.
Mary, I love that you said it's at the time of crisis, which I don't know the way in which crisis and opportunity is looked at as the same character in Chinese. So forgive me if I don't do that correctly, but we are at a point where disruption is happening all around us, but it's also realignments and redesign opportunities and revisiting all of these things. And so I can see that Lois has a comment to add before I ask my next question.
I can't, I'm just struck by, well, everybody facing from their different perspectives, the crisis that we all are experiencing. But and some of us here, of course, are depending on the judicial system, but the power goes back to the people where we started. And it's the public voice. And when I think of the global situation and the local situation, I come to the same conclusion as I listen to everybody. It's really elevating the public's voice, whether it's local or global. And it reminds me that in the WHO Global Oral Health Action Plan, there is a specific section. They're for governments, for educational institutions, for researchers, but there's a section on civil society. That is the weakest link at the global level, civil society. And when I think back what it took to get the World Health Assembly to listen, 2 NGOs stood up for dentistry: Doctors Without Borders and Smile Train. Doctors Without Borders spoke on behalf of NOMA, oral gangrene, primarily in West Africa, but it's been in many other places. They suspected it in Haiti, for example. But the other Smile Train, Peter Massey is from the cleft lip and palate community, and they spoke up. And so those were powerful voices that the nation's ministers of health listened to. But it's our weakest link. We don't have the public stakeholders at the global level. Now, the Friends of the National Institute of Dental and Craniofacial Research represent some of those patient groups. Sjogren's, juvenile diabetes, ectodermal dysplasia. I wish we had those kinds of, or osteoporosis foundation. we had the civil society groups at the global level that we have so well articulated in Maryland. I wish we had that at the global level. If you can, we can find a way to transform that. That would help tremendously in growing, not only sustaining our progress, but growing it.
So
I think-
this
I think to your
theme
point-
of
If I-
civil
if I-
society, can we continue on that, Eleanor?
Yeah, if I may, I think this point that you raise, and I'm putting on my political science cap on this one, it's not the fact that civil society is weak. I would actually say that civil society is the strongest foundation that we have. The problem is that the powers that be at the top refuse to listen. And I think that that's where the conversation and the resistance and the work has to happen, is to break open those doors and to do the actual disruption. Because if we believe and if we see that communities are organized around a health outcome or housing or whatever their issue happens to be, and if their collective effort is translating into local, national, whatever, it only begs the argument that they can make it to the global stage. But do they have the ability to? And are those folks like the Friends of NIDCR or Smile Train or whatever the group is, are they willing to bring with civil society, or are they operating in their own silos? I would argue that it is the siloization and the seeing civil society as different that is the problem, which speaks to this moment. If you think about this moment and what is happening, civil society has spoken up. And there are segments in this population that have said, nope, nope. And they've been doing this consistently. It was quiet. It was, we don't want books in some schools, or we're gonna be anti-mask, or whatever the issue may be, but they had the power. And they were able to translate that power to electoral power, to the control of the courts, and the dominoes are falling. So I would say that we actually have strong evidence here that civil society, even fringe, has the ability to move up if their voices are heard and accepted. And so my argument to you, and the point that I think is worth considering, is, are we willing to do that work with civil society? Are we willing to demand that WHO or whomever the body is listens to the people? Because if you pay attention to what's happened, there's a certain segment of civil society that said enough is enough. And so if that can happen with democracy, certainly it can happen if you want to elevate oral health policy. So just a nuanced way of thinking about the issue is not necessarily weakness in terms of a link in the chain, but actually the missed opportunity in terms of the barriers of institutions that don't allow for that. And that you're pointing at Mary then begs the question of, that's where we need the other part of civil society, which is that fourth estate, to really come in and to help us do that work. But of course, we see what is happening with journalism. So to the degree that all of these things are connected and the house really is on fire, again, what business are we going to stand on?
So this is exactly what we wanted out of our panel. We're allowed to go a few more minutes after 10 o'clock. And on the topic of what we're just talking about, the issue about civil society and authentic engagement with civil society and how we build it into our organizations and structures, knowing once you build an organization and structure, you put impediments and guardrails. We don't want the guardrails anymore, but we do want to listen and hear and learn. I'm going to ask each of the panel members as closing thoughts to think back to the frame that we spoke about knowledge base, political will, and social strategies in order to let us move forward in a more positive way. And so by looking at that, you can choose whichever of those three, not all three of them. But I'm going to start with Darian and move down the line there. This is a gem that you're going to share with these wonderful folks that are going to be around for the next day and a half, thinking about that.
Well, yeah, first I'd like to thank all the panelists, because I mean, I got a great perspective and just kind of soaking all this in and thinking about, you know, how we can really advance oral health, particularly for the community, for the people. That's what we, many of us, I mean, all of us got into public health for. I don't know where mine fall, but just thinking about some of the things that were said, I've really been thinking about people outside of the traditional healthcare space and how we can keep those people healthy. Eleanor mentioned that, you know, many of our communities, you know, health is the last thing on their mind. They've got so many other challenges. And so what can we do, given those circumstances, to keep people healthy, keep their oral health, and general health good? And so I've been on this topic of community touch points, trusted spaces. As I mentioned, I gave an example about churches, faith-based communities. Depending on the specific neighborhood, that's going to be different. But I'm thinking about how we can enable people and empower the community so that they're not relying necessarily on a specific healthcare provider. You know, we do our parts, everyone's going to do at each level, policymakers, clinicians, we're all going to be doing our parts, but we want our communities, despite what's going on, to be able to stay healthy. And so I'm thinking about community touch points, trusted spaces to give a little bit of hope, specifically as it pertains to Johns Hopkins. We're collaborating on a project with the ALIVE cohort. I can't ever remember the name, but it's the AIDS linked to intravenous experience. It's a big research study. It's gone on for decades. It's a study that is investigating the impact of injection drug use on HIV and the ability to keep people into the system to get care for HIV and the impact that can have on general health. We were actually brought on to bring an oral health component to that study, which I think is great and maybe might open up some connections with Hopkins. But in talking to people, participants in the study, oral health is important to them, but they're also dealing with, many of them, homelessness, all kinds of other issues. And so the questions we've had in our mind is how can we stay engaged with them when they're not regularly engaged in the healthcare system? How can we empower them? And so I just think about, when we think about oral health, general health integration and different programs that address that, thinking about the trusted community spaces that can be touch points to connect people who aren't traditionally in the healthcare system, to empower them to stay healthy when we're not seeing them one-on-one. So I don't know what category that falls under, but
Well,
that was my takeaway.
you've covered the waterfront. Thank you so much. We'll move down the table. Thank you, Darian.
Thank you, Darian, and thank you, everyone. I've been taking copious notes. I wish I was kind of out there taking some. I've developed about 5 different projects, so I don't know if that's good or bad, but thank you all very much. Yeah, I'm the eternal optimist. You have to be. And I look at what has been done over the past 10 years, and it's really quite extraordinary. Not only in the state of Maryland, but nationally and globally. And my focus here is the state of Maryland. And because of the community that I referenced earlier, we have shifted the political conversation in Annapolis about oral health. When you speak about public health programs, when you speak about policies to expand coverage, to expand services, to expand coverage to a community, such as through the Healthy Baby Equity Act, which now provides coverage to immigrant moms and children, regardless of their documented status. And when that legislation was being discussed in Annapolis and our partners at CASA and Esperanza, and we brought up, well, what about oral health? Of course, we had our partner support, 5 million%, but the change, the shift that I see in Annapolis is, oh, of course, oral health. of course, oral health. Whereas 10 years ago, it was why oral health. So I think there's a huge difference and achievements that we've been able to do because of the active engagement of all different types of people within the total community. And so, using that positivity now that we have from the legislators, and even expanding and growing what we've been able to do, and really look at now the integration of oral health into somatic health, into the totality of health. And I think we're in a very good position to be able to do that, despite the very challenging climate we find ourselves here, even in the state of Maryland with a deficit. It's almost the issue itself, I would like to optimistically say, is almost bipartisan in Annapolis. Legislators understand it. And so now, because of our work, it is time to take it to the next level on the integration of oral health into prenatal postpartum care, on the integration of oral health and medical care in terms of primary care. So I think we find ourselves, again, you have to be the eternal optimist on this, but our optimism since starting, frankly, in 2011 has enabled us to achieve what we've been able to achieve. And so there is data out there. 10 to 12 years ago, there was not any data. Yeah. So I think if we look at the evolution of the issue of oral health and how much more there is available today than there was 10 years ago, you should take encouragement over the fact is that we've been able to incrementally, step by step, advance the issue and serve a much broader, inclusive community within the entire state.
Mary, thank you very much. We're running a little bit late on time, but we need 3 more visionaries to contribute to the comments that have already been made. So Lois?
Yeah, I want to build on that in terms of the investment case. Building the economic argument, why it makes sense, it costs less, it's more efficient. It affects total health by making this investment case for integration of oral health into the mainstream. It's just going to deal with scarce resources, and I think that's a message. The other message has to do with advocacy. I also think as a researcher, as a sociologist, we have a deficit of research on advocacy. We think we know how to advocate, but we haven't really tested a lot of these things in real life and subjected them to the kind of research we give to basic translational implementation science. We think we have some baseline data and some case study reports on how health policy has been formulated in different places, locally, nationally, and globally. But we really don't have a systematic body of knowledge in advocacy research. We can take pieces from community organization research. But I make a plea for that because I think in the case, we can use oral health as a case study point. And so we need to expand our knowledge base on the political will as well as the social strategies to get there.
Thank you. And Mary Otto.
Speaking as a journalist, it's important to remember the press as part of this larger challenge we face. Our local newsrooms have been decimated in recent years, but they remain trusted voices in the communities. So in your work, don't ever forget to include journalists and, you know, help them understand and tell the stories that need to be told. They can become, you know, more than the sum of their parts in this ongoing effort to get important, urgent scientific information to the public, to help people understand what they need to do to survive and sustain themselves. I wouldn't have been able to write with the confidence and authority that I was given by so many knowledgeable, wise people, you know, including people right here at this table and in this room, inviting me into their clinics, giving me access to their research, being patient enough to explain to me, and to have faith and courage to trust me, to tell the stories that need to be told, and that there are reporters everywhere who would be grateful for that same kind of help. Thank you.
Mary, thank you. We need an embedded journalist in all that we do, so we can help with communication. Eleanor, few closing comments.
No, I'll just be super brief and to the point of what you shared, Mary, in terms of being brave. I encourage all of us to be brave. And I go back to what I said in the beginning. Are we going to stand on business? And whatever that looks like for you, however you do it, whatever you need to do to resist, or whatever the verb is in this moment for you at this time, do that. And hopefully do that with some sense of community that isn't just those of us in this room, even though we're great, but to go outside and to do that in spaces with community members and respecting that the community has the power. They don't need us to empower, to elevate. They need us to listen. And if you can show up and do that work, hopefully we'll be here next year, 3 years, whenever we convene again, and we can say that we survived, and now we can build this new health justice reality that we want. But in the meantime, you either stand on business or know that your silence is not going to protect you.
Thank you very much. I mean, let me just thank the panel for their wonderful thinking and that they're bringing. And the charge to all of you. We expect you to answer the question that we gave the panel of looking at how we could look at sustainability and resilience in our efforts. Well, being authentic, by listening, by being able to share and communicate with diverse populations, and most importantly, looking at how we can grow what Sujay and his team have established here so that we can have a think tank in the oral health arena that can help grow these ideas. Thank you so much.
Now, before you all go, don't go too far. I know we're a little bit behind. We will catch up. We did plan for this. But we have a few a couple of quick notes. You know, this combination of perspectives, I never imagined that I would get this kind of combination of experiences in dental school. And for me, you know, if I can reference and maybe perhaps date myself, there's a 1985 movie that was kind of seminal for me. It kind of shows you my age bracket, The Breakfast Club. And it's, yeah, so some of you are familiar with it. And you're probably wondering, where is this guy going with this? Now, John Hughes, I believe is the director's name, had a fairly kind of homogeneous background. And clearly the effort here was not to recreate John Hughes's experience. He had, you know, I 5 people maybe serving detention on a Saturday. There was a princess and an athlete or a jock And in their words, not mine, a basket case and a criminal, and there might be somebody else, a nerd, a geek. And I'm not suggesting that's what we've done here, but we do have something slightly different. We have a journalist, we have a sociologist, we have a political scientist, we have the CEO of a patient advocacy group, and we have a dental public health professor. And I appreciate they have multiple roles. So I'm sort of putting them in small boxes and moderated by a professor emeritus and retired Rear Admiral General of the U.S. Public Health Service. So once again, I want to thank you. Dr. Munir Butler is Professor of Dental Public Health and Associate Dean of Academic Affairs at the IMU School of Dentistry in Malaysia, Kuala Lumpur. Holds a BDS and an MDSC in Conservative Dentistry and DHPM and MPH and a PhD. He's active in academia since the early 2000s, contributes to undergraduate curriculum planning, evaluation, and assessment.
Good morning, distinguished colleagues and fellow oral health advocates. I'm Munir, Professor of Dental Public Health at IMU School of Dentistry in Malaysia. I would like to begin by expressing my sincere gratitude to the Johns Hopkins Center for Global Health and especially to Dr. Sujay Mehta for the kind invitation to speak today. Today, I invite you on a journey to explore what might be the most significant paradox in our profession. How the very field dedicated to healing may simultaneously be contributing to planetary harm. But more importantly, I want to chart a path forward where oral health and environmental sustainability aren't competing priorities, but complementary necessities. Our exploration today will follow 6 key areas. We will begin with iceberg model to understand the visible and hidden dimensions of our challenge. We will confront the urgent paradox in global oral health and pose a key question that must guide our profession forward. We will examine the triple threat of environmental impacts from dentistry, introduce an upstream, midstream, downstream framework, and conclude with call to action that I hope will resonate with each of you. Let's begin with the iceberg model for amalgam phase down. Like an actual iceberg, what's visible above the surface are elements like global phase down initiative, adoption of alternative materials, public awareness campaigns, policy changes. These visible aspects receive the most attention in our profession discourse. But just below the surface lie critical factors that often go unaddressed. Research on alternative material, environmental impact assessment, dental education reforms, economic consideration, and waste management infrastructure. These middle section elements significantly influence the success of our transition efforts. And at the deepest level, the foundations that's hardest to see but most critical to address, we find the elements that will truly transform our profession. Technological advancements, global health priorities, interdisciplinary collaboration, long-term practice on dental practices, and perhaps most importantly, reshaping oral health paradigms themselves. The key here is that successful transformation requires intervention at all levels, not just addressing what's immediately visible. Now let's confront what I call the urgent paradox. Over 3.69 billion people worldwide suffer from untreated caries, severe periodontitis, edentulosum, and other oral disorders. This staggering burden demands immediate action. Yet look at the diagram on the right. From dental clinics, from waste treatment to landfill, dental mercury follows an alarming pathways into our atmosphere. Soil and water system, and mercury is just one part of dentistry environmental footprint. This is our paradox. We are healers whose practices may inadvertently cause harm. The profession dedicated to improving health is simultaneously contributing to conditions that threaten global health through environmental degradation. This isn't just ironic, it's untenable, and it demands a fundamental reimagining of how we practice. This brings us to our central question. How do we address the global oral disease burden while safeguarding environmental health? Look at these diverse voices on the screen. Healthy smile shouldn't cost Earth its vital grain. Biodegradable tools heal mouth without lasting centuries in landfills. Clean water fundamental to both dental health and environmental preservation. These aren't just clever phrases. They represent the core principle that must guide our profession forward. Oral health care and environmental health must be viewed as indispensable concern. The most profound insight here is that prevention remains the greenest dental intervention ever conceived. A cavity that never forms requires no filling, mercury-based or otherwise, and generate no environmental impact from treatment. Dental care's environmental impact constitute what I call a triple threat. First, mercury pollution from dental amalgam. Despite being phased down through Minamata Convention, amalgam remains in use globally, continuing to contribute to the mercury in our ecosystem. Second, the climate impact through dentistry's carbon footprint. Did you know that significant portion, 64.5% of dentistry carbon emission originates from travel? Dental associated travel affects air quality, releasing over 443 tons of nitrogen oxide and 22 tons of particulate matter annually. Third, water resources depletion and contamination. A typical dental office uses thousands of gallons of water annually, with concerning levels of contamination in wastewater. A sustainable approach must address all three dimensions simultaneously, not in isolation. The global response to mercury pollution is embodied in Minamata Convention of 2013, now ratified by 146 countries. This landmark agreement specifically addressed dental amalgam in Article 4 Annex A, calling for phase-down approach. Countries like Malaysia have embraced this commitment, implementing measures to promote mercury-free alternatives, minimize amalgam use in vulnerable populations, and establish best management practices for the waste. The Minamata Convention represents our profession's first global environmental commitment, a recognition that oral health and environmental health are linked. However, implementation faces three key challenges. Economic constraints, particularly in low-resource settings where alternative materials may be prohibitively expensive. Technical challenges with alternative materials compounded by cultural and professional resistance to change, what we might call the way we have always done it syndrome. And knowledge gaps among practitioners who may lack confidence and expertise with mercury-free alternatives. The opportunity lies in transforming these challenges into innovation drivers, developing affordable alternatives, creating context-specific implementation strategies, and enhancing professional education. Turning to carbon emission, dentistry contributes to approximately 0.5% of all healthcare carbon emission. While this may seem small, when scaled globally, it represents a significant environmental burden. The source include transportation emission from patient, safety, energy, staff, energy intensive equipment like autoclaves, X-rays, and the production and disposal of single-use products and packaging situation that reached crisis level during pandemic. Each dental visit generates more than just clinical outcomes. It generates a carbon footprint that affect our climate. In 2021, Bangkok statement endorsed by FDI World Dental Federation, representing over 1 million dentists, establishes environmental sustainability as core professional value in dentistry. This landmark document provides 4 crucial frameworks: a unifying framework for action through multi-stakeholder consultation, a prevention-focused approach to reduce treatment needs, evidence-based environmentally sustainable practice standards, FDI's endorsement elevating sustainability from niche concern to mainstream professional responsibility. The Bangkok statement represents nothing less than paradigm shift from treatment focus to environmentally conscious oral health care. Prevention must be recognized as our most powerful environmental strategy, operating across 3 domains. Economic, prevention costs are invariably lower than combined cost of treatment plus environmental remediation. Community, population-level intervention like water fluoridation and school-based oral health programs remain most environmentally efficient approaches. Digital, the technologies for remote prevention support can dramatically reduce the carbon footprint associated with preventive care. Remember, the most sustainable dental treatment is the one never needed. For necessary clinical care, we must transform our practice through 4 key approaches. Mercury-free restorative material advancement, which continues to improve in durability and clinical performance. Energy-efficient equipment and renewable energy adoption, which can reduce a practice carbon footprint by up to 60%. Water conservation technologies and waste management protocol that minimize environmental impact, and digital workflow optimization to reduce material use for digital impression to CAD/CAM restoration. These aren't future aspirations. They are available now and represent the new standard for responsible care. This conceptual framework illustrates the complex sociological nature of our challenge. Upstream factors include national and global governance, healthcare funding models, and cultural determinants. Midstream factors encompass the healthcare system structure, psychological factors affecting both practitioner and patient, and dental professional behavior. Downstream factors include clinical system, environmental impacts, and biological reaction. 5 key interactions span this framework: the policy to practice pathway, the education cascade, economic influences, environmental pathway, and equity consideration. This demonstrates that amalgam phase down is not simply a material substitution issue, but a complex sociological challenge requiring coordinated intervention at multiple levels. The economic dimensions are crucial because financial sustainability enables environmental sustainability. Key elements include cost-benefit analysis of green dentistry practices, which increasingly show positive return on investment, insurance and reimbursement models, reforms to incentivize prevention and environmentally friendly treatment, investment in sustainable infrastructure and economic incentive for mercury-free approaches, and perhaps most importantly, recognizing the long-term cost saving from prevention focus. Building capacity for environmental oral health requires workforce transformation through scientific research to address knowledge gaps among professionals, curricular transformation, integrating sustainability through dental education, continuing education focused on hands-on workshop rather than theoretical training, auxiliary workforce expansion with emphasis on prevention and minimal invasive techniques, community health worker integration to deliver preventive messages, and cross-disciplinary approaches combining oral health and environmental expertise. Our strategic priorities moving forward must focus on strengthening policy frameworks, accelerating research, developing implementation guidelines, creating a monitoring mechanism, and fostering international collaboration. The environmental challenges of oral health care demand not just new technologies, but a workforce equipped with new knowledge, skill, and values. This brings us to our collective responsibility, building a sustainable future through responsible oral health care encompasses an ethical imperative that recognizes our moral obligation to practice sustainable care, intergenerational justice, ensuring fairness for future generation, planetary health integration that positions oral health with broader environmental frameworks, personal and professional pledges to sustainable practice and participation in global community sharing best practices. I will leave you with this thought. We cannot have healthy people on a sick planet. Our commitment to oral health must include a commitment to environmental health. The choice before us is clear. Continue business as usual and contribute to environmental degradation, or embrace the challenge of transformation and become part of the solution. Thank you for your attention. I welcome your question and insight as we navigate this crucial transition together. You can scan the QR code to connect with me on LinkedIn or send me an email with your question or insight. Thank you and goodbye.
Okay, let's see if this works now.
Hello, everyone. My name is Heywan. I'm a pediatric dentist from the United States, now working in South Korea and Kenya mainly. I'm really glad to give this a welcoming Zoom recording for you all. Hopkins, Bloomberg, was the place where I learned public health and global health. Graduated from master program in 2013 and doctor in public health in 2020. As a clinician, it really gave me a perspective and a position how to view our current oral health challenges and issues in public health lens. So I thank you to all the Hopkins community. I will also want to say another thank you for this amazing symposium over the next 2 days. We're going to talk about all different aspects about global oral health, from positioning oral health as a primary healthcare agenda, the workforce issue that we have to go beyond dentists, the inequalities, which is immense, that Lancet report defined oral diseases as a social diseases. And we want to talk about the context. My dear friend Elham and her team will present on refugee oral health. So what does it mean, this workforce, this care delivery issue of oral health care in different contexts, low-income countries, middle income, high income, urban and rural, and considering all other factors to deliver the essential oral health care for all. I'm excited, and I'm sure that you are excited as well. This is beginning, and we are going to collaborate in many different ways to elevate oral health as health agenda. Thank you all for coming for this symposium, and I hope to meet you in person for next decades to come for innovative, meaningful, and fun collaboration. Thank you so much.
Okay, so for those of you who don't know, that was Dr. Heywan Lee, recording from Seoul National University. She was one of our original 8 who was involved in 2023. I'd like to bring Maureen Henley to the stage. I'll just say a few words about Maureen. She was instrumental in organizing last year's event courtesy of the Johns Hopkins Hospital. This was a fantastic combination of in-hospital, on the ward, exciting projects and things for kids on the ward and for staff and faculty and patients, bringing in collaborative work to increase awareness about oral health and hospital-acquired pneumonia. And I'm grateful that Maureen invited me onto her team to help organize the event last year. We did a webinar, and I think it went off very well. And so a bit about Maureen. She's a manager of clinical quality improvement at the Johns Hopkins Hospital. In her role, she provides leadership for preventing harm and improving the quality of care through developing, advancing, and evaluating hospital quality and safety priorities in collaboration with clinical and administrative leaders. She has over 15 years in healthcare and over 7 years in quality improvement experience. Maureen knows investing in clinical improvement contributes to more positive patient recovery experiences, improves the quality of life for people with serious illness. Her previous clinical experience includes emergency nursing at Johns Hopkins Hospital and St. Agnes Hospital. She is a certified professional in healthcare quality, has a Lean Six Sigma Green Belt. She is certified in patient safety and is an Armstrong Institute Patient Safety and Quality Leadership Academy Scholar. Maureen's earned a bachelor's and master's degree in nursing in health systems management from the Johns Hopkins University. Maureen, the stage is yours. Thank you so much for being here. And
well, thank you so much. I'm so honored to be here. It was just actually by chance that I got to be so engaged and involved in oral health, and I've learned so much about how oral health impacts overall health. And I'm so privileged to be here amongst you all who also have the same mental model. We're really excited to start embedding some of oral health in our clinical care at the Johns Hopkins Hospital. And we're seeing benefits across the board, not only with reducing aspiration pneumonia or NVHAP specifically, but also just how patients are feeling. We also recognize through the equity lens that we really have an opportunity to go beyond just our walls at the hospital and really start to empower, especially our local East Baltimore clinic, in their access and understanding of the importance of oral health. So thrilled to be here and thrilled to be introducing 3 wonderful panelists and talks for you guys. We are going to go first. I think the agenda, we're going to switch around the agenda a little bit. And so first, I'm privileged to introduce Dr. Katie Batani. She is an assistant research professor in the Department of Pediatrics at Georgetown University and serves as deputy director of the National Maternal and Child Oral Health Resource Center. She is also a 3rd-year doctorate in public health student here at the Bloomberg School of Public Health and in the Health Equity and Social Justice concentration. Katie has 23 years of combined experience in academia, clinical practice, and public health, and has a strong passion for maternal and child oral health. Public health contributions include co-authoring and leading nationwide dissemination of an American Public Health Association policy statement on improving access to oral health care for pregnant women and leading the development and statewide dissemination of Maryland practice guidance on oral health care during pregnancy for medical and dental providers. Katie also has authored or co-authored several publications on oral health and primary care integration and maternal and child oral health. Katie is a member of the Maryland Pregnancy Risk Assessment Monitoring System Steering Committee, serves as the Regional 3rd Dental Hygienist Liaison Coordinator for Head Start programs for the National Center on Health, Behavioral Health, and Safety, and serves as Governing Counselor for the APHA Oral Health Section. She is also a member of the University of Maryland School of Dentistry's Prenatal Postpartum Advisory Board and the Maryland Coalition for the Allied Dental Education. She's going to be presenting today on integrating oral health care and primary care for the maternal and child health population. Welcome, Katie. Thank you.
Wow, thank you so much. I want to thank Sujay for inviting me. As Maureen said, I've been doing integration work for the MCH population for many years, and I'm going to try to sum it up in 15 minutes. So we'll see how that goes. So I'm just going to share a little bit. Happy to talk to anybody after, whenever. You can email me. So what do I do here? Do I just?
You hit the arrow button.
Should I do this on the keyboard? Here? Oh, thank you. Okay. I think we're going to start with a Slido, right? It'll come. Okay, great. All right, before we do that, I just wanted to comment on the panel earlier. The conversation, I think it was Sujay's point, like everything starts in communities and at the local level. I'm actually missing my son's 5th grade Patriot Assembly. Right now, my husband just sent me the funniest picture. He's in 5th grade, so he's got that wild hair. I don't know if you've seen 5th graders, but the boys with the hair. But it made me think about, you know, we have to, at a time where things are really uncertain and sometimes can feel grim, we have to try to focus. I think you all know this, on the good things in life. And I'm sitting here thinking, like, he's at a Patriot Assembly, just 40 minutes up the road, and he's learning about his civic duty. And so good things are still happening. We have to keep the faith. We need public health practitioners more than ever right now. So we're going to start by doing a little Slido.
Which doesn't look like it's working.
It didn't work. Okay, we don't need it to work. It's fine. One word that describes what integrating oral health care and primary care means to you. This could be into prenatal care. This could be into pediatrics. This could be into behavioral health. This could be into school-based health centers. Call them out. One word that comes to mind when you think about integration. Trust.
Total.
Trust, what?
Total.
Total.
Complex.
Complex. Really good. Others? Don't be shy.
Challenges.
Challenges.
Necessary.
Necessary. Yeah. Giselle.
Comprehensive.
Comprehensive.
Obvious.
Obvious. Complex, but obvious.
Early intervention.
Early intervention.
Needed.
Needed.
That was mine, needed.
Good. Joy.
Collaboration.
Collaboration. Awesome. All right, so some others I had written down: integrated, quality-based. We heard collaboration, coordinated, teams or team-based, interprofessional, holistic, one-stop shop. We hear that. Comprehensive and access. Awesome. All right. So I just want to start with a little bit of data. I won't bore you, but I really like this. This is these are data from the Medical Expenditures Panel Survey, or MEPS. This is the percentage of Americans enrolled in public insurance who have medical and dental visits. So I'll start with the bad news here. And that's that purple slice of the pie, that 19% of Americans with public insurance had neither a medical or a dental visit in 2019. So this is pre-COVID data. Conversely, about 30% of Americans had both a medical and a dental visit. But then look at this, 6% had only a dental visit, and 46%, the largest slice of that pie, had a medical only visit. So again, I think we can all agree on this. Primary care is a remarkable opportunity to meet patients where they are, to address oral health needs, and to help connect them to the oral health care system, right? We don't say yes. When we look at, when we break this down by age, that green slice of the pie for children 0 to 5 gets even larger. About 55% have only a medical visit for children between birth and age 5. So children have 9 medical well-child visits in the first 2 years of life. And we know that most of those children do not see a dental provider, right, in the first 2 years of life, those with public insurance in particular. So our pediatric medical professionals play a really important role. Someone said early intervention, they play a really important role in prevention, early identification, early intervention. And we see this happening across the country. I see Stacy here from the Maryland State Office of Oral Health. Rund is the leader of the fluoride varnish program here. We see this happening across the country, but it's not the norm. And there's lots of improvement that we can do there. So when we think about integration, it's things like integrating oral health risk assessment and clinical oral screenings, looking in the mouth, doing fluoride varnish applications, counseling with parents, referrals, and helping with case management to make sure that those children and pregnant women get into care. And so those are some of the services that we're trying to integrate into primary care. This is looking at some Medicaid data. This is TMSIS data from the Dental Quality Alliance, utilization data. So if we look at, this is data from 33 states that have sufficient data quality to be included. This is the percentage of children receiving any dental service in 2019. And you can see that the national average is about 51.6%, with Connecticut, Texas, Washington, and Maryland, yay, being at the higher end in the 60s. So integration can help with this, right? Integration can help with preventing oral diseases and connecting children and families with the oral healthcare system. When we look at pregnant women, the same measure who received any dental visit in 2019, it's a little worse, right? This is based on 30 states. The national average is about 20% had a dental visit. We don't know exactly what that is. That could be an emergency visit. That could be for an extraction. This is kind of the minimum, I would say. And you can see that Vermont and Maryland are kind of in the best shape in the upper 30s there. So lots of work to do. The question that we ask is, what's the story behind these numbers? Why are children and pregnant women not getting dental care? What's getting in the way? What improvements can be made? What policy changes are needed? What programs and initiatives and supports need to be implemented? And then, of course, who needs to be at the table to do this work and what resources are needed? And we know that we're kind of in a place right now where there's uncertainty and we're unsure about resources, but there's lots of improvements to be made here. Okay, so just quickly a little bit about us at the National Maternal and Child Oral Health Resource Center. We are a center that's based at Georgetown University. We provide technical assistance and evidence-based and informed resources for professionals working in states and communities to improve access and utilization of oral health care. We work with state oral health programs, state Title V programs, other state organizations, primary care association, basically anyone who's working in the maternal and child oral health space and needs support, you can reach out to us. We currently have a project called the Consortium for Oral Health. We're in the first year of a 4-year project. It's funded by HRSA through the Maternal and Child Health Bureau. Again, we provide evidence-based and informed information, and we do this primarily through technical assistance. That can be one-on-one or in small groups. But we do it mostly via learning communities and learning collaboratives, and I'll talk about that in a minute. And then we develop high quality resources and disseminate them. So I'm not going to talk about this in detail because this could be multiple days. But this is to show you that we currently support with learning collaboratives. And Maureen, I love to hear that you do quality improvement work because quality improvement is a big part of this. But we currently have 2 learning collaboratives. You can see in the dark purple there, those 8 states are funded by the Maternal and Child Health Bureau. It's a project called the MCH Improving Oral Health Integration Project, and we facilitate the learning collaborative to bring those 8 states together to learn and share. I heard reciprocal learning, to learn about the challenges they're facing, to kind of problem solve together. We were just together actually the last 2 days in Alexandria. It was wonderful. And they're all doing this integration of oral health and primary care work for the MCH population for these 4 years. They are charged with working at both the systems level, the state level, and the local level in their states. And they're working in 3 core function areas: policy and practice at both local and state, education and outreach. We just spent an entire day on oral health literacy, both organizational and personal oral health literacy. They're doing that at the local and state levels, and on data analysis and evaluation at the local and state level. The Green States are another learning collaborative that we run, and they are focused on oral health and prenatal care integration, but they're looking at it from the systems level. So they are using a tool to assess systems level capacity factors for integration, and then to prioritize those factors and do some action planning, because we know that what happens at the local level can really only go so far as what happens at the systems level. So they have to they're addressing things like workforce, Medicaid reimbursement, professional education and training, data and surveillance, all the pieces that sort of have to be in place to make integration a reality and to be able to scale it in states. So this is just to say there are 13 states actively working in this space. We want to thank the Maternal and Child Health Bureau. They've been real dedicated and supportive of integration for many years. Okay, so what I am going to talk about just for the next maybe 5 minutes is a report that we released yet last year called Integrating Oral Health Care into Primary Care, 5 Successful Longstanding Statewide Programs Providing Care for the MCH Population. And essentially what we did in collaboration with the Maternal and Child Health Oral Health Think Tank was to select 5 programs that have been doing integration work for 10, 15, 20 plus years in states. These are statewide programs. And we conducted interviews with them. The Maternal and Child Health Bureau wanted to know, what are the key elements to success for these programs? How have they been able to sustain for so long? What are their common challenges? What's unique about them? And so we engaged in interviews with them, we reviewed lots of articles and reports and supplemental program materials. These are the programs. I want to give a shout out to them. 2 from Colorado, you probably have heard of these. Into the Mouth of Babes in North Carolina, one of the very, very first programs. I Smile and Cavity Free Iowa in Iowa, from the First Tooth in Maine. Cavity Free at 3 in Colorado. And the Colorado NDI project is actually a project where they're integrating dental hygienists into primary care settings, so into pediatric offices, into prenatal care and others. So spoiler, these are the key elements for program success. This is what we heard from them was common that had to be in place: collaborative partnerships and leadership support, sustained diverse funding, a commitment to technical assistance, which includes training and evaluation. So just going to leave this up here and I'm just going to read a little bit about each one, and then I'll share some quotes from the programs, and then I'll wrap up. So in terms of collaborative partnerships and leadership support, they shared that developing and maintaining partnerships and working collaboratively with others is absolutely essential for building trusting relationships, someone said trust, and for obtaining buy-in, commitment, involvement, and support for their programs. Also essential is having organizational leaders who manage and support program activities, and that includes building and maintaining advisory groups, and who identify and sustain relationships with key stakeholders and champions in communities who will then advocate for these programs. And so what we heard from them, some of these partners are academic partners, advocacy coalitions, community-based organizations, funders, government agencies and programs, healthcare organizations and clinics, legislators, medical and oral health champions, professional associations, people with lived experience in communities, and program leaders. So we heard all of that. I feel like we've already heard a lot of that today. When it comes to sustained diverse funding, we all know this is sort of a hot topic right now. Funding for these programs comes from a variety of sources. This is not new to public health, and is key to maintaining financial viability and adapting to funding fluctuations. They talked about the importance of braided funding, so having funding from multiple sources to support their efforts, and the importance of multi-year funding. If you've ever written a one-year grant or had one-year funding, and you're just like, so multi-year funding is really critical to be able to move the needle. They talked about funding from federal, state, and philanthropic sources, as well as Medicaid reimbursement and having adequate Medicaid reimbursement for those medical providers to bring them into the fold, to attain buy-in, and to keep them engaged in oral health integration. Again, some of these programs, we're worried about Medicaid cuts in general on kind of the dental side. So that wasn't something that they were talking about, last summer, but certainly is front of mind right now. The third one there, commitment to technical assistance and training. This was something we heard from every program. It's not just about training. It's about providing implementation, assistance, and coaching. So integrating oral health care into EMRs, this is hard work, right? This is not the norm. It takes being creative and working really hard to make that happen. Billing was some of the most frequently asked questions these programs get. Like, how do we bill? How do we go about that whole aspect? They need help in that area. Regional models bubbled up. So regional models in these states to support medical practices who are trying to integrate oral health. So for example, in North Carolina, their state oral health program employs 20 public health dental hygienists throughout 10 regions across North Carolina to provide training, implementation support. In Iowa, similar. They employ 15 iSmile coordinators who are also dental hygienists, serving all 99 counties in Iowa. They're employed by local public health organizations and contracted by the Iowa Department of Health and Human Services. So technical assistance, training, referral support, case management. I want to just read one quote here. I didn't have it on the screen, but just a quote from Iowa. They said the biggest challenge that they face the biggest challenge for every local coordinator, so every hygienist who's serving in this local coordinator role, is identifying dentists to refer to, not having enough dentists for the needs of the coordinators that the coordinators identify during screenings and preventive visits is a big and ongoing problem. And the final key element is evaluation. So programs identified evaluation as key. They gather and analyze both process and outcome data for quality improvement purposes and to assess program effectiveness. Data are typically tracked on program dashboards and shared with key stakeholders and champions, legislators, health professionals, and staff, the full gamut there. However, and I think we all know this, evaluation relies on funding. It relies on staff capacity, research and evaluation expertise, and internal and external partnerships. So all of these work hand in hand. All right, couple quick quotes within collaborative partnerships and leadership support. This is from Maine, from the First Tooth. We're very lucky to have long-standing champions who have been involved since the beginning and remain involved until this day. There's a stability there that helps weather the ebbs and flows, the ups and downs, the changes in staffing, and ground that gets lost here and there. These champions are still there to keep it going and get it back on track every time. For sustained diverse funding, this is from North Carolina. It's critical for sustainability that state appropriations continue at levels that will result in Medicaid reimbursement that incentivizes medical professionals to continue to participate in the program. And this is just a little program call out when we talk about braided funding and the importance of state funding. The state legislature in Iowa contributes $1 million annually to their program. And then the iSmile program is able to draw down federal administrative claims to help support their program infrastructure. So we thought that was pretty cool. They also receive some funding from their Title V block grant and some other federal funding. Commitment to technical assistance. This is from Maine again. We've shifted our thinking over time to realize that training is necessary but not sufficient. There's more coaching happening now and a mindset shift toward implementation and not just training. And for evaluation, having an epidemiologist on staff has been critical for our program evaluation. The ability to hire someone in this position has been due to receiving oral health funding through CDC and HRSA. And finally, I just want to read one more from North Carolina about evaluation. Research expertise is the most critical resource needed for evaluation. And if the partner institution with such expertise is unable to financially support the research, funding becomes the next most important needed resource. For many years, IMB in North Carolina was fortunate to have several wonderful academic partners in their own backyard, and that was UNC School of Dentistry and the Gilling School of Public Health. So they were able to work with them, but to have that happening in an ongoing way, you do need the right people and the right resources, right? So. And that is it for me. I just want to thank the Maternal and Child Health Bureau again, and all of you, and Sujay, and this is my contact information, so happy to talk more and answer the questions. Thank you.
Thank you so much, Katie. That was great. Next up, Dr. Elias Moron is an accomplished dental public health specialist, educator, and advocate for advancing oral health equity. As an associate professor and interim director of the Master of Science program at Nova Southeastern University's College of Dental Medicine, Dr. Moron is dedicated to improving access to oral health care and addressing disparities in underserved populations. Dr. Moron earned his Doctor of Dental Surgery degree from Universidad Metropolitana in Colombia, where he also completed a specialization in health services management at Universidad del Norte. In the United States, he continued his pursuit of academic and professional excellence by earning a Master of Public Health and a Master of Health Law from Nova Southeastern University. Additionally, he specialized in dental public health at NYU Lincoln and completed advanced clinical research training at Harvard University. Dr. Moron's work has been published in peer-reviewed journals and presented at national and international conferences. He is recognized for his leadership and holds prominent positions on the board of directors for the Diverse Dental Society, the board of trustees for the Hispanic Dental Association, the board of the American Association of Hospital Dentistry, and the American Dental Association's Strategic Forecasting Committee's Direct to Dentist Action Group, where he continues to shape the future of oral health and dental education. He will be presenting today on emergency department visits for non-traumatic dental conditions, implications for public health and policy. Welcome, Dr. Moron.
So good morning. Thank you very much for this introduction. Thank you for Dr. Sujay Mehta and John Hopkins, Bloomberg School of Public Health for this invitation. So today we are going to have a conversation to talk about the use of emergency departments to treat non-traumatic dental conditions. So we will describe the case in the United States. Probably this is something happening all over the world again. So unfortunately, many people or many communities, they are going to the emergency departments as a first and last resort, looking for delayed dental treatment. Unfortunately, in the United States, every 15 seconds, according to the CDC and the American Dental Association, let me say it again, every 15 seconds, an American is looking for dental treatment at emergency departments. So why many Americans are using the emergency departments for dental care? So, okay, this is an opportunity to start describing. First, Americans are facing barriers to access to dental care. Additionally, they have a limited dental coverage and financial barriers. So many of them, they have a limited or no dental insurance coverage. And unfortunately, the Medicaid, this is the government health insurance, they have limited benefits for insurance, at this vary by states. Secondly, lack of access of dental providers. So according to HRSA, the Health Resources and Services Administration, they have identified dental health professional shortage area. So that means that there is a limited number of dentists working in relation to the population they serve. Unfortunately, in the United States, many dentists provide services in metropolitan areas, and a few dentists working in rural areas. Additionally, some people, they found difficulty scheduling timely appointments when they find a dentist or a dental home where to go. So third is we have cost. In the United States, Americans, they have to pay high out-of-pocket cost for dental treatment. Additionally, the Emergency Medical Treatment and Labor Act, EMTALA, this is a federal law that requires that emergency departments provide medical screening or examination to any individual looking for health services. So this is why many people find the emergency departments as a setting to get for dental services. Fourth, limited oral health literacy. Many Americans, they don't have awareness about preventive dental practice and the consequences of untreated dental conditions. So for this reason, getting dental services or delaying dental care becomes an issue by the time. And of course, social determinants of health, they play a role. There are many communities facing transportation challenges, languages barriers, and other factors. Additionally, emergency departments, they are offering services 24 hours a day, 7 days a week, and for the whole year. So it's available for people for immediate pain relief, unlike the dental offices, but they provide or they have limited services hours. And finally, there is an inadequate integration of dental and medical care. This is something important. So dental care is traditionally isolated from general health, leading to a fragmented care. And there are limited referrals between medical and dental professionals. So there is an economic impact of this emergency department visit for non-traumatic dental conditions. So the emergency department visit for dental conditions represent about 100% of all emergency department visits in the US. Approximately in the United States, 150 million of dental visits occur each year. Emergency department visits associated with non-traumatic dental condition can cost 3 times more than a routine dental visit. The average is about $1,887 per visit, costing the United States healthcare system, listen about it, more than $3.4 billion annually. So this is not an effective way to spend funds to pay for conditions that can be prevented. Sometimes the medical condition of the patient requires admission into the hospital, adding more cost to the healthcare system. And about 3% of these emergency department visits resulted in admission into the hospital. So thanks to Dr. Natalia Chalmers for providing this table. In this table, I just wanted to show for self-pay, the person who are visiting the emergency departments looking for treatment, for dental treatment. So poor oral health is listed in the top 10 first diagnoses among treat and release emergency department visits in 2018. Another situation that we are facing with ER visits for dental conditions is many Americans, when they visit the dental departments, they don't have enough equipment, they don't have the proper staff or dentists to provide dental services, they don't have the dental supplies. So most of the people, they are treated and released. They prescribe antibiotics and painkillers, in most cases, opioids. So now in these graphs from the National Center for Health Statistic reports in 2020, we can see that the high percent of the visits that they are prescribed opioids is very high, and this is contributing for the opioids epidemic that we have in the country. So who uses the emergency departments for non-traumatic dental conditions? So these visits are more common among females, non-Hispanic African Americans, people living in rural areas, individual residing in the lowest income communities. And the highest rate of these visits is in the age group 25 to 34 years of age. Most of the visits are covered or are expected to be paid by public funding, particularly Medicaid. And the southern United States, they have the higher proportion of these emergency department visits for non-traumatic dental conditions. So in this map, we can see the rate of emergency department visits per 100,000 adults beneficiary by state in 2019. So we can see that we have more emergency department. The rate is higher in the East Coast of the United States, especially in the South. The three most commonly recorded primary diagnoses for emergency department visits for non-traumatic dental conditions are other specified disorder of teeth and supported structures. This is according to the International Classification of Diseases, the 10th edition. The second most common is periapical abscess without sinus tract. And the third one is dental caries, unspecified. So we can see this is something that can be prevented. And this is not an effective way to spend public funding. So this slide captures the multifaceted consequences of relying on emergency department for dental care. So it's not just about inconvenience, it's a matter of cost, fairness, safety, and health outcomes. From fiscal waste and inequity to risks of opioid overuse and even mortality. So these visits to the emergency departments reflect a breakdown in our health system. So a call to action for an integrated, accessible dental care. So there are some implications of these services, of these visits for public health and policy. So we have health disparities in access to dental care, as we already discussed. There is a need for a better integration between medical and dental services. So the solutions requires a multi-level approach. First, I think we can expand the Medicaid services or to dental services to adults we can integrate dental care into a broader healthcare system with more funding in prevention, education, and community-based programs. And we need more data collection, more surveillance, and research to inform and educate our policymakers and our community in general. In conclusion, emergency department visits for non-traumatic dental condition reflects systemic failures. It's not an isolated emergency. These visits are costly, ineffective, and contribute to a broader health system burden. Unfortunately, vulnerable populations with low income, living in rural areas, communities that belong to minority groups are disproportionately affected. Improving access to preventive dental care is not only fiscally responsible, listen, it saves lives. A high number of emergency department visits for non-traumatic dental conditions, as already mentioned, includes potentially preventable and manageable diseases as a dental carriers that they can be treated with early intervention. So thank you very much. Here you can find the if you have more questions, if you want more information, so you can please contact me. Thank you.
Thank you so much, Dr. Moron. I have to say, as a background in emergency medicine, I can vouch for all of that. It feels real. So I got a few questions for him after too, maybe. So next up, Dr. Cervantes is an assistant professor in the Division of Nephrology and with specific interest in quality improvement in medical education. Dr. Cervantes was selected for the 2024 ISN Emerging Leaders Program, Cohort 3, and for the 2024 Armstrong Institute of Leadership, reflecting her dedication to improving the quality of care at a local and global level. She is also actively contributing to the Johns Hopkins Amyloid Center since 2022. In medical education, she co-directs the Genes to Society Renal Physiology course since 2021 and is assistant program director for career pathway development for the fellowship program since 2022. She'll be presenting on bone health, nephrology, and the mouth. Welcome, thank you.
Hi, everybody. Thank you very much for having me here. Yeah, I'm going to be speaking about nephrology and the mouth. We're switching gears more to a clinical topic, and this is an opening question, right? Can your gums and jawbone provide clues about kidney disease? And I don't expect answers from you because admittedly, as kidney doctors, we don't ask patients what is happening in their mouths, right? And people are wearing masks nowadays. I mean, we don't know what is going on there. But the purpose of my talk will be to understand the relationship between chronic kidney disease and mineral bone disorder. We call this CKD-MBD. And we're going to review some of the oral manifestations of this disorder. And I will start with some pathophysiology, right? Explaining a little bit here about what happens with the kidneys. And the kidneys take care of many functions, but one of those is to regulate the electrolytes. And there are two electrolytes that are really important for bone health, phosphorus and calcium. Phosphorus, phosphorus, we basically eat phosphorus from our diet. It is absorbed in our gastrointestinal tract. And the kidneys have to deal with this load of phosphorus and excrete it in the urine. The other thing the kidneys do, and I apologize, I think some of the text is off the boxes, but the other role of the kidneys is to activate vitamin D. And in this way, they will maintain the levels of calcium in the blood. So what happens with kidney disease is that when we have less kidney mass, we have an increase in phosphorus levels and a decrease in calcium levels in the blood. And as a result of that, we have some hormones that activate to balance this out. One of those is the parathyroid hormone. it will go ahead and stimulate bone resorption, and in that way, it increases calcium levels in the blood. It also increases phosphorus. That's not intended, though. And the other hormone is the fibroblast growth factor 23 or FGF23. This hormone actually increases the excretion of phosphorus in the urine. And I certainly don't expect all of you to remember these, but I just want you all to appreciate the complexity of these axes and knowing all the organs that are involved in regulating these. And the two hormones that will be affected are, again, the PTH and FGF23. Interestingly, these FGF23 starts increasing even at very early stages of kidney disease. So you will see there we have a total of 5 stages of kidney disease, and then we have end stage when people need dialysis. And these FGF23 starts increasing between stages 1 and 2, so very early on. On the other hand, clinically, we identify CKD and BMD when patients have more advanced stages. We start seeing an increase in this parathyroid hormone, an increase in phosphorus, or a decrease in calcium level. And this happens mainly when the GFR, which is a marker of kidney function, drops below 45 to 50. So these will represent the stage 3B or above. So what do we do in clinical practice? Well, we as kidney doctors are monitoring these markers, PTH, calcium, phosphorus. We follow the trends, not the individual levels. FGF23 is rarely measured. It's very expensive, and we don't know really how that is going to inform practice. Even if the level is elevated, we don't know what to do with that. One of the challenges is that in patients that are not on dialysis, we don't know what the right PTH target is. So we have an abnormal number, and then we're like, okay, let's normalize the calcium, let's normalize the phosphorus, but for the PTH, we're just following that trend. For patients on dialysis, we do have more data. The goal for PTH is 2 to 9 times the upper limit of normal, which is around 150 to 600 picograms per milliliter. And we do have other markers of bone turnover besides the PTH, but we don't always use it in clinical settings. This is the alkaline phosphatase, and it can also be ordered a specific level called the bone-specific alkaline phosphatase. So this is how we are monitoring the health of the bones in our patients. And then how do we treat? Right? If there is an abnormality with phosphorus, we counsel our patients in low phosphorus diets. We can start phosphorus binders and start a medication. This is a new one called tenapanor that increases the excretion of phosphorus in the stools. If the calcium is a problem, we give vitamin D, and ideally 125 vitamin D, which is the active form. There are a group of medications called calcium mimetics, which basically trick the parathyroid gland so that this parathyroid level can decrease. And if this is not enough, we have to refer our patients for surgery, for removal of their parathyroid glands. And we're going to see why that is so important, right? Because this constant stimulation of the bones is weakening the bones, right? And we'll see some examples of that. So at the level of the bones, there are 3 key areas that are affected. The main one is the bone turnover. The other ones are mineralization and volume. And they can be affected in several ways. So just, again, more so to appreciate the complexity of how the relationship between all these aspects can give us different conditions. And I want to draw your attention mainly to this condition called osteitis fibrosa, which is represented by that purple tall bar at the back. We can see that this is a high bone turnover condition with normal mineralization and increased bone volume. So basically, patients will have an enlargement of their bones. And on the opposite, we have a low bone turnover state with low bone volume, which is a dynamic bone disease. And these are just some histologic pictures. We're a little bit, behind in time, so I will just move forward with this, but just want you to appreciate that this is a normal structure of the bone, and this is how bad it can become like a dynamic bone disease. There is complete loss of the structure of the bone and loss of cells there. So these problems can start early. And as I mentioned, bone turnover is the main area affected. The subperiosteum of the bone can be affected in all bones. And while we see osteoporosis in our patients, really it's the turnover what we are looking after. And the two markers that we've spoken about are the parathyroid hormone and alkaline phosphatase. These are good tools to differentiate between high and low bone turnover states. DEXA scans, these are bone scans, but they are used to evaluate risk of fractures, not to evaluate bone turnover. So why am I speaking so much about bone, right? As you all know, and you know this better than me, the oral manifestations of CKD and BD can affect the bone, the mandible. And these, the jaws are the most commonly affected area. The alveolar bone that supports the teeth can be affected as well. There is not a lot of data, right, between the link in kidney disease and what is happening at the level of the mouth. But from this retrospective study of 21 adults in Brazil, we could see that they reported half of those patients with a condition called brown tumor of hyperparathyroidism. And you can see in the pictures that there is basically a mass that a patient had in the gums. In the other one, they do an X-ray, and this is like a hyperlucent image. These are the masses that they are developing in their mouths. Remember, I mentioned osteitis fibrosa, this condition where it's very high bone turnover, and then the bones actually sort of grow, they become bigger. So that is also very frequent. It's happening roughly half of the patients. And this happens even at very early ages. This was at mean age of 33 years. As I said, the mandible was the most affected site. These are some pictures. You can see that there is, they call it swelling, but there is a growth of basically mucosa and bone. You can see that the mandible is bigger, the palate, and also right and left sides are bigger. And this is, again, manifestations of osteitis fibrosa. There's growth of bone happening in their mouths. From a radiologic standpoint, you could appreciate the ground glass appearance of both jaws. It's almost like a salt and pepper appearance here in the top figure. And this is a coronal CT scan. Some bones go through this, again, high bone turnover and start also getting sort of destroyed. And there is almost a complete absence of the bones in the nose that you can see in the CT scan in the lower pictures. In the picture of this patient, the bones grew, and you can observe in the lateral view that the face is almost protruding, right? It definitely changed the facial features of this patient. And another example that was quite impressive is this man that you can see that on presentation, his face is looking normal. His mouth, it's relatively okay, but 13 years into the disease, his facial features have changed significantly, and even there's significant space between his teeth and a lot of facial changes. So this is this condition, right? The extreme of the osteitis fibrosa affecting the mouth and the face it has been called Sagliker syndrome. Something, as I said, admittedly, I never knew about, but now I'm like definitely going to be more intentional in telling my patients to seek oral health. So I spoke a lot about the bones, but certainly there are many other conditions that affect our patients. Caries, missing feeling, erosions, hypomineralization, and most common ones being really tongue abnormalities and poor oral hygiene. And children are among the really most affected ones. We have a population of children that also develop chronic kidney disease. And as you know, they are in that stage of growth and bones are more vulnerable to these damages. So we have just descriptions of developmental defects of the enamel, as you can see in that picture, and the x-ray showing that it's affecting all the surface of those molars. But several other conditions have been described, like tooth staining, bad odor of the mouth, bad taste, etc. So this is to summarize. chronic kidney disease and mineral bone disorder really involves many organs, the kidneys, the gastrointestinal system, parathyroid glands, and the bone. We're monitoring trends in parathyroid hormone, alkaline phosphatase, and these two electrolytes, calcium and phosphate, to assess the progression. The bone abnormalities are mainly involving the bone turnover, and we have additional effects of mineralization and volume. And really the jaw and the alveolar bone, which is supporting the teeth, can be affected. The prevalence, we don't know, because it is something that is underreported. Yeah, thank you very much.
Do you guys want to come up when we have about 5 minutes for questions, if anybody has any questions? And I think.
Yeah, they're hungry.
Oh, no, they got.
Do we have any questions?
At the end of.
So I'll start with one around return on investment. So I'm hearing a lot of talk about funding and under resources. And then we're also in juxtaposition seeing the cost that this is having on the effect of the systems. I'm just curious in terms of evaluation and, you know, of course you need the funding to evaluate.
Right.
But certainly like, you know, from an ED and the maternal care kind of program position, is there return on investment kind of built into the arguments for additional support or resources to be built?
I would say, I'm trying to remember the 5 programs, but I would say, North Carolina, Into the Mouth of Babes, has the most research, and they may have some, it's a little bit dated at this point because of some of those issues around funding and having research expertise. But in their early years, they were able to do more research studies and publish on this. And I'm not sure if there's return on investment, but I can check. And if anyone, I can kind of get back, or if you want to check that report. In the report, I also just want to mention there's individual program spotlights. So if you're interested in learning more about those individual programs, their evaluation methodology, specific measures, some of those research studies that have been done in the past, they're all in that report. And that's the link to that is in my presentation. That's a really good point. I'm not sure, but I would say, if any, it's probably North Carolina.
Okay, great.
Yeah.
Yeah, it's something I'm personally trying to work on, to be more consistent with. So I'm hearing the impact that might have on some of the programs. So that's great. Any other questions? Yeah. I think so, yeah.
You can yell it and then you'll have to repeat it for the Zoom crowd.
Okay.
So my question is actually regarding the data for emergency room visits. Has there been, and we've been seeing this data for a really long time now across the country, has there been any movement in terms of using that data to inform the creation of dental departments within emergency rooms?
Yes,
The question, let me just repeat the question real quick. The question is, given the data for emergency medicine use or department use for non-traumatic dental care, are there any clinics that could be built into the EDs to help support that workflow?
Yes, thank you for your question. Yes, this has been a problem for several decades. I think we are fortunate because there are available some databases and this information is allowed. There is the nationwide emergency department sample. You can purchase the data if you are interested to do research about this topic. Additionally, there is another one. It's called the National Hospital Ambulatory Medical Care Survey. So these databases, they cover more than 90% of the hospitals around the country. They do not include the federal hospitals. They do not include the psychiatric hospital. but they will provide probably a sample size of more than 150 million emergency department visits, depending per year. And you can use the ICD-10 codes for non-traumatic dental conditions and isolate the diagnosis related to non-traumatic dental condition. The data is available. Additionally, the STDD it has a classification for non-traumatic dental condition. You can use those codes or diagnoses and extract the information from the databases. The only challenge is that each year is about $750, and you can purchase the databases from the government. It's available for research to everybody. Thank you.
A follow-up question or comment from Dr. Ellis' question or comment. Have you seen, when you talk about return on investment and things of that nature, specifically related to emergency department utilization, are you aware of any health systems or interventions that have been successful in demonstrating a potential return on investment as far as including oral health care services, even somewhat comprehensively within health systems? Because for me, that's been a personal challenge of mine. And I think that's one of the great things as far as kind of accomplishing what we're trying to accomplish.
Yeah, the question is there any return on investment kind of work around integrating dental services in the hospitals?
Or even just a streamlined referral system.
Or referral systems, okay.
Yeah.
Yes, thank you. I'm going to chime in. Thank you for your question. My answer is yes. I think all healthcare professionals can play a role in reducing the burden of oral diseases. All of you guys can play a role. Let me give you some examples. In the United States, there are some states implementing a school-based program. In rural areas, for example, school nurses who already provide clinical services at the schools, they can be trained to provide oral screenings, oral health education, and they can refer children they find in need of further treatment or comprehensive dental evaluation to a dentist. So this is just one example. So when they identify the cases early with early intervention, and we can provide prevention. Of course, every child or every adult that we provide early intervention, early treatment, of course, we will be contributing to reduce the rates of emergency department visits for non-traumatic dental conditions. Thank you.
Can I add one thing to that? Most of the work that we've done has been with federally qualified health centers, community health centers, but Wisconsin, I know, has been doing some integration work in large health systems, so I can connect you with them. I think they're paving the way. One of the things that's paving the way with, in addition to community health centers, that's a common pilot site, they're doing some work with large health systems, so happy to connect you there. I also wanted I looked real quickly about Into the Mouth of Babes in North Carolina. They did do some evaluation or some research, and this is what they found. For children receiving 4 or more Into the Mouth of Babes visits before age 3, there was a 21% reduction in hospitalizations for dental treatment. So that is there. The study was cost effectiveness of preventive oral health care in medical offices for young Medicaid enrollees. So 2012, but if you want to kind of read it and look at their methodology, maybe it could be repeated.
Thank you.
Yeah,
that's great. Thanks, Brenda. The last question, because I know we're just about at lunchtime. But Dr. Cervantes just wanted to follow up kind of in line with that multidisciplinary approach. If you had any recommendations for us about how healthcare providers, especially dentists and other oral health experts, can collaborate with nephrologists and endocrinologists and other folks to help build that comprehensive plan, for this population and, kind of be able to replicate that hopefully for. Okay.
Yeah, thank you very much. I think the first step would be education, right? And it's kind of like low hanging fruit, but again, as physicians, many of us, if we are not, that's not the area we're caring for, sometimes we just tend to, we don't look there really. And in medicine, I think many of us just don't ask about the mouth, and we don't know what to expect, right? What abnormalities are expected in the mouth. So that's what I said. I mean, working on these, I was like, wow, I mean, I wonder how many of my patients have brown tumors in their mouths, right? And I know that what I showed are probably extremes of patients that are not treated at all. But I think that starting with some educational initiatives of, even if they are in the forms of handouts or things like that, that can be shared with different specialties, and maybe emphasizing this link, right? Your patients with kidney disease can get these. Patients with diabetes, these are the most common, manifestations. And that, I think, creates that little awareness. And we may ask a final question, right? At the end of the encounter, by the way, did you see your dentist? And just don't forget that, right? So I think that that can be a good first step.
Great,
Yeah.
thank you.
Thank you.
All right, well, there is a bulletin board for more questions. If you have any other questions, I think it's time for lunch. Is that right? Did you want to ask one more?
No, just a follow up for your question. I think there is, I can't remember, there are studies that link the reduction of the ER visits with the including of more benefits for the adults and the kids. So that I think it's at the state level. So how if we include more benefits for adults, that will decrease eventually the ER visits. Yeah.
Great, thank you. All right, well, thank you.
Okay, I think so. We're going to break for lunch. For those of you in the Zoom room, let's meet back here at, well, our Baltimore, or what I like to say, Hopkins time, 12:45. Sorry, Zoomers. Who's yapping away? You couldn't hear me. Thank you for participating on the online discussions and Slido. We were talking about some breakout groups and such. Hopefully after this, there's the right answer.
Yeah.
There you go. So yeah, unfortunately, Johns Hopkins does not have a dental school. This is part of the problem that we don't have an oral health component at the School of Public Health. That is part of the dream. And that was probably a question that for technological reasons, unfortunately, did not happen at the beginning. Very good. Thank you for entertaining me with that.
Oh,
All right. Let's see. I think this is our surprise guest.
Hi, my name is Eric Sung. I am here as a part of Special Care Dentistry Association, the affiliate of American Association of Hospital Dentists, and of course UCLA Dentistry. I want to thank Dr. Mehta for inviting me to the 2025 Global Oral Health Symposium and advancing the global oral health agenda. When we look at the oral cavity, as a part of hospital dentistry and a CDA, I view it as something that's inseparable with the systemic health. When we look at the general patient population in the US, approximately 50% of patients who are in the age of 18 to 44 are on at least one prescription medication. Of course, as you age to greater than 65, nearly 90% or more are on prescription medications. If you look at the overall health of individuals, again, if you look at the general population, a significant population have at least one serious health condition. And obviously, the younger you are, the less likely you are to have it. But as you age, the number of serious health conditions significantly increases. And if you look at the overall health of individuals and the cause of mortality, whether it's in the US or the world, the number one cause of mortality is heart disease. And the second one is cancer. When you look at these conditions, it's almost inseparable. The reason I say it's inseparable from the patient because it has to do with the amount of time that one is diagnosed with some form of heart disease until the cause of death. And same thing with cancer. Cancer therapy has advanced so much over the years that treatments may prolong a person's overall health for years. The benefits of integrations is, it's significant because it improves patient outcomes. And as we all know already, as an oral health care provider, that oral health affects systemic health. We know through lots and lots of literature that bacteria and inflammation enters the bloodstream and spreads to other parts of the body, leading to inflammation and infections throughout the body. Periodontal disease and cardiovascular disease are well connected. Research suggests a significant link between periodontal disease and an increased risk of cardiovascular disease, including heart attack and strokes. Others also discuss an increased risk of dementia, Alzheimer's disease. Diabetes is well known to impact oral health. People with diabetes, especially those who are poorly controlled, are much more prone to oral infections. And conversely, oral infections can exacerbate diabetes. In respiratory infections, the oral bacteria can be aspirated into lungs, leading to respiratory infections such as pneumonia. This is extremely well documented, especially in those who are debilitated or in the hospital setting. Whether they're intubated or not, the risk of aspiration pneumonia goes tremendously higher. The systemic health also affects the oral health. As we well know, nutritional deficiencies, such as deficient in vitamins and minerals, such as vitamin D and calcium, can affect oral health, leading to tooth decay and gum disease. Or hormonal changes, specifically fluctuations during pregnancy, menopause, or puberty, can affect oral health, leading to changes in gum texture and increased risk of oral infections. Medications and oral health, as we well know, a lot of medications such as antidepressants, antihistamines, and decongestants can have side effects, specifically dry mouth, which leads to significant tooth decay and gum disease. Certain systemic diseases such as leukemia, lymphoma, HIV, AIDS can also have oral manifestations, including oral lesions as seen in the picture below, and infections. So without say, there is a profound interconnection between oral and systemic health, with oral health influencing overall health and vice versa, emphasizing the importance of holistic care and interdisciplinary collaboration to prevent, diagnose, and manage disease. Again, I want to thank you very much for having me.
Well, thank you, Dr. Sung from UCLA. I did my residency at UCLA, and Dr. Sung was one of my former teachers and attending, so I'm really massively appreciative of him participating in this. I would like to now call to the stage the moderator for our next kind of panel, the State of the Nation, Dr. Irini Hanna from the Johns Hopkins University Department of Otolaryngology, the dental clinic here. She's a clinical instructor through the Department of Otolaryngology, Head and Neck Surgery, Division of Dentistry, and Oral and Maxillofacial Surgery at the Johns Hopkins University School of Medicine. Local trained University of Maryland and University of Maryland School of Dentistry and Johns Hopkins University resident. Dr. Hanna, the stage is yours. Thank you for coming.
Thank you, everyone. It's a pleasure to moderate this the State of the Union. So the next talk is about from state to global perspectives, and we're going to talk about the state of oral health. And I would like to first introduce our first speaker, Dr. Debony Hughes, who is a native of Lynchburg, Virginia, and a graduate of the Howard University College of Dentistry. After graduation, Dr. Hughes completed her advanced education general dentistry program also at Howard University. And she currently serves as the dental director for the State of Maryland's Department of Health, Office of Oral Health. Dr. Hughes' interest in public health that began early in her career while living in Vermont. That interest continued as she was the dental director at the Prince George's County Health Department for many, many years. Dr. Hughes sits on several boards of organizations helping to improve the lives of Marylanders, and she co-chaired the Maryland Oral Health Care Task Force, legislatively charged with finding barriers to obtaining dental care and coming up with solutions to eliminate such barriers. That task force legislation passed during the 2023 session and is helping to improve access to various aspects of dental care. So please welcome Dr. Hughes.
These errors. Okay, great, thank you. Hello, everyone. And welcome back from lunch. And I must say that the state of Maryland is optimistic. We feel optimistic about where we are and where we've come from. And if you have to be to work in this field, and especially what is going on in these times. So I'm pleased to be here to talk about Maryland's journey. And I cannot talk about any story of Maryland's progression without talking about Diamante Driver. It is a story that we must always remember, and a story that we must continue to tell. When Diamante Driver died, I was the dental director at the Prince George's County Health Department. And we were all in a state of shock, sadness, a mixed bag of emotions, saying, how could this possibly happen in our state? But it did, and Maryland took action. I was so pleased to see Mary Otto here today. Mary Otto was the journalist that basically broke this story and brought it to the attention of the state and the nation and the world. She became the dental champion for this family and for oral health, and particularly in this state. So fortunately, Maryland took action. The Secretary of Health at the time developed the Dental Action Committee. So the Dental Action Committee was comprised of stakeholders from across the state, and everyone that needed to be at the table had a seat at the table. There were conversations and meetings, and out of those meetings and conversations came 7 recommendations. So, fortunately, those conversations and recommendations were not in vain. Out of the 7, 6 of them we can check off. Number 5, looking at school-based oral health screenings, we're still working on that. There have been several attempts at getting these screenings implemented in Maryland, but it is something that is in the thought process and something that we're still working on. So we have these recommendations now. So what's going to happen? The thought was we need an organization that's going to help implement and get these recommendations going to help the Office of Oral Health. And as a result, the Maryland Dental Action Coalition was established. Today, MDAC, as we fondly call it, is one of the strongest oral health coalitions in the nation and a very valued partner of the Office of Oral Health. And I'm going to take this opportunity to share with you that MDAC has been selected by the American Association of Public Health Dentistry as the 2025 recipient of the National Public of the National Public Service Award. And this award recognizes contributions to active creating to public administration. Sometimes, Mary, you can hear it. I'm sure you didn't want me to do that, but I did it. So it was a new day for oral health in Maryland. A single Medicaid dental administrator was named, Maryland Healthy Smiles. And with this came an increase in both participation for patients and providers. And today, you may hear me say, it's not perfect, but it is progress. We have about a third of the licensed providers in Maryland who now participate in Maryland Healthy Smiles. So again, it's not perfect, but we're making progress. And with these recommendations, a safety net of dental services was created. On the 24 counties in Maryland, each county has some oral health resource. If they don't have a physical dental clinic, they have other means of creating access for residents in those counties. So a county that doesn't have a physical dental clinic may have an oral health education component or a referral process that will allow this type of access. And then also the Public Health Dental Hygiene Act was passed, which allows dental hygienists to go in certain facilities without direct dental supervision. And next, our oral health literacy campaign was created, Healthy Teeth, Healthy Kids. And it was launched to educate parents. And so, if our patients don't understand, then we can't expect them to be compliant. So this is a campaign that was created, and fortunately, we are still utilizing this campaign. And the medical dental collaboration that was one of the recommendations created Maryland's Mouth Matters, which is a fluoride varnish program in which fluoride varnish applications are applied in pediatric offices for children up to age 5. And from the inception of the program, over 300,000 fluoride varnish applications have been applied to date. So along with these recommendations, the Office of Oral Health started to receive federal funding. And as I say that, I'm holding my breath.
It's gone. Gonna run out of breath.
From the Centers for Disease Control and from HRSA. And as a result, we've been able to implement programs that have improved access for Marylanders. And I will go into detail about one of those specific programs a little later. So these are some of the programs that the Office of Oral Health has been able to create and implement. There's so many, and I don't have time to go through all of them in detail, but if you are interested in the details of any of these programs, please feel free to visit our website. And also, we're always available. We love to talk about what we're doing and to share. So yes, I just wanted to let you know, these are some of the things that we're doing. And I show this slide for comparison to show that the state has made an investment in oral health. The org chart on your left is prior to Diamante Driver's, at the time of his death. And the org chart to the right is what currently exists. And I want to take this opportunity to introduce the best team you could possibly have. If you all would please stand up and be recognized. Many of you have worked with him. Please stand up. Many of you have worked with them and you know their passion for oral health and the things and the programs that they work on and implement, and it is indeed a pleasure. And they make me look good, so I thank you. And yay, we have Medicaid dental coverage for adults. So please, a round of applause. You know, Mary talked about this, she mentioned this earlier today, but it was a major effort. You know, we were on a list, we were at the bottom of the list, and we had to come off that list. And a bill was passed and it was signed, and what this does is provide dental coverage for over 800,000 adults. It includes, these are the procedures that it includes, and once again, I'm gonna say, it's not perfect, but it's progress. And so I wanted to include the numbers for each year that it's been working, and you can see that our unique members are increasing. So it's working, and also the number of providers that are participating, it's increasing. So it is working. So the task force on oral health in Maryland. In 2022, it was decided, let's look at, it's time to review what's going on in Maryland. Let's look at what the access issues are. And let's convene a group again. So there was, it felt somewhat like the Dental Action Committee. A group of stakeholders from across the state. Again, everyone that needed to be at the table had a seat at the table. And there were conversations, there were subcommittees that looked at special populations, and from that, recommendations were made. So House Bill 290 was passed in 2024. And what that bill, based on conversations from the Oral Health Task Force, it required that annual evaluation of Medicaid dental reimbursement rates to create and distribute specified plain language materials, and to convene a work group to look at a grant or no interest loan program for providers who want to work in rural areas, and conduct a study on dental provider participation in Medicaid, and also to conduct a study to look at reimbursement for community health workers. And one other thing the bill did was to modify our current dent care program, which is the loan repayment for dentists. So prior to this bill, the program funded 5 dentists at approximately $25,000 a year for a 3-year commitment. After this bill passed, the modification has allowed us to increase the number of dentists being reimbursed to 8 at $50,000 a year with a 3-year commitment, and also to add a dental hygiene cohort at $10,000 a year for a 2-year commitment, which we're very pleased with. And the last thing that this bill requires is that the State Board of Dental Examiners publish a list of mobile portable dental service providers. So this is one of the programs that I wanted to talk about that we are federally funded to address the workforce shortage. You know, workforce shortage is not only a Maryland state problem, it's a national problem. So the grant specifically has us to work in our specified dental HIPSA shortage areas, which are Baltimore City, Eastern Shore, and Western Maryland. So we call it Pathways to Bright Futures. It is a pathways project that identifies high school students who are interested in the field or also who may not know that they're interested in the field. And we provide educational opportunities for these students in these specific areas. Again, Baltimore City, the Eastern Shore, and Western Maryland. So these are the components of the program. We have presentations in the high schools, exponential learning opportunities, seminars for dental students at the University of Maryland School of Dentistry, scholarship awards for students who show interest in working in these shortage areas. And we also provide scholarships for students who want to take the DAT because we understand that the cost can be a deterrent just to take the test. And to recognize these students for their achievements, we have an annual event at the National Museum of Dentistry. And we also plan to launch a communication and social media campaign to make students aware of the opportunities in dentistry. So this is a picture I wanted to share. These are our regional oral health coordinators. So we have one that is designated to each of the areas, Baltimore City and Western Maryland and Eastern Shore. They go out, they are our contacts for these students. They go out to the high schools and make the presentations and then determine the interests of these students and connect them to experiential learning opportunities. And this is one of our experiential learning opportunities. We work with an organization called Planet Smiles, who brings actual dental equipment to a location and allows students to see and actually operate and touch some of the instruments that are used in procedures. And it's really exciting for the students to see these things. And as I mentioned, seminars for dental students at the dental school. So we ask volunteers, clinicians who work in these types of areas to come to the school to talk about what it's like to practice in a rural area. And what type of, give them, basic facts of what it's like to live there, to practice there, what it's like to be in the community. Because a lot of times, most people are interested in just working in urban areas. And then lastly, this is our first launch of the scholarship award program we had at the museum. It was held last year, and it gives the students an opportunity to come and be recognized for their accomplishments and also to visit the beautiful museum. So these are some of the outreach impacts of our project. We're always looking for more help, more experiential learning sites. So we welcome any thoughts that you may have on our project of how we can make it better or how we can reach more students to be interested in working in these shortage areas. And this is the campaign, the communications campaign that we plan on launching in the fall. As I said, we want to be able to reach more students and give them the opportunity to understand what resources are available for them and in the profession. So this is Maryland's journey. Did I keep my time? Am I good? Yeah. So there's so much to explore in what we're doing. And, the work is far from being done. So and there's so many individuals and organizations that have gotten us to this point, and I know that we will continue to. So I welcome your participation, your thoughts, and thank you for listening to Maryland's story.
Awesome. That was great, Dr. Hughes. Thank you for all that. And big kudos to you and your team for all that you've done in Maryland throughout the years. All right, next we have Dr. Heather Taylor, who is a health services and policy researcher with a clinical background in dental hygiene. She is a tenure track assistant professor at the Indiana University Fairbanks School of Public Health and an affiliated research scientist at the Rudenstreif Institute. Through her research, she aims to bridge policy and practice, advance oral and overall health, and ensure evidence-based solutions to drive meaningful healthcare improvements for vulnerable communities. Welcome. Thank you for coming.
Just the keyboard. Okay, thank you. Okay, I'm going to talk to you today about access and outcomes, and I'm going to try and tie some US lessons learned in oral health policy to how they might impact global communities. A little bit more about myself. I am a dental hygienist. I worked in private practice before getting asked to start teaching at the School of Dentistry in Indiana. And I taught dental radiology and also worked in dental public health. So I had boots on the ground. We went and did underserved populations in schools, provided sealants, preventive care, that sort of thing. And it was in that stark contrast to what I experienced in private practice and the patients I saw on boots on the ground who didn't have access to care that led me into, I need to go upstream more and get into policy. And so I pursued my doctoral degree, and I'm very glad I did that. So what can the global community learn from US oral health policy? Well, I think it's important to start off with the way I sort of teach my master's in public health students about our healthcare system. And I know there are some individuals here who are not from the US, so it's important to kind of give you the context of our healthcare system and how we operate. And so our healthcare system has been described as a behemoth. And this is because there is no centralized system that oversees all of healthcare in the United States. And so I apologize for how fuzzy this is. I scanned it in from a book, but all these stakeholders are trying to wrangle cost, quality, and access in our US healthcare system. But with no centralized oversight, it becomes impossible for any one of these single entities to try and do that. And what also it means is that there is not universal healthcare coverage offered to our patients and our populations. And that means people in our society certain populations do not have access to care. And that cost and quality varies depending on what your socioeconomic status is and where you fall in the system for access to care. Here's another complicated graph to describe our US healthcare system. This one is describing how we finance our US healthcare system. And no matter what pathway you look at, ultimately, healthcare is funded by the US citizen in one form or fashion. Now, the government does offer some programs through public health insurance. I don't know if you can see my mouse, doesn't look like you can, but up here in the upper right corner is where we get two types of programs. Perhaps you are familiar with them, Medicare and Medicaid. These are our public health insurance programs. And it is primarily through these levers that you see perhaps the most health policy action happening and advocacy. And this is I'm going to start kind of honing down on the complexity of our US healthcare system into these buckets. Now, before I get into policy a little bit more, it's so important for us to understand the systemic structural systems that these policies operate within. And so how has the US conceptualized oral health in the United States? Like this. This doesn't exist. And they're entirely fragmented. And medical care does talk about fragmentation, but perhaps there's no greater chasm in our system than the separation of the mouth from the body. And to push a little bit, I'm going to be a little bit generate Sujay here. This is how John Hopkins conceptualizes oral health. And so what is happening? From the very beginning, we educate these providers entirely separate. Unlike other fields, you do not learn dentistry alongside medical professionals and then branch off into the specialty of dentistry. No, you have separate anatomy and physiology classes, separate pharmacology classes, everything is separate. So from the very beginning, we're telling our professionals, we're different. We don't need to talk to them, and they won't talk to us. We also have separate financing systems. Do you have a medical insurance card and a dental insurance card? You betcha you do. And medical insurance is not the same as dental insurance. Dental insurance has been described as a dental discount plan. It's very different things happening. So we finance it different, we educate different, and finally, the infrastructure is different. Dentists are rarely part of these large healthcare systems. They have their own clinics, perhaps still solo dentists, group practices, but entirely separate. They have entirely separate electronic records on the same mutual patient. And so what's the downstream impact of this systemic structural system? Beyond lack of care coordination, beyond lack of an understanding of what each of our providers can do, well, actually, doesn't it perpetuate to our patients? Don't you see them undervaluing their oral health because of the way our system has structured things? They don't understand how important oral health is because of the way our systems don't talk to each other. All right, going back to policy. So that's our structure. Let's talk about the levers that we operate policy within Medicare and Medicaid. Guess what? It gets super complicated from here too. I'm not really going to spend a lot of time in Medicare, but there's type A, type B, type C, type D. And if you have traditional medical care, Medicare, your access to dental care is extremely limited. It is only if it's considered medically necessary, will they cover it. If you have Medicare Advantage, all the plans are different depending on the private insurer that is overseeing your Medicare Advantage plan. So that's complicated in and of itself. Medicare covers your 65 years and older, your elderly, and certain people with disabilities. Then we have Medicaid, and this covers, your low-income populations, children, those who are disabled. And I'd like to say that this is maybe a little bit more easy to understand, but at the adult level, it varies tremendously depending on where you live in the United States. And so dental coverage could be very comprehensive, might be covering a lot of services for certain states, or you could live in a state that offers limited services. And so less than 100 of the 600 plus dental services that are out there, emergency only services in some states, and some states offer no coverage whatsoever for their low income adults. All right, so now given this sort of structure, now that you understand where the US environment is, let's return to this question about what can the global community learn from us? Well, even though we are considered a developed high-income country, the truth is, just like we see in the global community, our low-income populations do suffer the greatest burden of oral diseases. And I would argue that in the United States, I think the population that is suffering the most is our young adults or our non-elderly adults, ages 20 to 64. They have the least access to care in our system. Now, this problem of not really focusing on oral health has devastating impacts. We've heard from the previous guest speaker about how it's tied to systemic health, but it's even more broad than that. It affects people's physical, psychosocial, and general well-being. And something I haven't quite heard yet, but I really want to highlight is its impact on mental health. So there is some evidence to suggest that there are correlations between systemic health, cardiovascular disease, diabetes, but there's actually causal evidence to suggest that tooth loss causally is related to depression. And we have a mental health problem in the United States. And sometimes I think, mental health was stigmatized in medical care. Oral health has somewhat of a stigma. We should be working with them because we are actually quite tied to mental health and people's ability to their social perceptions, their confidence, their self-esteem, so many things. And just like globally, low-income populations suffer the most, we see that here in the United States, with nearly double of our low-income population suffering from untreated cavities, a statistically significant difference in level of periodontal disease. And sadly, while we brag about how we keep our teeth longer over a lifetime, this is not true for those who are low income. Tooth loss has been declining in other populations. It has remained unchanged for the poor. So that brings me to some of my work. I'm residing in Indiana, and you're probably thinking, well, what can you learn from Indiana? But actually, there's some great similarities between Indiana, perhaps global communities. It has a very high rural population. We do have a considerable amount of individuals who are low income. And we have a limited dental public health program or a limited Medicaid program. And so perhaps we are similar to countries who have limited resources. We are sort of operating with low resources too. So some of my work has looked at Medicaid low-income adults and their access to care. And one of the questions I've asked is, how is seeing a dentist at least once a year, how is that affected by workforce supply and other things such as distance to the dentist? And I thought this is relevant to global communities because no matter what your insurance structure is and whatever community you come from, you still need to sort of manage your workforce and the geographic location of this workforce. And another question that has been imperative to ask is if a low-income individual who has a high burden of oral disease does get into the dentist, does this ultimately result in a return on investment? Do we see improved oral health outcomes downstream if they do have access to the dentist? So in my first study, and I do believe this is on the website that Sujay has created, but here I ask how dental provider density is related to access to care. And I'm not going to go through the methods, but I am going to talk to you about some of my results. Even with coverage for preventive dental care, all of that's covered, an annual dental visit, less than half have visit the dentist in a year, less than a third get a preventive dental visit, and about a fourth have a non-preventive dental visit. And so here's some of my overarching findings. I think I've already mentioned number one, but the other thing I found in workforce supply is that typically when we look at workforce supply, they use the census data and they look at licensed dentists to county population. And I found that that was not statistically significant related to whether or not the Medicaid population actually had care. It mattered if the dentist participated in Medicaid. Then access to dental care was positively improved. And so there's a call to perhaps we need to sort of incentivize dentists to participate in these programs. And that's a modifiable policy behavior we can change. The other thing, which perhaps is not surprising, we see this in medical care too, the farther distance you live from a dentist, the less likely you are to have a dental visit. And so this has global implications too, right? If you are a up and coming developing country, you want to think about the location of these providers so that you can sort of systematically help people access them. All right, what about the next question, return on investment? They get into the dentist, what happens to them? Well, I asked the question, if they get preventive dental care, does this reduce non-preventive dental visits downstream and expenditures? And this is a very important question to ask because it is about return on investment. I'm not going to again get into the methods, but I do want to illustrate that I use a more rigorous methodology here in that I followed the same person over time in the Medicaid program. And because I did that, I was allowed to control for important confounders we haven't been able to control for in the past, namely time invariant confounders or fixed characteristics. And this is particularly important when you're talking about prevention, because we would assume that this person's preventive behaviors at home, which may confound whether or not going to the dentist is effective, we would assume that perhaps their behaviors stay static over time, right? We're not assuming that the person one day wakes up and brushes for 2 minutes and the next day brushes for 2 seconds. They continually have sort of the same sort of static health consciousness behaviors over time. And so I was able to control for that using a type of methodology. And here are my findings. So what you're seeing here is that if they had a preventive dental visit, at least one prior preventive dental visit, they were less likely to have a non-preventive dental visit need in the future. And as they increase in the preventive dental visits, we continue to see that statistically significant effect. If you look at expenditures that Medicaid would pay for non-preventive dental visits and total dental expenditures, you almost see a dose-dependent response in that the more prevention they have, the more access they have to the dentist, the less they cost the dental program. So the less burden they might be on these Medicaid public insurance programs. So again, huge return on investment and suggests that we should be investing in preventive care. And this has global implications too. So if you are a low to middle income country and you're trying to design how will we structure perhaps some sort of public insurance program, you will want to invest in prevention because long-term that leads to cost savings. And then also too, you want to recognize that even with coverage, even by offering people an access point or financial support, it doesn't mean that they actually will utilize care. We found that even with coverage, visiting the dentist on an annual basis was low and somewhat irregular. And so this speaks to perhaps some other challenges such as health literacy or availability of dentists or transportation. So finally, some recaps. What can we take away perhaps from the little state of Indiana who has a limited dental program? Well, here are some things I came up with. Public health insurance programs in low and middle income countries would definitely benefit from making sure they allocate resources towards prevention to control long-term costs and improve population health. Despite coverage, actual use of care was low, and so that points to other barriers, structural barriers that need to be addressed, such as health literacy, transportation, trust in providers. And I think globally, oral health needs to talk about social determinants of health and how it interplays with access. And then geographic access matters. Where the dentist is matters to whether or not the patient actually visits these populations. And so that globally speaks to many countries who have rural and remote populations. And provider participation, if you do have something like the US, where you have public health insurance programs that providers can self-select into, it's really important that we sort of incentivize them correctly so that they participate in these programs. Because currently right now we are incentivizing them not to see these patients. In Indiana, I think we're at 40% of what private payers pay. And so we are essentially incentivizing these providers not to see the most needy, the ones who need them the most. And finally, my last takeaway, which is if you are designing developing policy or trying to create an electronic health record, please, I beg you, put the mouth back into the body. Please have a dental module in your electronic record. Please do not split these. I want you to imagine if you're a medical care provider and your patient walks in and their mouth is taped. They cannot talk to you. They cannot eat anything. It is the beginning of the GI tract. It is 100% connected to our body. Let's start acting like it does. Thank you.
Thank you, Dr. Taylor. Next, we have Dr. Parita Patel, who has extensive experience in federally qualified health centers in all of California, Massachusetts, and Maryland. She's a member of the Adult Dental Collaborative for the Maryland Dental Action Coalition, where she advocates for and supports initiatives around the Maryland Medical Assistance Adult Dental Program. In addition, she provides subject matter expertise for the development of community-based health programs across the U.S. And in her former role as the director of dentistry at Health Center for the Homeless Maryland, she expanded the dental program to include access to specialty services, improve dental medical integration, and improve care quality through performance improvement initiatives. Dr. Patel is a former Albert Schweitzer Fellow, and she holds her dental degree from the Tufts University School of Dental Medicine and her master's in public health from the Johns Hopkins School of Public Health. Welcome.
I have to say before I start, it will be 10 years almost since I graduated from the Master's of Public Health program from the Johns Hopkins School of Public Health. And this is a dream. When I did this program, I was by myself. I think in my class, I was the only dentist and the only representative of oral health. And it felt very siloed. And I get goosebumps thinking about where we are today. So thank you, Dr. Mehta, for bringing us all together today and tomorrow, and really having a chance to be inspired and work together. Dental care is healthcare. I'll say that again. Dental care is healthcare. And in my experience in working with federally qualified health centers, There's no place where I see this more apparently. Today, I'm going to share with all of you how federally qualified health centers are a wonderful place for interprofessional collaboration, care integration, and innovation. Okay. Okay, so first let's start with what is the definition of a federally qualified health center? And this is interesting because I went to the HRSA website thinking it would be a straightforward definition, and it sent me to the CMS website, which had a different definition. So this is my distilled version of what that definition is. A federally qualified health center is a community-based healthcare organization that provides comprehensive primary care and support services to disinvested populations, regardless of insurance status or ability to pay. Now, there are some key characteristics of federally qualified health centers that I would like to outline today because I think they're really important in the work. So first of all, FQHCs have to provide comprehensive primary care. Next, they are eligible for funding through HRSA and reimbursements through Medicaid and Medicare. And that's why I was getting punted to different websites. The reimbursements are different than the Public Health Service Act, Section 330, which is what established the network of federally qualified health centers in our nation. Most FQHCs have to have an ongoing quality assurance program. And the Board of Consumers of FQHCs must consist of consumers. So let's look at active dentists by place of practice. This is ADA Health Policy Institute data. It's unpublished, but it's from late 2023. And we can see the different occupation categories here: private practice, dental school faculty, armed forces, FQHC, BH, and PHS, state, local government, hospital staff dentists, grad student or residents, and other health organization staff. Private practice is the overwhelming majority of this pie chart, 23.4%, okay, close to 95%. And if you look at the section that is FQHC, it's combined with the VA and PHS, and it's less than 1.5%. It's actually 1.2%. I like to think that we are a small but mighty group of people, though, providing care to disinvested populations across the country. So what makes the federally qualified health center a really unique place for interprofessional collaboration? Well, first of all, we have a wide variety of primary care providers. We have medical providers that not only include PCPs, but we have psychiatry, pediatrics, maternal health, going into OB/GYN services. We have the dental team. We have behavioral health, which is therapists, and sometimes combined behavioral health and case management services. And in some programs, I've even seen case management, outreach, occupational therapy, optometry. I've seen dietitian services, even chiropractic services, acupuncture services. So it's awesome, holistic care. These programs are required, as I said in my definition, that they have to have ongoing quality assurance and performance improvement programs. Now, what does that tell us? That tells us that FQHCs then have to have a way to record that data, to organize that data, and then report that data back. A great place to collect data. Lastly, the electronic health record is an integrated clinical documentation and includes an integrated health record. What does that mean? The odontogram will be in the same chart that the comprehensive medical history is in. That also means that you have some insight in the mental health status of your patient. Like we know there is some overlap with your mental health. You can also see where did the patient sleep last night? What are the social determinants of health that impact their ability to access care? Do they have transportation? Do they have access to healthy foods? All this is really important when you're really trying to provide the best care outcomes and the best health outcomes, I should say, for your patients. So how can we leverage this electronic health record and really develop interventions across disciplines? Today, we spoke a lot about medical dental integration. We touched on some other things, But here, I'm going to talk about 3 separate programs that I developed in my former roles. And it's not about the clinical integration. I want to pay attention to the other folks that helped with this work. So we did a fluoride varnish with pediatrics intervention. So Dr. Hughes talked about the fluoride varnish program in Maryland. Our pediatrics providers were trained on providing fluoride varnish, but we saw that the numbers were dwindling and we had to ask why. And so we worked with the performance improvement team in looking at what were some of those barriers. And as we sat down, we worked actually in the IHI performance improvement framework, and we recognized that there were some barriers that were relatively easy fixes. Things like folks didn't know where the fluoride varnish was located. The fluoride varnish had expired. There was a new influx of new providers coming in that perhaps hadn't been trained on when to apply the fluoride varnish. One of the major things we learned, though, is that the pediatric providers were concerned about over-fluoridating the population, meaning that they weren't able to read inside the odontogram and know when our last fluoride varnish application had occurred. So they were concerned, oh my God, what if we're over-fluoridating these kids? So we worked with health informatics and we developed a very simple form. And that form was visible by all of the departments, meaning that if a pediatrician or an NP goes in and it's the well child visit, it's the scheduled time that a fluoride varnish would be applied, they're able to see that in the chart. And we did a few different versions of the chart. We landed on a very simple, you just check to see that they've had fluoride varnish applied, and you write the date. And if you're applying it, you enter it into the chart, and that's visible on both ends. And just this one simple intervention changed our trajectory in how those fluoride varnish applications happened. I think we were like at 40%, and we jumped up to the 80% just with this one intervention. The next example I want to share is with substance use disorder and the treatment for that. So for opioid use disorder, there is a intervention called medication-assisted treatment programs. This happens in FQHCs, and it's a medical, the medical department would do that. But what our primary care providers that were running this program realized is that Suboxone actually creates an intraoral environment where dental caries are more likely to occur. That is because Suboxone decreases intraoral pH, and it also has impact on salivary flow. Now, a little bit about Suboxone. It's actually administered in a film. It's in film form, and you put it inside the buccal mucosa, inside the mouth, and you have to wait for it to dissolve. And patients are actually instructed to keep the medication in their mouths for as long as possible. So you have now, we know that if you have an environment that is acidic, you have a higher risk of dental caries. So for this program, we needed an intervention, and we needed to find one relatively fast because the information had come out, and our medical providers were feeling bad. Oh my gosh, we are causing cavities in our patients and we're not counseling them appropriately. So I reached out to some of my colleagues in this work at the National Network of Oral Health Access. And there was a program out in the Eastern Shore that was doing an intervention for this population. And it was a sodium bicarbonate rinse. Sodium bicarbonate is baking soda. Okay, so it's just a high concentration baking soda with water. And you instruct the patient after 30 minutes after the medication has been dissolved to rinse with that. Swish for 2 minutes and spit out. A low cost, easy intervention. And for this, we really worked alongside clinical scheduling. So we worked with the front desk. We looked at what patients were being seen in the MAT clinic that day. We went over, did a warm handoff, introduced ourselves, provided some education, and then said, we're here if you ever, whenever you're ready to seek dental services. But that was at the point at which the intervention with those baking soda rinses happened. And then the last one is a case about diabetes and periodontal disease. So we know the research. We know that if you're pre-diabetic, that it's really important to maintain those periodontal tissues and make sure that the inflammation is not getting worse. And the other end, if you have moderate to severe periodontitis, there's very little that we can do as an intervention in a federally qualified health center. Yes, we can do root planing and scaling. Yes, we can do extractions, but really we can't reverse periodontal disease. That is another separate conversation about access to specialty services, but I'll stick to my topic here. So we looked at how can we then pull the data from our patient population and look specifically at labs. Here, hemoglobin A1C, and how can we design an intervention based on that? And for this, we worked alongside a population health nurse who was specifically doing small groups and education for patients that had had a recent diagnosis of diabetes. And we worked with the health informatics teams to pull those lists of patients. And then we worked with scheduling to get those scheduled. Now, what you do find very often in a federally qualified health center setting is that appointments are booked really far out. As soon as you open the schedule, they book out 3 to 4 months. We're a safety net program. So here, we really had to look at how do we prioritize getting folks in? If someone's on a 3 to 4 month recall schedule for their periodontal disease, they're probably not getting in at those intervals. So that's how we created priority scheduling, putting spaces in the schedule for folks to be pulled from these lists with hemoglobin A1C and putting them directly into the schedule so that they're not waiting 3 months to be seen. Also, things come up, right? There are competing priorities. And so you want to make sure that you get the patient in as soon as possible. So what are some of the key elements of sustainable innovation? For me, I think it's important to look at the other experts that you work with. And this is easier when you work in a federally qualified health center. Sure, if you're in a standalone private practice, you're not going to have a health informatics person helping you or someone to help you through performance improvement. But in the FQHC, you can. So we work alongside health informatics. You know, where are the folks that are building these electronic health records? And how can we simplify all of this for us so that we can improve patient outcomes? Next, work with population health, right? These are folks that have specialized training in improving population health. And then performance improvement, health informatics, I think I touched on that several times, but going through actual best practices for performance improvement, we would run through PDSA cycles, plan, do, study, act, and just tweak one little element of our program and figure out what the outcome was and then quickly pivot to the next thing. And that helped us get to where we needed to for our outcomes and for access. So as I close this out, I have some questions for you. We're gathered here, we're talking about integration, we're talking about how the mouth is separate from the body. It's all one, right? Dental care is healthcare. Let's start thinking of it as such. Let's not think about these small areas of integration, but let's start being more bold with what we say. How can the innovative strategies and programs that are developed in FQHCs, which as we know is only 1.2% of the practicing population of dentists, how can we scale that to other settings? How can we do that? And also think about this. If almost 94% of dentists are in private practice, are they going to be able to scale this? Do we need to really look at that pie chart and think about how that needs to be adjusted for the next 10, 20, 30 years? How can we, as the public health community, better train and support FQHCs to drive innovation? I shared that I was here 10 years ago, graduated from this program. Did I know how to run an oral health program in a federally qualified health center? How did I reach out for that training? I was lucky. The folks over here, the Maryland Department of Health, Office of Oral Health, I connected with them as I was doing my capstone. I would turn to them when I said, we have an access issue. My patients can't get access to specialty services. I believe that this is an amazing group of people that is always going to support and uplift each other. But I think it's critical right now. How do we better support FQHCs to drive innovation? Because I really do believe it's happening at the FQHC setting, and we need to take a look at what these folks are doing. And lastly, instead of continuing to work in silos, is it time for a fundamental shift in where health services are administered? Are we supposed to be in hospitals? Are dental programs supposed to really take more of a charge in improving patient outcomes beyond just educating the next generation of dentists? Are we setting up the next generation of dentists to be successful in this environment? Growing educational costs, growing costs of living, dental equipment, dental supplies, everything is going up, and now we have tariffs. But really, I mean, we have to take a step back. Where are we going? Because I don't think that the private practice model works. And it's up to us here at the Johns Hopkins School of Public Health to really have an honest discussion about that. Thank you.
I think those were three amazing talks that we had. Thank you, Dr. Hughes, Dr. Taylor, and Dr. Patel for those three talks. All questions can be, I encourage you to write them down. We will have time for questions later on, but I'll reintroduce Dr. Mehta.
Dr. Hanna. Thanks, Dr. Hanna. Appreciate you coming over from the School of Medicine, and you know, that isn't to echo what Dr. Patel was saying. In my MPH program here at Hopkins, we didn't get a ton of interaction with the School of Medicine, particularly the Department of Otolaryngology. So thank you for being here. And thank you, Dr. Hughes and Dr. Taylor and Dr. Patel have something for you. Dr. Hughes, can you come to the stage? Briefly tell you a little bit about them. These are salvaged maple trees from the British Columbia forest, and yeah, they're tariff-free. So have you our next moderator? I am very pleased to introduce our next moderator. Dr. Tom Quinn is the director of the Center for Global Health here at Johns Hopkins. We're really blessed to have him. Thank you for being here. He is a professor of medicine and pathology at the School of Medicine. He is professor of international health, epidemiology, and molecular microbiology and immunology at the School of Public Health, and professor of nursing in the Johns Hopkins School of Nursing. In 2006, he was appointed founding director of the Johns Hopkins Center for Global Health. And as you know, and as you've heard, is the massive sponsor and organizer of this event. So I am truly grateful that you are here, Dr. Quinn, and I will give you the stage for introduction. Thank you for being here.
Greetings, everyone. I'm glad to see such a great turnout. I have to give personal thanks to Megan Harrison sitting in the back there. She really was the driving force to try and have Hopkins be the venue for this. Thank you so much, Megan. One of my other hats is over in the Consortium of Universities for Global Health. It's based in Washington, D.C., and when it was formed, I guess it was 11 years ago, there was a working group on oral health, and some of you may have attended some of those sessions. It has always remained a very prominent force. And so when we think of global health, we think of oral health as well. And the topic that I was asked to moderate fits perfectly into that because it's entitled Expanding the Global Oral Health Workforce. And when we do global health, that is probably one of our #1 concerns is workforce. Who is out there in LMIC or middle income countries or even in our own parts of this country? So it's an important topic to really consider. And I'm glad to just be a part of this. So we have three really fantastic speakers. And I'm going to introduce the first one, who is Dr. Karim Manisa Kumaran, Venezuelan physician and epidemiologist, strongly committed to community health. After graduating from medical school at the Universidad Carabobo in 2019, she received a Fulbright scholarship to pursue her MPH at the University of Illinois in Chicago. Dr. Manasa Kumaran's work centers on improving oral health access and exploring language as a key social determinant of health, particularly among the Hispanic populations. And she hopes to improve health outcomes for diverse populations around the world. And her topic is reflections on culture and oral health. So please welcome Corinne.
Good afternoon, everybody. My presentation today is gonna be a little bit different. We're gonna do an exercise together. So I wanna hear from you, just a little warning before, I'm gonna use Slido. If you don't wanna use Slido, that's okay, but I still want you to do this exercise in your head and try to do this as a way of reflection. And what this exercise is gonna be about is understanding our own perceptions or what oral health means to us, but also what oral health means to other people as well. To give you a little background, or what we're gonna do is that we're gonna analyze two pictures. That's all that we're gonna do. To give you a little bit of background where these pictures come from, these pictures come from Ecuador for a sample of around 36 people, most of them females, middle age, 37. Only 55% hold a high school diploma, and the oral health or oral hygiene practices in this specific sample were not incredible. However, you will see later in a little exercise how this may also influence oral health. And what you need to know the most is where these people come from. So these pictures come from two different persons that come from Pichincha province. Ecuador, difference from the United States, is not divided into different states. It's divided in provinces. Most of this sample come from Pichincha, where the capital Quito is located. And the other people in this sample came from the Inter-Andean region of La Sierra, which is all of the provinces that you see on your left-hand side in yellow. So this is not that important. So we're gonna jump right into the exercise. I want you to look at this picture. Just look at it. Think about oral health. Look at the person's gums, their teeth, their lips, their smile, everything that you can see in this picture. Now I want you to observe. Slido's not working, but that's fine. What do you observe in this picture regarding oral health? Is there anything that pops to you? And if someone wants to speak up and like say, oh, we're this and this and this, that would be great as well.
Probably has a removable device, like a partial.
Yeah.
Gold tooth.
Yes. Something else.
Missing crown.
Yeah, the teeth are not symmetric there.
Mm-hmm.
Karen, can you just repeat for the Zoom so they can hear the slides?
Okay, so some of the answers that we've been having is a golden crown, some removable device, non-symmetric tooth, something else?
Toothwear.
Toothwear.
Not sure if a registered qualified dentist is treated, it could be a quack.
Okay, perfect. Okay, and I'm not a dentist, so this is gonna be, I can see like the gums look a little bit inflamed. Teeth are somewhat yellow. There's a lot of tear down, as someone also said.
Now having all of this that we already said, is this gonna work? No. Which treatments or procedures do you think are the most convenient for this person? What would you recommend? And it's okay, again, if you're not a dentist, but like in general, what would you recommend to the person in this picture?
I wouldn't recommend anything to the patient. I would ask them what they wanted to address first, because I have a job, because they have a need, and they don't need me to tell them what they need. I need them to tell me what they want, and what they need.
Perfect.
Can you repeat that?
Oh, yeah. One person said that before we recommend something, she will ask the person what this person needs or what they want to have, or what their priorities are before even starting any treatment, which is a great answer. Someone else? Okay, so I'm gonna give my own perceptions. Again, no answers are wrong. We're just evaluating our own perceptions. And I know that you may not want to speak because it might be a little bit scary to say that maybe the golden crown is like, not that great. Or how about some implants? Or how about some crowns? Maybe some whitening, maybe some orthodontic treatment. Maybe some cleaning, maybe some scaling. It's all valid, not wrong answers here. Now let's look at this second picture. What can you guys tell me about this second picture? What is the first thing that you notice?
There's
deep bite. Missing front teeth. Attrition. We see a lot of things. Gums look a little bit inflamed as well. Maybe some discoloration. We have a list that we can go through. Now to this person, which treatment will this person get done here regularly? Maybe some implants, a bridge, crown, cleaning, scaling, again, maybe some orthodontic treatment for sure. Maybe some recommend tooth whitening. Why not? Those are all things that we will recommend here in the global north to these two people. And what if I tell you that these two people are actually indigenous people that come from Ecuador? They come from two different indigenous communities where they practice dental modifications. Dental modifications, we kind of look at it as, there's a lot of archaeological evidence of dental modification. So when we think about it, we think about Asian civilizations, like putting gemstones in their teeth. But in fact, in Ecuador, for example, is one of the countries that has the biggest amount of archaeological evidence of dental modification. And this is still practiced today. These are two persons who are living right now with this teeth modification. In fact, we have some quotes. The first one is from the picture on your left, and the second one, the picture on your right. The first person is a religious leader of their community. That's what the golden crown means. It's like a sign of power and knowledge and leadership. In fact, you may think that that golden crown looks a little bit, broken. In fact, this person during the COVID-19 pandemic sacrificed part of the golden crown to defend her community against COVID-19 pandemic. So the meaning behind that golden teeth, she made this sacrifice to protect her community. So it's not a golden crown. It's more than that. But that's what we see. We only see a golden crown. And then the second person had their teeth knocked off, not pulled out, as a religious custom when was young. In fact, in some of these communities, these are traditions that are very common worldwide, ritual mutilations. We see them all over in Asia, we see it in South America, North America, we see it in Africa, we see it all over the world. And in this case, for example, this person had their teeth knocked off, and her mother, and her grandma, and her mother before that. So these are dental modifications that have been practiced years and years and years, hundreds of years. And we talk about dental modification as something that we find on mommies. But these are real people. And this is when we think about global health and decolonizing global health practices and what it means to be culturally sensitive. This is what we mean. Most of the things that we see as something that needs to be fixed is actually has a huge story after that. So that's some things that we need to take into account. So some key takeaways from this exercise is that the perception of health is subjective and is influenced by many factors that should be considered when designing and implementing global oral health programs. Internalizing and deconstructing our perceptions and biases towards oral health and health practices is essential for improving our own global health practices. And finally, we need some more research to understand the communities that we serve around the world and develop more culturally sensitive programs to advance oral health equity. Thank you, everybody.
Thank you very much. Hopefully we'll have some time for discussion and questions at the end. So our next speaker is Dr. Richard Rodriguez, who will be talking about remote Alaskan community health. As far as his bio, he's a staff dentist at South Central Foundation, a native-owned nonprofit that serves roughly 70,000 Alaskan Native and Native American people living in Anchorage, Alaska, and the surrounding area. He provides comprehensive dental care on a daily basis, in addition to traveling with a team to remote villages throughout Alaska during the year. During his dental school education, he founded a student-led dental public health organization to educate colleagues on the importance of health policy and its implications for oral health. Their interests include dental therapists, medical dental integration, and seeking innovative methods to address oral health disparities. Richard earned his Bachelor of Science in Biology with minors in History and BA, Business Administration from the University of the Incarnate Word, a Doctor of Dental Surgery from Texas A&M, University School of Dentistry, and a Master's of Public Health from Yale University. Please welcome Dr. Rodriguez.
Alrighty, good afternoon, everyone. Thank you, Dr. Mehta, for having me. Thank you, John Hopkins, for this opportunity. One thing I want to say is that I'm really grateful to be specifically in this environment, because I will later say this in my conclusion of my presentation, but I think public health is going to be at the forefront of improving oral health, and it won't necessarily be dentists. And I'm a dentist saying that. A hot take, but you'll see why. In the vein of speaking of Indigenous health and serving Indigenous populations, I want to be respectful and say that we are currently in Baltimore, which occupies the Piscataway and Susquehanna nations. I work in Anchorage and live in Anchorage, which is located within the territory of the Dena'ina Athabascan people. And the villages that I travel to, St. Paul and St. George, are the land of the Unga people. And also a great place to announce that I'm now clinic director of one of our 5 clinics that we have in Anchorage. So I'm really eager at this opportunity to now build in this admin and this public health role and to work within our FQHC to improve our health outcomes. And so, like in the introduction, what is South Central Foundation? Alaska Native owned nonprofit healthcare organization serving 70,000 Alaska Native and American Indian people living in Anchorage, the Matsu Borough, and surrounding villages in the Anchorage Service Unit. Okay. And so I also want to add on top of that, that this picture right here is not only South Central Foundation, but it's also the Alaska Native Med Center. And so we work in conjunction with the Alaska Native Tribal Health Consortium, and we work at a statewide basis, but then also we serve primarily the Anchorage service. And Anchorage specifically is the largest city in Alaska. It is our hub, therefore it's the most populous city in Alaska. Something that's really fascinating is that this medical center becomes the fourth most populous area in the state from 8 to 5 every day. So that many people are employed by this Alaska Native Med Center, but because so many people are going to the same area to work, it is really fascinating to think that this largest city in Alaska is 300,000. The next city after that is 30,000. The next city after that is a couple of thousand. So the population changes are staggering. There we go. And so I'm a very visual person myself. Therefore, I wanted to have this graphic to kind of identify exactly where we work. And I'm going to move a little bit if that's okay. So South Central Foundation is titled South Central Foundation because it is south and central of the state of Alaska. So everything in gray is the responsibility of our organization primarily. But then, however, like I said, the Alaska Native Tribal Health Consortium works at a statewide level to provide specialty and tertiary care services to Alaska Native people. So we work not only by ourselves all the time, we work in conjunction with other healthcare Native corporations or organizations to coordinate care for our people. And then we'll be discussing today remote travel and St. Paul and St. George. Has anyone found where St. Paul is on this map? A couple people. So it is this island all the way over here. So when we're talking about remotes, that's about as remote as you can get. So I know some people are gonna be curious. I had to fly on a 6 or 8 seater plane. And then on that plane, we have a refueling in further West Alaska, and then that's about a 2.5 hour flight. And then we have, after that, once we refuel for an hour, we have another 2.5 hour flight to get to St. Paul. But public health is about meeting people where they are. So that's why we do what we do. So to give you a little bit more about what we do and like what dentistry is like in Village, Alaska. So it's 1 to 2 week trips at a time, and it's usually one to two times a year. The villages in population size range from 30 to 400 people. St. Paul specifically is about 400, but then St. George, a neighboring island, is actually 30. The difference, why, I don't know, but that's just how it is. We have built clinics and some built clinics have additional FQHC funding from IHS or some federal entity to where we can actually have a nice operation that is operating for those 2 times out of the year, or we have to bring our own equipment, and bringing our own equipment involves bringing the patient chair, the staff chair, the provider chair, bringing the hand pieces, bringing the air compressor. I learned how to put a unit together on this job. Never done it before, but I'm in remote Alaska and I'm putting it together with my team. So very interesting environment and an interesting way to practice dentistry. So of course we're in remote Alaska. Do you think the Wi-Fi is great in remote Alaska? It is not. And when you have a cloud-based EDR, you're waiting quite a few times for the chart to load, right? And we try to document everything that we can through our EHR. So self-service is also limited in this area. And with that, do you think coordinating patient care is easy? No, half the time the phone calls drop. You're actually walking through the village trying to get people to come to clinic because you're only there for 2 weeks. Unique travel costs for further care. And so of course, we're only there twice a year, right? But people have extensive treatment plans in the village. And so are they gonna get everything done within those 2 weeks? Absolutely not. And some people have more extensive needs and they would like to go to Anchorage to be flown to receive all their dental care. Do you think that is covered in any way or form? No. Do you think that people in the village have high-paying jobs necessarily? No. So a plane ticket out of pocket to get from St. Paul to Anchorage usually is about in the 1,600 range, depending on the time of the year. So you're asking people to pay out of pocket $1,600 to receive and complete their dental care. Of course, in some rare cases, the dental problem becomes an emergency, and that's when Medicaid will come in and provide a voucher to have them traveled and flown to Anchorage. So only in the most rare cases and kind of what we talked about, emergency visits, do people actually receive the care in Anchorage. But it's for that one problem, and then they go right back to where they're from. And then another thing I just want to emphasize is limited access to affordable, nutritious foods. Do you think groceries in remote Alaska are cheap? I was just saying this earlier. I think I saw that a box of cereal, some boxes of cereal are $15. Do you think that the nutritious foods, the produce in there is great? No. Do you think that the foods that are less nutritious are more affordable? Because they have longer shelf life. And so because of that, you understand, like you learn all these unique issues that these communities face and how they're set up to have poor oral health and like what are the solutions that we can have. And of course, care is one of them, always care is one of them. But when we think about like our economic and our healthcare systems, how can we actually try to educate and emphasize prevention while we're out there? And this is just a quote at the very end, just saying that overall, the past few decades, although we have these great programs and meet people where they are, we keep having to go back out because of all these issues. So it's a really tough challenge to work within. And so pictures, visual. So on the top left, what we have is that built-in clinic. This is St. Paul specifically. So this just lights on for 2 weeks and then lights back off. And then we come back in 6 months, lights on and everything. So it's very nice and clean. It's not as, remote or, we're not working with poor equipment. It's there, it works for us. That is our clinic van. Of course, we have to go get some fresh air because this island is beautiful. This is a picture I took myself of seal pups. Incredible opportunity, and I ate seal for the first time. Seal oil, fascinating. And this is just me with my. It gets better the more you eat it. So this is me with my staff, and so they're just kind of doing the triaging and kind of assessing the needs for our kids. And then this is the clinic center right here at the bottom left, and then that's me with one of my teams. So the team changes every 6 months, but I'm the consistent provider. We're trying to really focus on empanelment as a concept and having the same provider come to the same village so that we build a better relationship with the community. And so I think this video will play, hopefully. This is my plane landing in St. George to pick us up after a week. And I'm not gonna lie, I'm a little bit more nervous to fly out there, but we're gonna do it. And then let's see if I can switch to the next one. There we go. And then I took a video of our team setting up our clinic. This was in St. George, so the smaller village, with approximately 30 people. This is just a spare exam room in the primary care clinic that they have. And we are setting up everything. And it took about probably 4 to 6 hours, our own sterilizer, because we are a federally qualified health center. We have to be up to standard when it comes to sterilization. So we're very careful about that. And of course, does that hinder patient treatment sometimes? It does. My doctor chair was broken in transit. So I had 2 wheels broken off. So I was sitting at an angle for the entire week. So you never know. Okay. And then I'm going to use this opportunity to segue in what also my colleague Carrie is going to discuss in more detail about working with a DHAT and why I believe it's important and how I'm about to go back out to St. Paul next week. And it'll be my first visit with a DHAT, and a DHAT is a dental health aid therapist. And I'm really excited for that opportunity. I personally have been working, and I'm the supervising dentist of a dental health aid therapist in a clinical setting. It's been about a year since we started working together. The patient feedback has been largely positive. Everyone's been really excited that we have DHATs in our clinic. It's a collaborative treatment approach. The DHATs are trained specifically in Alaska, and I can only speak to this program, but they're trained to be practicing minimally invasive care. And so what does that mean? That means that you don't have to treat every instance of caries with a drill. Like you can try SDF, you can try restoration with glass ionomer, and glass ionomer is just this new material that it releases fluoride slowly over time. And so that's something that I've been excited about. I learned how to be a better treatment planner by working with my dental therapist. And that's someone who had 2 years of training over my 4 years of undergrad and 4 years of dental school. So because her training is so unique to the setting that we work in, I feel like I've learned so much, and I'm really grateful for that opportunity. The coordination of patient care to maximize patient experience, and this is specifically in Anchorage that I've experienced so far, but I can do an exam in a hygiene chair and then go to my chair to do a treatment. And then later that day, oh, there's an opening on my DHAT schedule. Let's go ahead, and while you're here in town, let's get you started on some of those fillings since you're here at the clinic already. So it's been fantastic to see how that all works together. And so now literally on Sunday, I will be flying back out to St. Paul with my DHAT on my team to be practicing in remote end parts of Alaska. And so I'm really looking forward, and I will report back next year when we have this to see how it goes, right? So DHATs, they're going, and they have traveled out by themselves in different parts of Alaska. But then there's also teams where they're gonna go with the dentist to be providing the dental care. So in previous discussions of dentists and DHATs, it's been one versus the other. And in public health specifically, I just don't think that's possible. The only way is to go forward together to address the needs of our community. And also in some ways, it allows the dentists to practice their full scope that they were trained with. So I get to do more crowns now on my schedule because I have my DHAT. I get to do more single root canal procedures. I get to do the more complex stuff that I was trained to do, whereas I'm not so bogged down with the very important simple fillings, simple extractions. And so I like to just talk about this idea of like dental therapy as a manifestation of distributive justice. And I think we shouldn't be afraid to use the word justice when we're talking about health policy and healthcare, and that we are allowing people from these communities to receive an education, a limited scope of education, but it's what's needed in the communities to provide the most basic, the most access, to improve that access to oral health care. And I feel like I'm just naturally a disruptor of things. And I think it's important to disrupt this long established hierarchy that only dentists are gonna be the people who are qualified and knowledgeable to provide safe and effective care. And I like to finish, and I don't know if this is in the following presentation, but I just saw this the other day and I had to emphasize that every state has a different journey with dental therapy. But in Florida specifically, the dental therapists are taking the same exam as the dentists, the graduating dental students, and they just take less of the exam, right? So who do you think had higher scores on basic fillings? It was the dental therapist. So when we're thinking about who can provide safe and effective care, they can do it just as well, if not better than us. And with that being said, dentists should and must support dental therapy if they are truly invested in the improvement of oral health care in all communities, and not even just historically marginalized one. I think everyone can benefit from this concept. I'm really eager to see where it goes in the future. Thank you.
Fascinating. Two great presentations and one more to go. And let me introduce Carrie Ann Kunzelman. She's a member of the Chickasaw Nation of Oklahoma and graduated from the Alaska Dental Therapy Education Program in 2019. Carrie is a dental health aid specialist within the Tribal Community Health Provider Program at the Northwest Portland Area India Health Board, and a state licensed dental therapist in Oregon, where she resides. She's the president of the American Dental Therapy Association and continues to advocate for dental therapy on a national level. Carrie hopes to inspire others to become more interested in oral health and to represent the American Indian Alaska Native communities in the dental field. She's passionate about minimally invasive dentistry as it uses evidence-based research to practice in good dentistry. Carrie, please welcome.
Can you all hear me okay if I stand here? Okay. Chicmaw, hello. My name is Carrie Ann Kunkelman. As stated, I'm a member of the Chickasaw Nation of Oklahoma. My tribe now resides in the Oklahoma area, but before the Trail of Tears colonization, my tribe and my ancestors were in the Mississippi area. It's really a great honor to be here and to speak in front of you all, and thank you so much for having me. It's really like super wild that I'm here. I'm the first of in my family to graduate high school, let alone to go to college and to finish. It took me 5 years to get an associate degree that I'm so grateful that I have. So I'm gonna back up a little bit and just, these are some pictures that I thought would be fun to share with you all so you all can see who I am, so you can see who my family is. And there's also some pictures of my classmates up there as well. My daughter turned 5 a couple weeks ago, and she's the little girl in some of these individual pictures. And then there's one down here at the bottom in front of the totem pole. That's the Portland Zoo, my husband and my daughter. I came from a broken household. I'm the oldest of 5. I have two half siblings and 2 step siblings, and we moved around a lot. I went to 5 high schools in 4 different states. I was asked growing up if anyone was in the military in my family. Now I just say no military. We just moved around a lot. But school was really hard. It was really, really hard for me. And I really, truly feel that the public school system, the many schools that I went to really failed me because it felt like it was my fault that I wasn't doing well. And so I really think that it's important to share that information and that story with you all because traditional education doesn't fit everyone. It didn't fit me, and I didn't know that until I learned and heard about dental therapy. In 2015, 2016 is when I had first learned about dental therapy. I was attending a community college in Gresham, Oregon to get ready to apply for their hygiene program. And I, ironically enough, had a toothache, and I had heard that there was an urban Indian dental clinic that had opened about 20 minutes from where I lived. And I knew somehow that I wanted to be able to give back to my native community, even if it wasn't at home, with my people in Oklahoma. So I went in there, I have a toothache, can you help me? Yes. And at the time, to become my supervising dentist, Dr. Asma Ahmed had said, hey, have you ever heard about dental therapy? I see you're tribally enrolled. And I was like, no, but tell me all about it. And just to cut straight to the chase, my now husband and I had moved to Alaska in 2017 so I could start my journey with dental therapy. During that journey, I had many thoughts of quitting because I was one of, there was 12 in my class that started, and only 3 of us had no existing dental experience. So I didn't know the teeth numbers or the names of the instruments. I didn't know how to sit in the chair. And so I already was at a very high disadvantage compared to some of my other classmates. That being said, the dental therapy program didn't let me fail. Dr. Shopstall-Cohn, who I'm sure Dr. Rodriguez knows, she kind of took me under her wing and told me about this Sylvan Learning Center, which was super embarrassing. I was quite a bit older than some of my classmates already. And, when you have someone come to you and they kind of point out at first that you need help, it's, I didn't really take it super well at first, but then I was open to it and I got that help because I didn't know that I didn't know how to study because I never had anybody around me to tell me that. I didn't have anyone until I was in college just to really kind of help push me along because I really needed that extra help. So fast forward, I graduated from the program in 2019 and I went back to work at that same urban Indian dental clinic for 2.5 years under Pilot Project 100. And then a few years later, applied and received, I'm number 11 of the Oregon State Dental Therapy license, which is really exciting. It was the day before my birthday that I found out about that, and lucky number 11. So I feel like it's really important to share that story with you all because when you're looking at dental therapy or dental health aid therapy, it's not just this other oral healthcare provider type. I was, essentially selected from my community to go and do this training and to go back to my people, even though my people right now are the people of Portland. It's really important to know and to talk about the fact that there are huge provider shortages in urban settings just as much as there are in rural settings. And I don't feel like I hear that talked about enough. So I just wanted to make sure that I shared that with you all. And I'm very glad I didn't cry because usually I do. Okay, so I'm going to try to get through this quick. It's so much information to share in just a few minutes. So I'm just going to go ahead and fast forward, and I'm sure that our slides are going to be shared with you all. So for some of you that don't know, a dental therapist is similar to a physician assistant for a doctor, but for a dentist. And also kind of looping back to the fact that this is a global oral health conference, dental therapy originated in the early 1920s in New Zealand. So dental therapy has been around for over 100 years. And I'd also like to point out that the Alaska Dental Therapy Education Program is celebrating 20 years this year as well. So we've had dental therapy in the United States that started in Indian country for 20 years. And it's still taking this long to get dental therapy to other states. There are only 14 states so far that have authorized dental therapy. I also wanted to kind of just point out, because I know we talk about dental health aid therapist and dental therapist and advanced dental therapist, and it gets kind of confusing. When you see that health aid part, it's really the same provider type as a dental therapist. It's just referring to Indian country or reservations, providers that are serving tribal members. And then when you see advanced dental therapists, those are going to be dual licensed dental therapists that either attended a program that looped in hygiene, or they were already a hygienist and then received a little bit more training, not a little bit, but a few years of training to also then be able to carry that dental therapy scope. And then this is a picture of my class and then the class before us that graduated. I also really need to point out the fact, because I do, I'm a tribal member and I do work for the 43 federally recognized tribes of Oregon, Washington, and Idaho. It's really important to note that American Indian Alaska Natives still to this day have the highest caries disease rate of any other population. I don't have enough time to really get into that, but I'm sure you can all imagine that that is very much due to colonization and tribes being pushed away from their homelands and their traditional foods being taken away from them. I really like this chart because it does share information for other populations, not just for American Indian Alaska Native. And it's also important to note because this model, the dental therapy model, can work for any community, for any population. You can see here that for Asian Pacific Islander, there are only 7% at the time of this study that were identified as dentists. And so it's really important just to remember that this isn't just for Indian country. This isn't just for Medicaid patients. Dental therapy works for everybody because everybody deserves to have culturally relevant, appropriate, accessible, affordable oral health care. This picture here is of a dental therapist. On the top picture, Rochelle Ferry. She attended the New Zealand dental therapy program and was one of the first to provide services to her Alaska Native village. And then there's my daughter again down there in the bottom picture. But I just wanted to highlight what integrating a dental therapist would look like for your community. You would increase encounters. Dr. Rodriguez talked about the fact that when you have a dental therapist within your dental team, that frees up time for the dentist to provide more extensive procedures like crowns, and so that in turn is going to bring in a higher profit if that's something that you're looking at within the dental clinic that you work in. You're going to improve efficiency. So you're going to help alleviate some burdens that might be on the dentist or on the hygienist by just having another body that's trained there to help your patient population. You're going to, of course, reduce patient wait times because you have another provider that's able to provide services. Your dental therapists provide community-based care. So in my training, we were taught patient-centered care, and that was why I'd answered the question earlier that was asked about, what would you say to this patient? I would never tell a patient what they need because I wouldn't want someone to do that to me. That's going to make me feel shame. That's going to make me feel like it's my fault that my teeth are that way, even though it took me 8 months to get into the clinic. And so I think that that's really important to remember. Again, it provides an opportunity for all providers to work at the top of their scope. And just going back to person-centered, patient-centered care, this is going to offer early, frequent, prevention-focused care. I also wanted to comment, I'm sorry, I was taking some notes down just as everyone was presenting today, that dental therapists in Minnesota and dental therapists in Alaska are actually working in ER settings. In Minnesota, they do rotate, the dual licensed dental therapists do a rotation through a hospital setting in downtown Minneapolis. And I can't speak extensively about that, but I do know that those students do a rotation. And so they're able to provide services and to see patients in an ER setting. And then in Alaska, there is a dental health aid therapist because I think in part because the Alaska Dental Therapy Education Program is on the same campus as the hospital. There is a dental therapist that goes through and actually does rotations in the morning with their ER staff to assess and provide screenings, fluoride varnish, and to see, you know, if those patients or those kiddos need to be seen a little bit more urgently. And so I think that, you know, thinking about integrating a dental health aid therapist within an ER setting could really help to expand access. I also had shared, I won't get into detail of these studies, but I did share them on the app platform, so y'all can have access to this. But this is a really great paper that was put together by CareQuest and the Society of American Indian Dentists. The American Dental Therapy Association contributed as well, and then the National Indian Health Board also contributed. But it just really highlights and provides statistics for really why dental therapists are needed. And then circling back to the fact that dental therapy works for all populations, for all communities, not just for rural communities and not just for American Indian, Alaska Native communities, but for all populations. And that was the point that I wanted to make with this research here. The last thing that I want to leave you with, that's my dog. He did go to Alaska with us. That was Valdez. He's 11 now, Leo. But I wanted to share with you all, I guess, not a call to action because we're on to the action phase now, as Dr. Mehta stated. Become an ally to dental therapy. If you feel a certain way against dental therapy, I urge you to kind of look at the whole picture and to do your own research. You know, in this kind of political scene that we're in right now, I think it's really important for you to just do your own research and to create your own bias rather than just to listen to what other people are saying, because evidence is evidence, science is science. Like, I don't really know how else to convey that other than dental therapy has been proven for over 100 years to be a safe, effective solution, not the only solution, but a solution to a problem that we're not seeing change. It's been the same for too long. And I think that you all feel that there can be change. Otherwise, you wouldn't be here. So I will go ahead and wrap it up. And thank you so much again for allowing me to be here and to speak to you today.
Thank you very much, Carrie. That was wonderful. Time precludes that we're not going to be able to have a discussion group, unfortunate. But during the break, please reach out to our three fantastic speakers. I learned a lot just sitting there, and why don't we give them an applause. There is one more speaker before this session concludes, and it's by Zoom, I believe. Megan, you want to do it?
Sure.
Yeah.
Thank you, Dr. Quinn.
You bet.
Oh, it's fantastic. Absolutely. Yeah. Okay, so we'll just get out of this. Let's see. There's Dr. Teo. Welcome. I think
good afternoon.
You'll be able to share your screen. I'll just do a quick intro for you though. How are you doing? It's early for you.
It is quite early, but not too bad. It's
fantastic.
Almost 6, so not too
You're a trooper. I really appreciate you doing this by Zoom. So Dr. Teo is coming to well, let me get out of this thing here first. Sorry, Dr. Teo. And Megan, you might be getting something ready, but let me introduce Dr. Teo. So she is an associate professor of dental therapeutics at the University of Melbourne in Australia, practicing dentist and registered pharmacist. Her research focuses on medicine use in dentistry and dental prescribing practices. She co-authored the National Australian Dental Guidelines, Therapeutic Guidelines, Oral and Dental version 2, and is on the editorial board for the International Dental Journal and VMT Oral Health. She's also the current chair of the Global Antimicrobial Resistance Dental Network and a member of the Preventing AMR and Infection Task Team for the FDI, the Fédération Dentaire Internationale World Dental Federation. She has recently published the book Handbook of Dental Therapeutics and co-invented the drug compendia MIMS, or is it MIMS? Drugs for Dent.
Mims. That's absolutely right. Thanks. So yes, perfect. Thank you.
Fantastic. We're just going to make sure that we have you on our screen.
I'm gonna drag it all the way over.
Fantastic. Thank you, Megan. And once Megan gives you the clear, you will be ready to go. Thank you for being here, Dr. Cohen.
Amazing. Thank you.
I'm just dragging, we have so many screens here. I'm just dragging you over to the name for right now.
There you go.
There we go. It's still right here. There we go. Okay, I think you're good.
Great. Thank you so much. Good afternoon, everyone. And thank you so much, Dr. Mehta, Solidarity Dental and Johns Hopkins University for having me speak today at this wonderful oral health symposium, bringing together so many important agenda items to the table. The one I'll be talking about is the silent pandemic of antibiotic resistance. And while we've all heard of this before, we've heard this many times, in my session today, I'll be talking about why this is relevant for dentistry, what we can do about it, but also how we can go about improving the use of antibiotics. And it affects us all, whether you are an oral health practitioner, a public health researcher, consumer, or in policy. Why, what, and how can we tackle antibiotic resistance in dental practice? So before that, I just have to go through some disclosures. As Dr. Mehta mentioned, I have some research grants. I do hold some positions with the FDI World Dental Federation. I do receive royalties for a couple of items, my book and the drug compendium, MIMS, Drugs for Dent, but I won't be talking about either of those in my session today. But apart from my disclosures, a little bit about myself. I'm a dentist and a pharmacist from Melbourne, Australia. We're very far away from everyone in the world, but I do spend most of my time as an academic researcher at the University of Melbourne. And when I'm not there, I'm in the dental clinic treating patients. And when I treat patients, as all the oral health practitioners listening will know, we always see these holes in teeth. And when these cavities get bigger, infections form. And dentistry is very much a surgical discipline, isn't it? We have to do some form of dental treatment to be able to address the cause of the infection. Dentistry, I always say, is about dental treatment and not drugs. And antibiotics are not required for localized infections, which is luckily the vast majority of infections that we see. So given that information, it's then surprising that dental antibiotic prescribing accounts for about 10% of all prescribed antibiotics worldwide, which is actually very high, as high as hospital prescribing in some countries. And it may be less surprising to know that overprescribing is actually very common around the world. In general, it tends to be for localized infections when dental treatment alone is appropriate, but actually, the statistics are quite shocking, and up to 80% of antibiotics are overprescribed, inappropriately prescribed to varying degrees, depending on where you are in the world. And this is for both therapeutic as well as prophylactic reasons. So, for example, in Australia, where I'm from, around 1 in 2, about 55% of antibiotics are overprescribed when they're not necessary for therapeutic reasons. Also very high prescribing for therapeutic reasons in the UK. The guidelines in the UK are very different when it comes to prophylaxis. So there's actually very little prescribing for prophylaxis in dentistry in the UK, but very high prescribing for prophylaxis in the US, joint replacements, wisdom teeth extractions, surgical extractions, and so on. But prescribing decisions are actually really complex. It's certainly not as easy as handing a set of guidelines to dental practitioners and saying, there you go, you're all set. You can now follow guidelines and you're going to be prescribing perfectly. It just doesn't work like that in real life. So we did a survey of dentists in Australia a few years ago now, and we found that 77% of Australian dentists on a routine or occasional basis will prescribe antibiotics if they're running late. Patient expectations and requests for antibiotics is a really big factor when it comes to prescribing, as well as being unsure of a diagnosis as well, but it sounds very much like an infection. These are all these non-clinical factors that influence antibiotic prescription. is not just unique to Australian dentists. I'm not just picking on them. It's dentists all the way around the world to varying degrees, and different factors will influence them in different areas. So just to illustrate that, in a survey of US endodontists, around a third will prescribe, a self-reported survey, will prescribe antibiotics because of patient expectations. But 39% of Swiss dentists, being unsure of a diagnosis, occasionally might prescribe. One of my colleagues in Wales, Anwen Cope, did a cross-sectional study looking at the odds of a patient who would be prescribed an antibiotic in the absence of infection. So there's not even an infection present. If the patient requested for antibiotics, the odds ratio was 3.7. If the dentist is running late, the odds ratio over there is 10.2. So if we were in that part of the world and the dentist was running late, and whether we had an infection or not, we might be getting some antibiotics based on this study. And so there's lots of non-clinical factors, and prescribing decisions are complex. And the reason why, of course, we worry about all this and are concerned with our high rates of inappropriate prescribing is because of the global public health emergency that is antimicrobial resistance. And we've all heard it before. In terms of some recent statistics in 2021, this is from The Lancet, published just last year, 4.7 million deaths were associated with bacterial AMR, antimicrobial resistance. For some US statistics, this is from the CDC, published, I believe the year was 2019. Every year, antibiotic-resistant bacteria and fungi cause at least almost 3 million infections and almost 36,000 deaths. And antibiotics are life-saving drugs. And they underpin all of modern medicine. We need antibiotics to keep working. Without antibiotics working, we wouldn't be able to have organ transplants, dialysis, cancer care, sepsis treatments, surgeries, autoimmune therapies. None of this would be possible if antibiotics weren't working. The World Health Organization has a task force of AMR survivors headed by this lady, Vanessa Carter. I know Vanessa, and if you ever meet her or see her speak, and she's a fabulous speaker, she tells her story all around the world, you'll notice that one of her eyes isn't the same as the other. She has a prosthetic eye because when she was 25 years old, she was involved in a car accident in South Africa, and she had multiple surgeries and contracted multiple resistant bacterial infections that affected large portions of her face. And she's now a really strong patient advocate for AMR, and there's many more patient stories on the World Health Organization website. Last year, they ran a campaign called Antimicrobial Resistance is Invisible. I am not. We are not. People are not invisible. And it was to highlight the voice of patient survivors. So given the high rates of inappropriate antibiotic prescribing in dentistry, highlights a need for oral health practitioners to be involved in initiatives to address this issue. So that's the why we need a seat at the table. But what and how do we do this? The FDI World Dental Federation has done a lot of work in this space and produced many resources, many of them which are led by my good friend and colleague, Wendy Thompson, in educating and advocating to the global dental community about this issue. And so I'll present some of these resources, not all because there's a lot. One of them is the white paper, the essential role of the dental team in reducing antibiotic resistance. And they produced an accompanying massive online open course that I was lucky to be part of, tackling antibiotic resistance, what should dental teams do. And in the white paper, they have presented 3 main ways to tackle antibiotic resistance in the context of dental practice: raising awareness, antibiotic stewardship, and then infection prevention and control. So I'm going to finish up now with each of these 3 areas as my main take-home messages about how we can tackle antibiotic resistance in dental practice. So starting off with awareness raising. So awareness raising is essentially what we're doing right now, improving knowledge, awareness of impacts of antibiotic use, and the need for stewardship, or stewardship being strategies to improve the use of antibiotics. And of course, it involves education of consumers, patients, oral health practitioners, promotion of research, but it really starts at the top. Dentistry and oral health need to be included in national and global action plans on AMR. If you think about, I've got Australia's national AMR action plan up here on the screen, and every country will have one. Think about your own country's national AMR action plan. Every country will have one. It might be US, might be from somewhere else. Is dentistry included? Very unlikely. Dentistry is generally not included in these plans, but it needs to be. Oral health needs to be included to be taken seriously, to be involved in initiatives to address this issue. In terms of raising awareness, one of the other initiatives by the FDI, World Dental Federation, was that back in 2021, the team managed to secure the pledge of about 60 national dental associations worldwide. They literally got them in a virtual room and they literally signed this pledge to commit to antibiotic stewardship. And, you know, whether it's quitting smoking or commitment to antibiotic stewardship, all change starts with a decision. And the countries in blue are the ones that had signed up. And that was back in 2021. And as we all know, talking is one thing, but walking the talk is a lot harder. And so last year we went back to those countries and asked them what they actually have done about it in terms of raising awareness. And I'm very happy to say that many of them, not all of them, but many of them actually had taken some initiatives and steps to raise awareness about this issue. So we're writing that paper up at the moment. The second point of the triangle is antibiotic stewardship, or strategies to improve the use of antibiotics in dentistry. So we've done both a narrative and a systematic review on this in this area. And from our systematic review and the narrative review, we found that most of these interventions tend to be bundles of interventions consisting of elements such as audit and feedback, guidelines, and education as bundles. And each of these bundles all showed to be effective in terms of reducing antibiotic use or improving the appropriateness of antibiotic prescribing. The only exception to that was guidelines alone. There was one trial where they gave dentists a set of guidelines and there was a control group, and the guideline group didn't produce any change in prescribing. And it's because, as I alluded to before, prescribing decisions are complex and they're multifactorial. Guidelines don't address all those areas. Guidelines are certainly still important because we need to be able to measure what we consider to be appropriate prescribing. But because prescribing decisions are multifactorial, interventions in dentistry need to be customized to the context. In stewardship, we often say there is no one-size-fits-all solution. And because this is dentistry, I like to say, like a set of dentures, there is no one-size-fits-all solution. These interventions, we need to take into account behavioural factors, as I mentioned before, but also the context. And what I mean by that, for example, is the factors that influence inappropriate prescribing in downtown Melbourne, where I'm from, we're very different to some parts of Africa, for example. One of my friends is doing a lot of work with antibiotic prescribing by dentists in Ghana. And one of the reasons that they found that dentists use antibiotics in Ghana is because they're concerned with how sterile their instruments are. So very different factors that influence antibiotic prescribing, and these need to be addressed when developing such interventions. So that's antibiotic stewardship in a nutshell. Then the third point of that triangle is infection prevention and control. So as a dentist, when I think of infection control, I think of it as having clean instruments to put in my patients' mouths. And that's certainly one aspect of infection prevention and control. But the other aspect is prevention of oral disease, prevention of tooth decay and gum disease, which make up the bulk of oral diseases. And as we know, tooth decay and gum disease are entirely preventable. And it's the preventive work that oral health practitioners around the world do every day, drilling and filling, cleaning teeth, nagging our patients to floss, making you all feel bad about the sugar that you'll have in your coffee after my session today. It's so important when it comes to stewardship, because if we can stop holes in teeth from developing or getting big and stop gum disease from becoming severe, then there'll be reduced chance of tooth infections and so less need for antibiotics. But dentistry is all about dental treatment and not drugs. And that's why access to dental care, access to oral health care, and inclusion of dentistry and oral health as part of universal health coverage is central to that third key message of infection prevention and control. I can just say that it's certainly, very challenging, easier said than done. In Australia, we have universal health coverage. Dentistry is included, but we have around a third of the population on a wait list for about 2 years, and some places more, depending on where you are in Australia, just to access a checkup for preventive dental care. So certainly many challenges, but the mouth is not separate to the body. We need access to dental care and oral health care in terms of reducing antibiotic use. So to finish up with some take-home messages, why AMR is relevant for dentistry? It's because we've got really high rates of inappropriate prescribing. What we can do about it and how we can go about this from the FDI, 3 main areas: awareness raising, the education of oral health professionals, consumers, but it really starts at the top. We need to include dentistry and oral health in national action plans on AMR. Antibiotic stewardship, these tend to be bundles of customized interventions. We need to take into account the context and behavior change. Like a set of dentures, there is no one-size-fits-all solution. And finally, infection prevention and control. Inclusion of dentistry as part of universal health coverage and access to dental care for all. Dentistry is all about dental treatment and not drugs. Dentistry needs a seat at the table in each of these three areas so we can join the rest of our healthcare colleagues to tackle the global public health problem of antibiotic resistance. I just want to finish up by thanking my team from the University of Melbourne, National Centre for Antimicrobial Stewardship, and many collaborators from around the world. Thank you so much for listening.
Thank you, Dr. Cho. That was fantastic. And you're getting some applause from the Zoom room. So it's fun.
Thank you so much.
Really well done. I guess one of the concerns that I see from I see a lot of trigeminal neuralgia patients, and I think you'll appreciate this being the other hat that you wear as a pharmacist. But as you sort of reinforced, when patients are unable to access dental, if they're going to the medical providers, one is that there may be prescriptions going both ways. But the other is we have to make sure that it's actually odontogenic pain, and then obviously address it more appropriately than antibiotics, but reinforce it.
Yes, absolutely. It's always an ongoing challenge, isn't it? And certainly I think discussions with the medical field are really important in this area as well.
Yes, absolutely. And again, I really just want to echo thanks to you for coming here to Hopkins to the School of Public Health, because these conversations clearly are needed and necessary. We had a chat earlier today with one of our alums who graduated maybe a decade back, and these conversations weren't occurring. And more recently for myself as well, we need these collaborative discussions. So thank you. And I will be looking for you at a conference because I have something to give you, and I'd prefer to do it in person. And my goal is to do it in the next 12 months. So I'll reach out to you to find out which conferences you'll be and see what matches up. We'll have to get a spreadsheet or something. Yeah,
absolutely. Thank you so much again. Thank you, everyone.
Thank you. So we will take a very quick break. We are behind, but you need coffee. But Megan, can we do it in 5 minutes?
5 minutes.
It's gonna be tough. Okay. Yeah. So Zoom crowd, come back in 5. We have this isn't quite the final panel. We have our Dragon's Den that's coming up right after this, and I realize we're we're behind. I do want to introduce the moderator for this panel. This is an individual who's been working very hard here at the School of Public Health, has organized and revitalized the oral health student group. So the Johns Hopkins University Bloomberg School of Public Health Oral Health Society. And I'd like to welcome Dr. Sana Kataria. Please give her a warm welcome.
Good afternoon, everyone. I am so excited to welcome you to the panel on innovations for the 21st century. I'm Sana Kataria, as Dr. Sujay Mehta said. I serve as the president for Johns Hopkins Oral Health Society. I'm a dentist, a Masters of Public Health student, and I'm passionate about health systems, advocacy, and policy in oral health. Even though I began my journey in clinical dentistry, it is with Dr. Sujay Mehta's guidance and mentorship that I'm standing right here before you. He is the person who has helped me find a voice in public health dentistry. Dr. Mehta has inspired me, definitely challenged me, and pushed me to stand right here before you. And with that, we are going to dive right into the topic for today, innovation in oral health. Innovation in oral health isn't just about the new tech. It's about the people, the systems, and the values behind it. And I couldn't ask for a better group of speakers to explore that. First up, we have Dr. Jessica Klavick, a powerhouse in both clinical technology and community-driven health. She holds her Doctor of Dental Surgery from Indiana University and a Master's of Public Health from University of Florida. She's the head of clinical effectiveness at Vidya Health, which develops AI tools for dental diagnostics, and also serves as the executive director for Solidarity Dental Foundation. Dr. Jessica is one of those rare people who can talk to a room full of engineers and community health workers with the same clarity and compassion. Just wait and you'll see. Please join me in welcoming Dr. Jessica Clavel.
Thank you all. I'm gonna raise this up a little. Ooh, I was just told technology. Here we go. Great, awesome. And then the next here we move the buttons. All right. Okay, so Slido question before we start kind of diving into the topic of technology is how ready do you think the dental field is for the widespread adoption of AI and other digital innovations? So you can go ahead and scan that QR code and then put in your answer. Do you think we're ready? Are we ready for it as dental professionals? Or are we getting there? A little medium, a little unsure of it? Or are we just not quite there yet? You know, do we need some work, some advocacy, some education on the topic before we can hit it? And then, is there a secret to showing the results? Yeah. All right. Okay. This is very interesting. So we're somewhat ready. This is great. I agree. Even though you know, I work in the AI industry as a public health dentist, we are somewhat ready. There is a lot to do. There's a lot of research to be done. There's a lot of understanding of how dental AI works, how it doesn't work. And so, yeah, totally agree. This is exciting to hear that at least there's interest, right? If you guys had all said we're not ready, I would have been a little concerned that the next hour would be very boring for you. Anyway, so moving on, my topic is, you know, how can we leverage AI and technology for global oral health collaborations? I have a few disclosures. I do work for Vidya Health as the head of clinical effectiveness, and I am the executive director of the Solidarity Dental Foundation, but the views and opinions in this presentation are my own. Also, all images and graphics and materials are property of Vidya Health, and some of these slides were co-created with my colleague, Katie Paulson. So a little bit of an overview of this presentation. So first, we're going to talk about what AI is, a little bit about the history. I'll go into a brief overview of how artificial intelligence models are trained. Then we'll sort of talk about some of the clinical implications of it, some of the benefits of the care standardization that comes from dental AI, and some of the oral health literacy piece that comes with, you know, having this as a diagnostic tool, but also a training tool for your patients. And then sort of how AI and technology can be used for oral health collaborations. So sort of bringing it all together, big picture, what can this look like? So to start, just a very basic definition of artificial intelligence, right? It's in the news everywhere. It's hard to miss, right? ChatGPT, everyone knows what that is, probably. And, you know, so what is it though? What is AI? And really, like, at its core, AI is, you know, a part of engineering and science where you're just trying to see if a computer can do human tasks, right? Can a computer think like a human? And even though AI is something that, you know, is recently in the news, right? Very recent years, there's been a lot of momentum in artificial intelligence. It's been around since the 50s. If any of you have seen the movie, The Imitation Game, Alex Turing, he started that back in the 50s. And so the field has continued to develop over the years, where now we're getting into really some of the deep learning, the neural networks, computer vision and speech, right? So some really cool tools coming up. But with the concern of everyone's like, oh, AI is so new, they're so, you know, it's been around for almost 75 years now. So just want to highlight that. So the next, I'm just going to talk about some of the very basics for how AI models are developed. So what you want to do, you get the biggest data set, and this is for dental x-ray, artificial intelligence, but it's kind of holds true for all. So you want to get the biggest set of x-rays you can get. So like at Video Health, we actually have like the largest in the world. We collected dental x-rays from all sorts of demographics, different populations. The idea is that by having this really large, robust data set from different sources, you get a less biased AI output. Right, and then you have clinical experts, so dental clinicians that will annotate on those X-rays certain findings. So you tell a group of dentists, hey, on this set of X-rays that we give you, show where every cavity is on the X-ray, right? Just highlight it, So then you take all of those X-rays and you put them into the machine, and that then creates these AI models that begin to label the data. So the AI models will say, oh, I've seen this type of radiolucency or darkness on the X-ray before. That's a cavity. So I'm going to start flagging that as a cavity. So that's sort of how the AI models are initially developed. Then there's this really important fourth step where you have these AI models that you then run through new images to get new outputs. And this is where that refinement part is really important. So in this example here, there was an AI model trained to find blueberry muffins. And you can see it did okay. But there's also chihuahuas. And there's a big difference, if you just want your blueberry muffins, you need to then go back and retrain the model of be like, okay, no, this is a blueberry muffin and this is a chihuahua. Try and find some differences between the two. So that's sort of the continuous improvement and development of AI models and how they work. And that is really where dental image AI is right now, right? So we are continuously developing to reduce these false positives and false negatives to make sure that what's being highlighted on the x-rays is actually the disease state that we're looking for. So just another real quick overview of sort of what dental image AI is and what it isn't, because there's a lot of confusion here. So it's a diagnostic tool for oral health professionals. It's not a replacement. So, everyone's always so concerned, AI taking jobs, it's not taking jobs in dentistry. It is assisting dental professionals. So I always say, it's oral health professionals plus AI. It's not oral health professionals versus AI. And so it can help with detecting early stage disease or hard to identify disease, but it's not a replacement of that clinical judgment. It's also not a replacement of receiving preventive care in the office. And then sort of I hinted at it earlier, it can be a much less biased analysis because of the data inputs being so broad. And, so it's less biased across most patient demographics. So why though? Why do we need it, right? We've been practicing dentistry without it for years. One thing that we did a study at Video Health, and what we found was that dental clinicians, everywhere from recent graduates to really experienced dentists, benefited from using the AI. So we had them look at x-rays of 10 different dental pathologies. And what we found was without AI, there's a pretty standard distribution curve that you can see there on the left. And then when they used AI as the diagnostic tool, we found that the variation among dentists, the variation in performance of being able to identify diseases was reduced, and that the overall detection of disease was enhanced. And so that means that diseases can be detected earlier and more accurately and more consistently. So that clinical consistency piece is really important, and I'll dive in to some examples here. So for the clinicians in the room, we all know this. For the non-clinical team, this is sort of a standard set of x-rays that we take for a new patient exam. This is without the use of AI. So we've all maybe been there where we go to a provider and they give us a treatment plan and like, I don't know, I want to get a second opinion, right? So then you go to another provider and they give you a treatment plan and it's completely different. You're just like, what, how does that work, right? When you're looking at, a set of x-rays, everyone can see something different. And that's great, but it can be confusing and challenging, and it doesn't necessarily lead to the highest quality care possible. When you add AI to it, so this is sort of our patient view, you can start with everyone seeing the same thing, including your patients, which is, we'll get into that a little bit later. But everyone is starting at least with the same starting point. So dentists might still, develop different treatment plans, but they're seeing the same thing to start. And so kind of zoomed in a little bit more here. So this is sort of the clinical view for the dental providers, but then also the patient view for patient education. And so you can kind of zoom in and we maybe for the clinical providers in the room, maybe you saw the broken tooth and the abscess, but maybe you didn't see the bone loss, right? Maybe you didn't see some of those really small carious lesions. So just starting from the same point can really help with that clinical consistency and early disease detection. So Dr. Ine, in his next presentation is going to go over more clinical decision support systems. But right now with AI where it's at, we are offering clinical decision support, but we haven't quite gotten to the systems piece yet. So he's going to talk about that a little bit more. But what we can do is then, with training on millions of real treated restorative procedures where you have the x-ray, the before and after, you can start to develop some recommendations for, potential treatment. Again, it is 100% up to the clinical team and, the treatment that they want to deliver, but you can start to get some speed and some increased accuracy on consistently treating dental diseases. And so when you have a lot of FDA clearances and the regulatory standards to put all of these models together, the computer models begin to be able to think clinically, right? So all of these complex models coming together, you can get a pretty good clinical picture. Once you start bringing in the health histories, once you start bringing in all those other things, you start getting that system that Ine is going to talk about. So let's talk about oral health literacy. We've all been sort of talking about some of the challenges that it creates. As a dentist or a dental clinician, you can take a look at that top x-ray, you can easily put together what's going on, right? But then you try and talk to your patient. You're like, do you see this dark area? How it's touching this other dark area? Then it created this other dark area. And the patient's just like, what? But then maybe if you show them the x-ray on the bottom and you can say, hey, do you see this red? How it's touching the purple? The red is the cavity. The purple is the pulping nerve of your tooth. Because those are touching, you have this other red area. That's the abscess that we need to treat. There's just a lot more understanding for the patient, for them to feel empowered to understand what's going on. We talk about how, medical providers often don't look past the mouth, but patients don't look in their mouth either, right? And so a lot of times they don't even know what's going on. And so being able to share this sort of pictures worth 1,000 words, it can really help. Moving on, you can add, as we start adding in intraoral images as well. So you can have the x-ray, intraoral images, a description of the care that you're recommending. You can print this out for the patient. They can go home, they can think about it. They can look at, your findings as opposed to Dr. Google, which is, a whole nother thing. But so you can share with them kind of the hows and the whys, and they can take it home and look at it. So again, really helps, patients understand and visualize the care that you're recommending for them. So let's kind of talk about the future state and what this means for global oral health collaborations. When we start looking at using AI models for some of our global oral health metrics, like the DMFT, the Oral Health Status Index, again, by using either x-rays or intraoral photos to take these metrics, you can remove the bias, you can save time, right? And imagine having a community health worker being able to go in and take photos, and then with that community, you understand the need before you even get there. right? So you know what resources you need. You can apply for grant funding because you know then, before you go even for the initial visit, kind of what's needed. So that's kind of on the roadmap, and a great way that AI, I think, will be leveraged sooner rather than later as we start talking about resources being really tight, right? So AI is one way to help when the resources get skimmed, to add it in so that we can, one, justify your funding, and two, know exactly how much you need. And it reduces sort of some of the subjectivity in these analyses as well. Oh, sorry, my picture kind of went over. And then finally, so AI can be kind of like the core, but then there's so many other additional technologies coming up, right? So things like point of care saliva testing, teledentistry, data exchange platforms, all of these pieces of technology can be kind of put together like pieces of a pie to really start creating movement on that outcomes needle that we keep talking about hasn't moved. Right. And so I think that as we continue to innovate and continue to put these systems of innovation together, ideally, then we can start changing oral health care for the better globally. That is all I had. Thank you so much for your attention.
And again, technology. Thank you, Dr. Jessica. I don't think I'll ever be able to look at a blueberry muffin the same way. Now, introduce Dr. Ane Tudhati. He is currently an EPIC application analyst at a women's college hospital in Toronto and a professor of health informatics. Dr. Ane has one foot in hospital systems and the other in the classroom, where he's helping to train the next wave of health tech professionals. He's one of the few people who can explain interoperability and make you laugh at the same time. So please join me in welcoming Dr. Ane. No pressure.
Take it up and talk. First off, thank you so much, Dr. Mehta, for inviting me. Such a good podium. This is my first time speaking to such an audience, so please bear with me if I make any mistakes. That's a joke, sorry. Just to give a background on health informatics, being a dentist, I had zero idea what health informatics was, okay? Until I came across George Brown College program of health informatics. I started it in 2020, January. In March, COVID happened. We went online. That's when technology hit me, okay? And that's when everything began. So today we're gonna look at bite-sized decisions, pun intended. Before I begin, no conflict of interest for this presentation, and some content for this presentation is intellectual property of George Brown College, where I teach in my course. I've taken slides from there and is used with permission. So to begin, and let's look at the evolution of technology in dentistry. So starting from 1980, we had CAD/CAM come into picture the first time. Then in 1990, we saw digital imaging and diagnostics come into picture. And then, as Jessica mentioned as well, early 2000s when application of AI started being used in dentistry. And then we saw a steep rise in the use of machine learning and AI algorithms for dentistry, specifically for dentistry. And then by the mid-2010s, we had focused on personalized treatment, like video health. And then in 2020s, that's when we started to understand what a CDSS can do in dentistry. And can I say we're the future? Maybe. So what is dental informatics? So dental informatics is the combination of dentistry, information science, computer science, cognitive science, and telecommunications combined together in a prism to get improved dental practice, improved dental research, and improved dental education. And where would a CDSS fit in? This is where the red circle is. Just to help make dentists' life better. We talk a lot about AI, but there's a need to understand where CDSS can go. Does anyone know what the device is? It's from Star Trek. I don't know if anyone has watched Star Trek. Mr. Spock, yes. So that tool is called the tricorder. It's one device to rule them all. Okay, so in health informatics, the ideal CDSS is often compared to the tricorder from Star Trek, a device that provides instant diagnostics at the touch of a button. Okay, in dentistry, what we need to do is we need to integrate dental informatics, we just learned about it, with medical data, dental data, patient data, and CDSS algorithms to enhance decision-making and improve patient care. Getting in technical a bit, how a CDSS would work. So we'll start here in the first picture. It says knowledge, tacit, experiential. That's a dentist. Okay. The dentist enters information into the dental information system. The system communicates with the inference engine, where the clinician's query or the dentist's query is translated into a language the system would understand. The inference engine then performs a detailed search in the knowledge base. That's the knowledge base where all the information is stored and codified for us to use. The answer is then sent back to the dental information system in form of actionable recommendations for the dentist. The inference engine works on if-then statements. So let's say a patient is on warfarin, the CDSS would say avoid surgeries on the patient. Sometimes things get really crazy. The system doesn't even need to be asked formally by the dentist. Let's say the dentist is entering an order for amoxicillin for patient antibiotic treatment. The system would fire a warning to the dentist saying that, hey, this patient has recorded a penicillin allergy in their hospital record. You don't need to prescribe antibiotic amoxicillin to them. Consider alternative options. So in complex situations, CDSS is what we need. And I say that because there are two cases, both from 2018. I'll give you some time to read. Where dentists have been sued to treat incorrectly. The case on the far right is there's two things that have happened there. The first thing is that patient had pain and that patient needed orthodontic extractions. The dentist prioritized the extractions over the pain, and the decay was left untreated. And she sued the dentist for 22,000 pounds. Okay. The extractions were also incorrectly done. Okay, so that dentist also got sued. The case on the right is from Ontario, is where I am from, is where a patient had to go for a surgery and get his tooth removed so that he could get a partial denture. But instead of removing one tooth and the abscess with it, the dentist removed all the patient's teeth to get a complete denture. So the patient woke up just to know, oh, it's not going to be a partial denture, it's going to be a complete denture. So that has happened. So let's talk a common scenario. A 35-year-old man walks into a dental clinic with tooth pain sensitivity. What would happen? In the regular case, dentist would examine the oral cavity, review x-rays, review patient history, make a treatment plan based on experience, right? Dentists do everything based on experience. Understand what fillings are required, what root canal treatments are required. There's no clear prioritization of the treatment, and it's solely relied on intuition, if a specialist is required or not. Follow-ups are also based on dentist availability, patient availability, and that can lead to delays, can lead to potential complications. And delayed follow-ups can cause higher treatment costs adding burden to the patient and to the dentist as well. And that leads to more chair time spent on ultimately straining the clinic resources, the clinic staff, the clinic time, right? So what would happen if we use a CDSS in the same scenario? A CDSS would analyze X-rays, like Video Health does, highlighting high-risk areas based on the patient, based on the patient history as well. CDSS would prioritize treatments and suggest structured follow-ups based on the dentist schedule. CDSS would give dentists ability to make decisions that are backed by data and preventing any future issues. The patient gets the right treatment at the right time. Done. So the conclusion here is CDSS enhances but does not replace the dentist expertise. The dentist always is going to be there. CDSS helps make us smart decisions based on recommendations, which betters patient outcomes and gives us a more efficient practice, reducing burden on clinic workforce. So what do we need to build a good AI-powered CDSS? We need to inbuild into the system these 5 rights: the right information to the right person, through the right channel, in the right format, at the right time in their workflow in the clinic. The second consideration is we need to understand diffusion of innovation. I'm not sure how many of you have heard about diffusion of innovation, but you can raise your hands. Okay, see a few hands, it's good. So let's break down these 5 adopter types. So innovators are the first to adopt because they're willing to take risks. Early adopters are the next. They're opinion leaders and embrace change readily. Then we have gap, and that gap is called a chasm. It's a critical gap where marketing strategies are needed to be the best to attract the early majority and avoid failure. Then we have the early majority. They are deliberate before adopting. And we have the late majority. They're skeptical and will only follow what the majority does. And then finally, we have the laggards. The laggards are the last to adopt. Sometimes they may not adopt as well because they're often bound by tradition. All people in this room need to be in the first 2 categories: innovators or early adopters. Otherwise, this won't work for us. So let's understand how innovation diffusion works and connect this story with dentistry. So in 1928, Otto Waweder invented sliced bread. You'd think it'd be an instant hit, right? But it failed miserably. And that's because the focus was on the patent of the device and the slicing machine, not on the consumer and what the consumer needs. The game changer was when Wonder decided to market sliced bread, not just as a product, but as an idea, a symbol of innovation and convenience, because they understood something crucial. For innovation to take hold, it should resonate with the people's perceptions and their daily experience. We heard Karen speak about perception before. This is where it comes into picture. So in health informatics, this story mirrors many scenarios. We've seen technologies develop like EHRs, EDRs, AI-driven diagnostic tools, but unless we perceive them as valuable, we will not use them. And these technologies will struggle in the real world. So what's the lesson learned from here is that perception is everything. And as innovators, for myself, in health informatics, and you guys in the dental informatics world, we need to ensure that our breakthroughs are not only technically sound, but also resonate with other dentists and meets their expectations. So how do we advance CDSS ahead? So on a clinical level, dental care is built on trust, equity, and responsible innovation. To ensure ethical use of technology, its use to provide patient-centered care, policies must prioritize privacy, equity, and accessibility while considering CDSS. As dental care evolves, it is critical to ensure that dentists and enterprise dental practices are prepared to integrate new technologies effectively when they get incentives. This includes continuous professional development, because education is really important when we're going to use digital tools, and we're going to use them with the clinic workforce. So everyone in the clinic needs education. Then we have data. Data in dentistry is very important. And if reliable and accurately collected, it will enhance decision-making and will improve patient outcomes. This also includes key integration between electronic health records and electronic dental records, like Dr. Patel mentioned. The progress in dental care relies on ongoing research when it comes to technology use. When it comes to using CDSS, we need to look at the global level as well. Like what's being done across borders? What can we adopt, right? We need to understand those points. And then finally, we need to have robust regulatory policies to tackle AI and CDSS liability issues. Like who's responsible if AI makes a mistake? Who's responsible if CDSS makes a mistake, right? We need to ensure a level of transparency in order to use the AI suggested recommendations, right? So just the Gen Z line, I don't know if it's right or wrong. The use of CDSS will revolutionize dentistry by improving diagnostics, early disease detection, reducing errors, reducing associated costs, and making personalized preventive care a reality. With AI-powered insights, we can predict risks and extend quality dental care to underserved populations. Think about teledentistry, AI in rural Canada, in Greenland, in places that they cannot get dental care, okay? Alaska, right? The future of dentistry is smart, accessible, and data-driven. So let's embrace the glow up. We've just scratched the surface of how a CDSS can shape the future of dentistry. So our work has only just begun for bite-sized decisions. Thank you.
Thank you for pushing the boundaries both in innovation and startup references as well. And let's continue the spirit of exploration as we welcome Dr. Alonso Carrasco-Labra, Associate Professor at Penn Dental Medicine, Director of Cochrane Oral Health Collaborating Center. His resume includes work with WHO, ADA. So basically any global organization that takes evidence seriously. He's helped shape international guidelines in TMD, opioids, and health equity, and is proof that policy can be powerful when it's rooted in real data and real people. Please put your hands together for Dr. Alonso.
Great. Thank you for the introduction. And the invitation, of course, Dr. Mehta. Thank you very much. Appreciate it. Typically, my audience is primarily clinicians. I'm extremely happy to be here. I mentioned to one of our colleagues, Sarah, that I have not need coffee today. I'm so excited with every single one of the presentations. Yeah, and I always need coffee. I will talk about AI, living evidence-informed guidelines for clinical practice and public health. I hope that this can answer some of the questions. I believe that the sequence was carefully crafted. Let's see. Conflict of interest. I have no financial conflict of interest to declare. Tremendous amount of intellectual conflict of interest. I believe that data should be driven, decisions should be driven by data. I believe in evidence synthesis as a way to inform policies, inform guidelines. And I'm currently a principal investigator on a research grant related to the ADA Living Guideline Program, which I will describe to you in this presentation. But what you see is my own opinion. I do not represent the American Dental Association. 3 objectives for this session. What is a clinical practice guideline informed by evidence? Identify the key features of a living evidence-informed guideline and the recent AI applications to accelerate guideline development in this framework. This is an old definition of guidelines from the National Academy of Medicine that I think needs to be revised. They talk about statements. We need to conceive guideline development in a broader sense as an agreement among interest holders in the health system about how patient care will be delivered, what is the type of interventions that need to be delivered, regardless of whether we're talking about clinical intervention or a public health intervention. And as you can see there, they are informed by systematic reviews of the best available evidence across different domains. What makes a policy or a guideline evidence informed? A direct link between the decisions and the evidence. And that should be very straightforward to see in the documents that you review. There's always a problem when we fail to summarize the totality of the evidence at the moment that decisions are made. And you can, as you can see from the figure, it's very apparent that you can miss the target. Often in the news, we see that coffee is good, coffee is bad, right? Chocolate improves something and the next week makes it worse. So looking at single studies is never a good idea, right? And guidelines that are evidence-based are always informed by systematic reviews of the best available evidence and then a process of decision-making, because the data never make decisions by itself. The data needs to be interpreted. Values in the decision-making process need to be explicitly described. The word values is something that I've been missing in this conversation. I think we're very good at bringing the word needs first. And patients' values are also something that we need to be talking about. With values, we mean what our patients care about, which we can go further and say it is something that can be reflected on the relative importance of different healthcare outcomes or outcomes of well-being. Very quickly, we put together a multidisciplinary panel, and this panel has a representation from several interest holders in the health system: payers, clinicians, professional organizations, patient partner organizations, methodologists, health economists, you name it. Everyone who in one way or another will be affected by this guideline. And they provide clinical questions or public health related questions that need to be addressed using systematic review methodology. This is a well-defined process that we've been using in medicine and dentistry for the past 25 years very effectively. The domains that we cover, probably the most important one, the determination of the balance between the desirable and undesirable effects of implementing an intervention or another option. The certainty of the evidence, to what extent the panel making the decision has a certain level of confidence in the data that is observed. Patient values and preference, as I said before, the relative importance of outcomes that patients assign at the moment of decision making. And finally, utilization of resources in the health system. All these judgments are summarized and synthesized and in the old way of doing things, published in peer-reviewed journals in the shape of systematic reviews and guidelines that probably you saw in the context of the United States, published some of them in the Journal of American Dental Association, but you also see guidelines from other government agencies that has been helping us to shape healthcare here in the country. Let's move now to living guidelines. The key problem we have is we want to be evidence-based, we want to bring data to the table. Conducting a guideline takes a really long time, probably something around 2 years. It's extremely expensive, and basically they get obsolete very quickly. Here's the guideline, we put in there on a link, and it start getting rotten, and then stings, and then it's terrible. And then we're citing recommendations from 2011, 2012. And it seems that we may not make a good use of money if we go there and try to redo that guideline. The problem is that guidelines tend to get obsolete. Different recommendations within a guideline, different statements within a guideline has different expiration time. Some of those statements can be there for a long time and remain valid for a really long time. One example, the effectiveness of sealants. I don't think we need to study that anymore, right? So that recommendation probably still stands until today. But there are other type of recommendations that may get obsolete fairly quickly. As you can see in a single guideline document, there is a different expiration time. So if we update guidelines here, great, we got 3 recommendations updated. All these other ones are already valid and the effort was actually wasted. So this is a high validity. We're making sure that all the recommendations are all up to date, but it was so quickly that it's too early. So this is a poor use of resources. On the other hand, if we wait for longer, recommendations will be obsolete faster. And then at the end of the day, we make better efficient, so we get more in return for our effort. However, recommendations are obsolete out there, providing misguided care for a long time. How do we solve this problem? Moving from providing these traditional guidelines to what we call leading recommendations. And that's what we're talking about today. This is a methodology that was developed primarily and very fastly during the pandemic in the medical field. Recommendations that are typically recommended or supported for leading guideline implementation are those that are priority for decision making. If this is priority for decision making, we need to know the state of the art immediately, and immediately means in a couple of hours, sometimes in a couple of days. High prevalence diseases, high rate associated with morbidity and mortality. So when we know that the effort that we're going to place in producing these guidelines really will translate in better patient outcomes at a population level. When we know that there is a reasonable chance that existing recommendations will change when new evidence emerge, right? And this is classic, something that happened during the pandemic, not only related to how the decision-making process occurred, but new evidence coming and is being processed. And then a field that we know is very dynamic. If we know that a new field is very dynamic and new evidence is coming over and over, we will like to have summaries of the best available evidence ready to go. If we want to be fast with the production of guidelines and recommendations, we also need to be fast with the implementation and the dissemination of those efforts. What you see here is this graphic that describes the technical infrastructure that is needed. This is currently in place right now in the programs that I am a PI for, in a collaboration with the Magic Foundation, Magic Evidence Foundation. And what you see there from the left side is the dynamic updating that I was just talking to you about. Currently, we're capable of updating clinical or public health related questions for a guideline in a time frame of no more than 4 hours. So every 4 hours, we know whether a new study has been published that needs to inform a particular question with an accuracy that is, of course, better than humans. From that new evidence, as you can see there, we create descriptive tables, evidence profiles, and via API, we're able to connect with different dissemination channels. A panel is on call as new evidence may warrant a change in a recommendation, and they know that we can call them at any point. So they come provide the recommendations with information for the rationale, and this is via API now disseminated through different channels. Evidence-based medicine books, structured process and shared decision-making, clinical decision support systems, when we actually have solid and tested systems, right? We can interact with those systems and quickly update with a click of a button. Widgets, PDF that are automatically created. We're really struggling right now with the publication process because journals cannot keep up with the speed of the evidence. And from my standpoint, that's okay. They need to think about a solution, right? It's not my problem. And these should be informing clinical pathways that are relevant for decision-making. So how does this look in practice? This is Epistemonikos. Epistemonikos is the largest repository of systematic reviews in the world, and it's translated to 9 languages. I strongly recommend that you look at Epistemonikos' work, nonprofit organization. Oh, no, that's not what, we're not ready for a live demo, right? That's not what we're going to do right now. Let me go back. Great. For some reason, I don't see that here. Oh, this. Yes, thank you. I just needed your presence to work. And this is what Epistemonikos does. Picture a clinical question just like this, surgical compared to non-surgical treatment of mandibular spondylar fractures. Picture a clinical question in your own field. On the columns, you see primary studies informing that question, and in the rows, you see systematic reviews available answering that question. What happened then is that we can filter for observation studies or randomized controlled trials, and after these matrices are created, we update every one of those questions prospectively. Each question, each matrix is connected to our recommendation, and every 4 hours, the system search for information in every single one of the large electronic databases that you know, and produce a summary that kind of looks like this. And this summary, I have on the left column an outcome, in the columns in the center, relative and absolute effects of the alternative options, and at the end, the certainty of the evidence, which is the evidence that we present to guideline panels to determine the course of action. We also use that information to create a table and a figure like the one you see here. This is what we call the LOVE platform. This is the Living Overviews of Evidence platform. What I'm presenting to you here is the platform from the COVID-19 Living Overview of Evidence. And what you see on the left column is all the available interventions for the management of COVID-19. So what you see here is a catalog of potential interventions that can be used. With a click of a button, you can see how many systematic reviews and primary studies are included, basically a transferring of that matrix into a platform that is easy to search. In other words, a table of content for that particular question. Guidelines like this are creating tools. This is a guideline we published in 2019, speaking of antibiotic use, right? And these guidelines are presenting algorithms like the one like you see like this, machine readable algorithms ready to be integrated in clinical decision support system. Nobody have done that, unfortunately, but the functionality is there. And we have typically guidelines that are for dental settings and non-dental settings, because we know the reality in our country. And we also create conversation aids, like the one you see here, digital tools that can help patients and clinicians to make decisions together. This is a guideline we published in 2023 about the management of chronic pain associated with temporomandibular disorders in the British Medical Journal. And again, we're trying to produce guidelines and disseminate guidelines in a way that have not been done before. And this is our effort. Here you see a visual summary of the recommendations. So at the top, the type of population that is relevant for this guideline, and those who may apply and those who may not apply at all. On the right side, you see practical issues that are relevant at the moment of decision making. And at the bottom, what type of interventions were prioritized as strong recommendations in favor, conditional recommendations in favor, conditional recommendation against, and strong recommendations against. Every single one of those that you see there can be clicked of a link to see more data in case it's needed, because the data is not, we don't want to overwhelm clinicians with information, right? If they want to see it, it will be available for them. This is backed up by a large network meta-analysis, like the one you see here. And this is a new tool, it's called Match It tool. From left to right, you see all the type of interventions that can be used for the management of chronic pain. In this case, the outcomes prioritized for temporomandibular disorder issues were pain relief, physical functioning. At the bottom, a description of that outcome. And in the two rows, you see how many more people would benefit from having this intervention, over 1,000 patients treated. And these are too many options, right? So if in the context of care, patients will say, I'm actually only interested in 3 options. And now we can compare and contrast depending on what is the type of problem that the patient is facing. Picture now that through natural language processing and an AI that is listening to the conversation between a patient and clinician, the setup of the interventions that could benefit the patient the most can be automatically done. So now they don't need to, again, deal with information overload. They were talking about augmented cognitive behavioral therapy and joint mobilization as 2 options. Here in the screen is the data available to determine which one is preferable. If you want to know more about how guidelines should be done and trustworthy guidelines should be done and appraise the next guideline that you see, I recommend this article we published in the Journal of the American Medical Association, absolutely applicable to any guideline in healthcare in 2021. So in summary, at the minimum, a guideline panel should synthesize and examine the evidence related to the balance between benefits and harms, the certainty of the evidence, patients' values and preferences, and the utilization of resources in the health system. There are other aspects that are important, like equity, feasibility, acceptability, stakeholder acceptability of certain interventions that must be brought to the table. And living guidelines represent the next evolution in the production of continuously updated evidence-informed recommendations. Thank you very much.
Just like that, The journey through the 21st century innovation comes to a close. Unfortunately, we do not have enough time to dive deeper. But since the beauty of modern technology, please connect my links. Connect with the brilliant panelists. Your thoughts on Padlet. Innovation isn't just on stage, it's how we continue the dialogue. Thank you again to Dr. Klaver, Dr. Dudbate, and Dr. Colabra for boldly pushing the boundaries. Can we please have a round of applause for the brilliant panelists? Following the tech now.
Yeah, this might be better. Can you hear me in the back?
Keep going, my friend.
We had a proposal, a 250-word abstract that you could submit, and it was very vague, and this is my doing, this is probably my fault. So because there wasn't enough time to have a real abstract presentation. So I'm prepping you, researchers, PhD types, because I'm not the PhD, right? I'm a clinician. So don't take it out on them. So the idea was you could have a proposal, it could be a research idea, a concept, a program, very airy-fairy. You know, this is a clinician that designed this. This is, so yeah, so you might have to take it down a notch. What, was there any other things? Did I miss anything? Program, concept, evaluation, innovation. There was an innovation. Yeah, there's a clue. Somebody might have an innovation. And so you had 250 words. You were only given a month. The notification of this was very short. So you had to be connected. You had to be on social media to find out and this kind of thing. So this is not, there's some failures with this, from a global health perspective, but this is an exercise, first time out for them and for me. So if you have issues, you can tell me privately. Don't post out on social media. And we will correct it. We will, the whole learning thing, we will improve on that. So that was the idea, that was the concept. So with that, I do want to introduce our moderator. Dr. Anita Eichstreit is the Senior VP of Research and Policy Education?
Policy and Education.
Yeah, so I got it right. At ADIA, the American Dental Education Association. And ADIA's headquarters is in Washington, DC. If you ever get a chance to see, at least the outside, I don't know if you'll get invited in, but the outside of the building is amazing. Just a fantastic location, great places to eat, fantastic coffee shops. So with that, I'm going to give you Dr. Eichstreit. Thank you for being here.
Thank you, Dr. Mehta, for the introduction. So let's please give a big round of applause to Dr. Mehta for the intervention and the principal of global health for this event. How has been the first day of the conference? A little bit low. I hope at the end of the day, but I expect from dentists a little bit more oomph. How was the first day? That's what I want. Okay. So this session is going to be a lot of fun. So it's geared towards giving back to those who are early in their career in dental public health. We have a wonderful panel of experts with us today that I'm going to introduce shortly. All of you have access to their full bios and research on Padlet, so I'm just going to introduce them only with one line. We have Dr. Abiola Adeni, who is Assistant Professor of Health and Human Services at Farley Dickinson University, Vancouver. Exactly, that was about to say. Dr. Elham Khadib, Professor of Dental Public Health and Dean of Scientific Research at Alquist University. Hi. Dr. Khadib. Dr. Martha Mudis, who is president of the American Association of Hospital Dentists, is here with us today. Dr. Mudis, just tell everyone, who are you? And Dr. Ramprasad Vastare, who is professor and head of the Department of Public Health Dentistry at Manipal College of Dental Sciences.
Hi.
We have a wonderful panel, very diverse. This is how the session is going to go. Each presenter, in some cases I found out there are multiple presenters for the same presentation, will have 2 minutes for the presentation. They will present in alphabetical order. For those who are two, I took whoever was on the page in terms of the last name. So they have 2 minutes for the presentation. They have to introduce themselves, part of that. But they also have a 30-second, time allowance. Just for you to know, I was instructed to be very, very mindful about that time, which means after 2 minutes, I'm going to show you a page when time is over, and at 2 minutes 30, the phone is going to ring. So after that, we're going to have a panel feedback. I know that Dr. Mehta said 2 minutes, but in the interest of time and interest of this session is all about giving back to early career professionals. We calculated about maximum 5 minutes from the panel to make sure that we have everyone on the panel has the opportunity to give feedback. Each presenter has a first responder. Once the first responder provides their feedback, the other panelists may provide their feedback if they want to do so. Panelists are not off the hook. At 5 minutes, the phone is going to ring, and that's it. We're moving to the next one. So I'm not sure if we're going to have any time left at the end. Initially, we planning, but I hope it's going to be an enjoyable exercise. This is about fun. This is about learning. And this is about the next generation of dental public health professionals. So with no time ado, I want to have here the first presenter. There is a group, so whoever knows this first one, please join.
Can everyone hear me in the back?
Yeah.
Yeah.
Okay, get going.
Hi, everyone. We're Alexa, Catherine, and Aoife. Together, we have expertise in environmental health, medicine, and social entrepreneurship. And we're excited to be pitching the innovation that we've been developing. Dragons, are we ready to get started? So 3.5 billion people are affected by oral diseases worldwide, and the burden isn't decreasing. One major reason, preventive care is lacking, especially in low and middle income countries. Brushing has long been the foundation for preventive care. But let me ask you, what if the key to improve global oral health wasn't just about brushing, but about rethinking the toothbrush itself? Traditional plastic and nylon toothbrushes wear out quickly. They harbor bacteria, and they're inaccessible to many people who cannot afford to replace them every 3 to 4 months. Not to mention, 1 billion toothbrushes end up in landfills in the United States each year. If we know that traditional toothbrushes are failing to address global oral health challenges and they're harmful for the environment, why has this tool not developed? Well, now it can. We present to you the Alka brush. The Alka brush is a long-lasting toothbrush made from 100% medical-grade silicone.
We chose to create a product out of silicone because it has antimicrobial and durable characteristics. But until now, silicone's application to oral health has been limited to children and pets. Through conducting a scoping review, our team found that silicone toothbrushes are just as effective at removing plaque. They also last longer, are gentler on the gums, and are more hygienic. While everyone can benefit from the Alka brush, think of the older adult with receding gums and poor dexterity. The Alka brush has a more flexible design and softer bristles. Think of an unhoused individual with no sanitary place to store their toothbrush. The Alka brush can be easily sterilized when needed. Think of a consumer who wants to reduce their environmental footprint. The Alka brush has a longer life cycle and reduces waste. Our next step is to develop a prototype. Informed by evidence and through collaboration with stakeholders, the Alka brush has the potential to redefine preventive oral care. So, for the benefit of both people and the planet, are you ready to rethink the toothbrush? Yes. Thank you.
Okay. This is great. They even had a couple of seconds to spare. I was about dreading that I have to get that stuff going. So, Dr. Denny, I think you are the first one. So let's give some good feedback here.
Thank you very much. All right, then. So thank you very much to the three of you. I think you did fantastic. Great idea. You shared it clearly. I love that you ended with a question. A couple of things that I just want you to think about as you take this forward. First of all, who will be the biggest beneficiaries of this tool? I heard you say it would last longer. How much longer? Yeah. And I think one big piece I'd like you to think about is affordability. Finally, I just wanted to say that this idea really matches with the global health, and I would, if I had to think about it, I would position it within the SDGs somewhere, or One Health. And just ideas that you think about. Well, welcome.
Thank you. Thank you. I think those cover like some of the major points that we really want to be covering within our thing. I don't know if are we supposed to respond or?
But it's gonna take up your time for feedback.
Oh, well then, I think those are great comments. Carry on.
Nice presentation. I really appreciate the effort. Two points. What is the cost per brush that you're anticipating? What do you foresee? The cost per toothbrush. For how long can the patient use it? Those are two very important things. So any thoughts on that?
Yeah, so this is kind of like the one big thing is, so we just conducted a scoping review and we only identified 10 papers that talk about silicone toothbrushes. So what's really concerning is the fact that these are something that's out on the market for children and for pets. And I'm sure many of you who have small children have seen this device in your household. So within that literature, we've only identified one paper that talks about the life cycle assessment. And it says that and this is all kind of based on a kind of conceptual kind of understandings. So it's difficult to say. All they can say is that it lasts longer. But we know that the key to making this a success is in its durability and also in its ability to effectively remove plaque. So when we're developing this product, those are going to be the things that we're really concentrating on. And I think also one of the big points, which I think has been really emphasized throughout many of the speakers today, is that collaboration with users to making sure that this is something that meets the needs and values of users through iterative prototyping and that collaboration. So unfortunately, we do not have the answer to the question there in terms of cost. We've done some early modeling in terms of what the cost would be based on how much it costs medical grade silicone costs per kilogram. We're expecting it to be $5 to $7 a unit delivered in bulk. If it's an individual product, so that would be $25. But I'm the social entrepreneurship nerd. And the big thing that we kind of envision for this is selling this in high income markets to decrease the cost. So when we're selling this to or supplying this to aid agencies in different contexts, that we can make sure that this is available for the population that I think needs to have a hygienic and long lasting tool the most.
Is this cost in consent with an industry and collaboration, with an industry collaboration, or is it on your own calculation?
So this is just on our own kind of calculation, because this is, once again, the literature on this is so limited, but our next step is actually to do a cost analysis on what's going on following our scoping review, because we understand that this is the number one next thing that we really need to address.
Thank you. Thank you for the presentation, it's so great. My point is more a recommendation. When you are speaking about environment and sustainability, try to contrast about the possibility to show your silicone-based product with biodegradable plastic. So in a way that the people understand why your focus is better than the trending topic about biodegradable plastic. That's it.
Thank you.
Thank you. 42 seconds. Let's go.
It's very fantastic. I just, because my colleagues. And maybe next time we present this, maybe you can start with it as scoping, review that your methodology, and then go to your recommendations. And framing this within the CPG will be perfect, but you did very well. Thank you.
Please give me that round of applause.
Good afternoon. My name is Tanzua Mukandawire, and I just recently completed my BDS, and I'll be graduating next month from the Hopkins University. So I'll be presenting about the knowledge, attitude, and practices towards periodontal disease amongst pregnant women attending antenatal clinic at Sindola Teaching Hospital. To begin with, meet Tavo. Tavo had always dreamed of becoming a mother. And when she found out she was pregnant, she did everything right. She took all her prescribed vitamins. She went for every antenatal checkup, and she followed all the advice that was given to her. However, 7 months later, Tavo went into early labor and gave birth to a beautiful premature baby girl. Unfortunately, her joy was short-lived as her baby did not survive. Not long after this, she discovered that something that she had been ignoring, bleeding gums, may have put her baby in harm's way. However, no one told her about this. So the aim of the research was to assess the knowledge, attitudes, and practices of 75 pregnant women. And of interest, it was discovered that about 61% either strongly disagreed and both disagreed and strongly disagreed that they did not know that swelling of gums could occur during pregnancy. Another interesting finding was that out of all the 75, about 81% had never been to the dental clinic for a checkup. Why is this relevant? Why is this a problem? Firstly, due to the lack of knowledge that was demonstrated among these pregnant women, there's likelihood of them not being able to prevent due to their not being able to know about periodontal diseases. Apart from this, due to the fact that many of them did not go for dental checkups, there is a possibility of undetected diseases.
Time is up. Thank you so much. I think it's time for folks to take some questions now. I think it's Dr. Khatib is the first one.
Yes.
So, Dr. Khatib.
Yes, thank you very much for this important topic that we've been talking all the morning and the afternoon about it. So you presented a very nice story, then you come up with your research and your results. So, and you have very interesting results. So what you are planning based on those results to do, what's the next step for you to do with advocacy or intervention, or how you want to help your community based on the results that you got from this research?
Sorry, can you repeat the question?
Okay, so after you did this survey, which is very important, okay, you collect this data from pregnant women and see how their knowledge, attitude about oral health, or their access to dental. What are you planning, if there is any plan or to do with this data next to try to help your community?
Thank you for that question. To begin with, I would like to have a project where there's incorporation of oral health education in reproductive clinics, so that firstly, the pregnant women are aware of these possible adverse pregnancy outcomes. And then apart from that, I would also engage the gynecologists and the people who will see them to be able to refer if there are any pregnant women that have oral challenges so that they can get further treatment. Yes, right.
Very good.
Are you planning to monitor the birth weight of infants prospectively, in the sense that's also an indicator? With low birth weight and periodontal disease, there's a direct relationship. So if you're planning to monitor, have you thought about any thoughts on that? Have you gone through literature and have you envisioned that?
Yes, actually, I also plan to first screen so that the ones who are found with periodontal disease are able to monitor the babies and the health and everything else.
What is the outpatient in your department? What are the numbers? How many patients are seen regularly in your department? What is your per month or per day? Do you know the statistics? How many patients visit your dental outpatient department?
Yes, about 200 per week.
200 per week. Okay, how many are having periodontal diseases?
Unfortunately, I haven't been able to screen, so I'm able to answer about how many have periodontal disease.
Thank you.
Thank you.
Thank you for that lovely presentation. I want to commend your boldness. Yeah, and your courage to come and speak at this event. As it is here today, that is great what you've done. I want to speak to the fact that it might look like it's a small thing, but that was exactly where a lot of us started. So kudos to you. I agree with everything that has been said to you so far, but I think this study can be taken forward in many directions, and I look forward to seeing where you take it next.
Thank you.
Thank you. It's a great study case. And I'm just making a recommendation. You have a great opportunity to publish it. So include the comparison between the national data and your study in a way that the people can understand the outcomes and the things in your story. That's it. Congratulations.
Thank you.
Hello, my name is Lakshmi Murthy. I'm an MPH student here at Hopkins and a pediatric and preventive dentist. Today, I'm presenting Bridging the Oral Healthcare Gap for Children with Autism. Before I start, this idea stems from my own research, which I did as a pediatric and preventive dentist, and also right now my policy education that I'm getting at Hopkins. So imagine standing at the edge of a canyon. On one side, parents know that oral hygiene is critical. On the other, dental professionals provide expert advice. But in between, children with autism face sensory issues, which makes even a simple task, such as brushing their teeth, overwhelming for them. Our study found that significantly more number of children with autism gag while brushing as compared to children without autism. We also found that parents of children with autism followed the 2 times brushing routine more rigorously, but yet they had poor oral hygiene. A major reason for this was the sensory sensitivities in these children made the brushing ineffective. This shows that they don't just need guidance, they need a bridge. That bridge could be occupational therapists. These professionals often already work with children to help them manage their sensory problems. And with the right training, they could also provide personalized strategies for toothbrushing. As a preventive dentist, policy student, and an oral health advocate, I believe that the key to success is collaboration. We not only need to modify dental environments, but also need to make oral care at home more accessible for these children. Integrating preventive oral care into occupational therapy could offer practical solutions for managing sensory issues, making the experience of brushing more tolerable and effective. This just isn't about brushing. It's about building a pathway where oral care is no longer a challenge. By working together as a team, we can create an integrated model of care. So let's build that bridge because every child deserves a healthy smile. Thank you.
Thank you. The topic is very interesting. Are you planning to make a guideline to work with other interprofessional teams and to provide step by step about how to work with oral care profession?
Sorry, could you repeat the question? I lost you in the.
Are you planning to create or develop a guideline to work with interprofessional professionals in this topic with the oral care professionals?
Yes, I think it has to be like an integrated care model. This is an idea I'm proposing because I personally had an experience of working with occupational therapists, and I also realized that even though they were helping them manage sensory challenges, they weren't aware of the dental problems at all. So the idea would be to integrate like some sort of basic preventive oral therapy into occupational therapy training. So occupational therapists getting out of school should have some basic ideas, is what I'm thinking.
Thank you very much for caring or researching this important topic. Did you review the literature to see what solutions or what others did? Were there any application for technology to help also in this specific population?
Yes, so visual pedagogy is a very popular technique that is recommended even for toothbrushing. And in fact, I would say that Dr. Stein, who is one of my references, and Sir Mac, they have done a lot of research. They are occupational therapists who have done a lot of research of integrating occupational therapy and dental care, but most of it has been in the dental environment, like dental clinic environment. So what I'm trying to say is, of course, that's important and that's a really big challenge. But if I have to focus on prevention, then, it has to start at home. So that's something. And with respect to technology, there are like various apps that are making their life easier for sure.
Yeah, because you see them first, as you said, like, yeah.
Right. And it's just that this would be more personalized is what I'm saying. Even recommending an app, like if you go to the app store, I actually did try to see that are there other methods, and there are quite a few, but to decide which one's the best, if it comes from an expert, it would be better.
Thank you.
Thank you.
Thank you for your work to share with us. I agree with my colleagues. It's a very important and interesting topic. I will just make a few comments for you to think about as you take this work forward. How do you envision this as a research idea, growing, right? I would think about testing the ideas, feasibility and reporting on it, right? And seeing how much impact it really makes. How do you envision this integration happening? That's another area where you might want to sort of go do some testing to see if this really works.
Right.
Good idea.
Thank you.
Thank you, Dr. Lakshmi. It's an interesting topic. Have you observed any gradation in the spectrum of autism?
Yes.
The patients?
Yes, it is a spectrum. I had not recorded that, but yes, it's very variable.
And any challenges seen in the detection of autism? Did you go into that detail? Because borderline or not autistic, that is again an area where
Yes.
a lot of sensitive handling.
During my research, I worked with Sion Hospital, which is a big hospital in Mumbai, which had a learning disability center. And one of my study inclusion criteria was that they should be diagnosed with ASD. So I came across cases where they would term it as behavioral issues, but not autism. Yeah, so it wasn't recorded for my research, but yes, I did do, like, the way I had done my research was oral health checkup camp and then talking to them more.
Yeah, because there can be ambiguity in inclusion criteria or exclusion criteria.
Yeah.
Who's to be included and who's to be excluded.
Right.
So that is something which is a very sensitive decision, but you can have a significant percentage of the population being getting affected because of that.
Yes.
All the best wishes.
Thank you.
Hello, everyone. My name is Marina. I have an honors degree, a bachelor's degree in science, and I'm currently completing my master's degree in global health at McMaster University in Canada. Today, I will be presenting a call to action to all oral health professionals to reduce emissions by rethinking anesthetic gases. Some of you may be wondering why oral health professionals should care, hopefully less with today's presentations. The climate crisis continues to have devastating effects on health around the world, including rising spread of infectious disease, respiratory issues from air quality, significantly issues with food security, which of course is a factor of periodontal disease. Why focus on emissions? Greenhouse gases are a major focus of sustainability due to their role in global warming and the associated health consequences. Some of you will know better than me the role of anesthetic gases in oral health, honestly, much more than me. I'm going to make another assumption that many of you have used or are using desflurane or nitrous oxide. Well, what you may not know is that not all anesthetic gases are equal in terms of emission. This is a time for action for you all to take steps away from using desflurane and instead use sevoflurane. When you convert these greenhouse gases into a standard of carbon dioxide, the global warming potential over 100 years for sevoflurane is 130 compared to desflurane, which has the highest impact of 2,540. For a clearer comparison, because I know numbers just fly through my head, this, for example, is the impact of, and I figured sugar may be what emissions are to me, to you. So we have, if I can pull this up. So let's say this is the impact of sevoflurane. This would be the impact of desflurane. It's 50 times greater. Rethinking current practices regarding anesthetic gases is clear, and you will not be alone in this. Practitioners and hospitals have already transitioned to lower emission anesthetics. To end, anesthetic sustainability is a responsibility to health, to patient and future patients, or really preventing future patients, making this an important call to action for all oral health professionals. Start where you are and leave no one behind. Thank you.
Thanks, Martin. Actually, it's a niche area. It's a very fine area. And what inspired you to focus on this area?
Sorry?
What was your inspiration? What motivated you to focus on this particular aspect?
You know, I actually happened to be in a planetary health class and a guest speaker who I believe is associated, or she actually started this process in her own hospital and is in collaboration with the Canadian Coalition for Green Healthcare. So they're starting this project all around Canada, specifically like Ontario's had some success in other hospitals, but they're really trying to reduce emissions. I believe one hospital actually, their total emissions reduced by 1% with just this type of change. So it's really significant results.
Do you have a pan country data in Canada regarding these gases? Do you have a pan country data? Do you have, you have data across the country, sub-provinces of Canada, you have sub-unit?
I'm not sure about per province or for the whole country, but I mean, desflurane and nitrous oxide are like the two of the most common used anesthetics. So I don't really have a breakdown for it. But we do have results about hospitals that have switched in the emission differences. But it's not like a national wide, not every hospital or practitioner has switched. And a gap I noticed was oral health professionals were not really included in those conversations at all. It was very much focused in hospitals, healthcare, that type of setting.
And is there a governmental support for this particular initiative?
I'm not exactly sure. I know a lot of the organizations are like NGOs or practitioner based, so I'm not sure how much the government is supporting in this transition. I think it is very much location specific making this change. So no, I don't know if there's a particular plan at play. It seems to be very localized.
All this.
Thank you.
Yes, thank you, Marina, for talking about this. This is very important and how you know, combine the environments with the practice of dentistry and what we call like a green dentistry or more sustainable dentistry. I think that maybe next time when you want to advocate for this, as my colleague said, to collect some data about the position of the professional organizations. Because there is, you know, for anesthesia, there's an organization for the dental practitioners or hospital practitioner, you know, associations to know what their stand or their position. If they favor, then you advocate with them. If they don't have a position, you need, you know, now to start to lobby and advocate for them to have this stand because you have like a strong argument here. So it will be very nice to work on that and advocate for that, working with those professionals at local, national, and also global. Thank you.
Thank you.
Thank you very much, Marina. This is, I agree, it's a very niche area. I would think of that as new, unique, something you might want to push forward. But I would want to just invite you to think about the so what question. So what happens? What would you like oral health professionals to do about anesthetic gases, right? And position, you can position that as your advocacy statement in this way. But well done, good work.
Thank you so much.
Thank you, Marina. As my colleagues say, that is a great topic. And if you want to start a call for action, that, as you say, I think you need to start conducting the organized dentistry at national and global level, share your results, and start asking, what do you think about that? How you want to be part of this call of action? It's great.
Thank you so much.
Just to add, actually, I think you can get in touch with the Canadian Oral and Maxillofacial Surgeons Association as well as the Canadian Pediatric Dental Association, because these two specialties are the ones which will be dominating the use of these gases. So you can, so you can get in touch with them as well as involve the Canadian Dental Association to see what their say is, and then take a call, because a position paper may be needed, and then you can take a call. So I think you have to do it incrementally. But you have to go step by step, but it may have potential because Canada is very high on health promotion, and I'm sure there is some particular background issue which we may not be in the know of. So we may not be aware of it, but there may be something very important coming out of it. So there may be tremendous potential, but it depends on how you check it out. All the best.
Thank you.
So, how was it? You see, everybody stayed on time. Everything was great. Thank you for your feedback. Unfortunately, in the interest of time, the two other presentations that we have recorded, please check them online. I think they're going to be available on the Padlet. I do want to recognize our other panelists that's also available virtual, Dr. Faik Quadri, who is Director of Research and Assistant Professor of Dental Public Health at Woody Hunt School of Dental Medicine at Texas Tech University Health Sciences Center. So Dr. Quadri provided already feedback to those presenters who recorded their presentation. Really appreciate all of you to stay for this session, stay for the entire event. I can tell you for myself that I kept thinking towards the end, like, is there a favorite presentation or a session I had that I couldn't really pick one because they were so different. They were kind of complementary and everything was bringing something to the table. And I really like that. I can tell as someone who does events, it's very hard to do that in a day to bring this kind of variety. I also want to congratulate Dr. Mehta's guts to actually organize not the entire event, but especially this session. 2 minutes. 2 minutes for our presenters. Even I would have said 5, but he said no, 2. Okay, I'm not gonna fight you on that. So I hope you have a great day tomorrow. Unfortunately, I'm not gonna be able to be with you today, but please enjoy Baltimore. If you haven't been to the dental Museum of Dentistry, I really encourage you, if you have time, to go to Museum of Dentistry. It's wonderful. And don't forget that Baltimore is home to the oldest dental school in the world. So this is where dental education, oral health education, formal, started in a modern form. In 1840, the Baltimore College of Dentistry was created here, which later on became the UMD Dental School. So while Johns Hopkins does not have a dental school, there is a very old tradition of dental education here in town. Thank you all for this, and I'll let Dr. Mehta to conclude the day for today.
Thank you, Dr. Estrade. Thank you to our dragons, as mentioned, and thank you to our mini dragons, our early career dragons. You have a lovely career coming down the pipes. As mentioned, we'll put all of the recordings and we'll get Dr. Kadri's feedback for you as well. And that concludes today. Make sure for those of you here in the room, bring your little ID badge just to kind of get back into the building. Don't throw it out. And we'll see you here. We're going to start on time at 8:45.